like this. Is it better now? Please see. I'm ready. Yes. Okay. I think we are good to go. A very good evening to everyone who's listening to this session. First of all, please let me know if I am audible and visible to all of you. The screen is audible, my face is visible, and my audio is audible or not. Please let me know, and then we can start. Just waiting for yes, no, everything. Okay, great, great, great. First of all, apologies, we are starting half an hour late. India, we have some technical issues always. I had come already and I was chatting with all of you. But because we are starting a bit late, don't worry. We can continue maybe 15-20 minutes late also. And tomorrow also we have entire day available to us. If needed, I will take another hour also if the need be. So you need not worry about the time. Let us start. Let us discuss about medicine. There are a few things before I start. So I will answer your queries commonly. Many of our friends will be joining, late. So they will be asking the same questions again and again. So the only help you can do is maybe, just cut, copy, post my answer and send it to them if they are asking again and again. But apart from that, many of us know each other. Many of us are meeting for the first time. I am Dr. Sandeep Sharma. I am both pediatric as well as medicine faculty. I take classes since last more than 10 years. I have been training students right from FMGE and NEET PG to all the way to super specialty. I have my super specialty programs running, residency courses running, and I try to simplify things the best I can. Here we are going to talk about medicine. Before you people ask me, sir, would this medicine be enough? My answer, ask yourself, if only 5 hours or 6 hours or 10 hours were enough, why would people do 300 page, 400 page, 500 page workbook or spend 80, 90, 100 hours of medicine and still not end up with something? So, yes, ideally, this is not going to be enough. But practically speaking, I have a few questions to ask. Do you have the time to read 400 or 500 pages? You know the answer. No. Do you have the time to give undue attention only to one subject when you have other 18 subjects also pending? The answer is no. And that is where this revision program comes in. I will try to teach the concepts only where they are bare minimum needed. But apart from that, I will be sticking to what you need to know. Let me tell you, medicine is like an ocean. ये एक समंदर की तरह है. Even if you take out one bucket out of it, or if you put one bucket into it, nothing is going to change. But what we are trying to do is, in these two sessions, we will touch upon every system. Yes, you heard it right, every system. How are we going to do? Part one, that is today, I will be touching upon five systems: pulmonology, GIT, hepatology, rheumatology, and nephrology. This will cover about 40 to 45% of the medicine today. Part 2, same time, 5 o'clock, we will be starting tomorrow. I will be covering CVS, neurology, endocrinology, hematology. Hematology will include miscellaneous as well as some one-liners on CML, CLL, AML, ALL as well. Okay, and tumor lysis syndrome, on which a recent question was asked in FMG exam. The time we have is roughly about 11 hours. 11 hours, there is a theory called as theory of time dilation. Time dilation means if you are focused enough, the time dilates and you can accommodate a lot of points in that limited time which is available. At the same time, because we have a lot of ground to cover, a lot of MCQs to do, a lot of things to discuss, I will not be looking at the chat box too much, because what it will do is I don't have anything in front of me that will break the flow, that will compromise the points I'm trying to discuss. In between, I will be taking a look at the chat box between the topics, and then I will be answering your queries accordingly. Right? So, regarding pediatric lectures, my lectures cannot be discussed anywhere apart from doc tutorials. It's a legal copyright thing with them. So, one pediatric rapid revision has already been done day before yesterday. You can go through it. My older videos are already available, 1.5 year old video on Dr. Bhanu Prakash YouTube channel. You can go through that as well. And of course, I keep coming on the Dr. Tutorials channel, so you can meet me there as well. That is about pediatrics. Let us not waste any time. And are there changes in what I have taught in my classes? I am also taking pediatrics as well as medicine offline classes all over the country. So whatever I'm discussing here, there is a difference is that Harrison 22nd edition has come in. So a few guidelines and updates have changed. And so I will be incorporating all those updates in my class itself. So if you have any query, you can reach out to me later. But let us begin the class. The references I'm using: Harrison, Robbins. Why Robbins? Because I'm trying to integrate uh, medicine with pathology and medicine with pharmacology wherever it is needed. This is about my background. If you have too much of Vela time, you can go through it. Otherwise, you can ignore this particular part. And disclaimer is again a legal thing to add. For those who want to reach out to me, this video later on will be available as a collab on my YouTube channel as well. So this is my YouTube channel where I keep posting. I have posted other medicine videos in slight more details, but they are older videos. Instagram, you can follow me. You can scan me. I use a bit of filter, but not too much filter that my face is unrecognizable. It is just filter for lighting. So you can recognize me. You can scan and follow me if you're not already doing. Any query related to medicine or even pediatrics, most welcome to send me a DM. Telegram, I have a Telegram group, FMG Avengers. Uh, I keep it very limited. I keep it very, you are allowed to post, but any spam, I remove it. So if you are academically oriented, you can always join. And all the updates I will be posting in the coming days on my Telegram group as well. These all scanners are there in the workbook also given to you. I am there on Twitter, but I'm not very active on Twitter because I personally feel it's a very, not, it takes up too much of mental space. But finally, WhatsApp, there is a WhatsApp group as well where only pediatric questions are put up, not the medicine part. Let us start with the first thing that we are going to take up. That is, we are going to start with pulmonology. Before we start with the discussion, what we are going to do, uh, if you look at the papers of medicine, see, it is very important to understand the enemy before fighting the enemy. And the enemy, the examiners have evolved. If you look at the older MCQs, if you go through the old MCQs of FMG, 2018, 2019, 2020, you will find, and older than that, you will find a lot of one-liners were asked. Lot of exception-based questions were asked. Lot of, tables were asked. Now what examiner is doing is, even if they are asking a simple thing, they are making it into a case. Instead of asking what is the investigation of choice for pulmonary embolism, They are making a case scenario to see whether you can identify pulmonary embolism by the case or not, and then they are asking the investigation. When you will actually sit in the exam in medicine, core medicine will be roughly about 15 to 20 question. Don't be surprised. Core medicine will be 15 to 20. Why this number is so less? Because another 15 to 20 questions are integrated. Integrated means there is a component of pharmacology, there is a component of pathology, or it is a concept related to surgery. For example, esophageal disorders and GI. A lot of integration occurs across with surgery. If you have done only surgery and not medicine, you cannot solve those questions. If you have done only medicine and surgery, you have not done, you cannot solve. You need to have a recognition of both. So what I will try to do is, in the topics that we discuss, integration I will do. What we don't have is too much of time. So a few definitions, a few tables, you have to mug it up. I will tell you clearly, honestly, this is something you need to mug up. So you are supposed to mug up. What we need to discuss, what we need to write, we will write. And whatever important topic I discuss, I will tell you what all different ways it has been asked and what all different ways it can be asked as well. So this workbook, the content that we are discussing will be double of what is given in the workbook. What it means is whatever I'm telling and speaking, that is also a content. It is just that you need to absorb it and write the technical points in your workbook. So, what about annotated PDF? Yes, annotated PDF will be shared with the team, and team will be forwarding it in the groups. If you can't find it sooner, so you're most welcome to reach out to me. What about other faculty members? Some other sessions also planned, or faculty members will try their best to take, but all sessions are standalone. Standalone means I will try to cover all the 9 systems of medicine the best possible I can in the limited time that we have available. You have to understand. Now, last thing before I start, sir, I have not done medicine. Would this be enough? My answer is this will give you a fighting chance. You are leaving topics discussed here and doing something else, playing with fire. You do this, it's your day, and you are an inherently hardworking, smart student. You have a good chance in the exam. But end of the day, it is not one subject. It is how you are in all the 19 subject that matter, right? Let us start with pulmonology. So pulmonology, first of all, there are a few basics. Now, there are some definitions you will find. These definitions, I will tell you first of all what is the meaning. Simple language. The exam will be in English, so I'll be teaching in English. A few Hindi words I may use intermittently, but they will only be to exemplify or to explain a particular point. So it will not be an academic thing, and you will not be missing out if you're not good in Hindi. But I will be teaching in English only, so you can be rest assured on that, right? So what is tidal volume? Tidal volume means whatever normal air is moving during inspiration and expiration. When you are breathing normally, not making an effort, yeah, you're solving an MCQ, you're thinking about something, watching a movie, eating food, or just sitting idle in your library. The volume which moves inside outside, that is tidal volume. This topic which I'm discussing, it has hugely integrated with physiology. You may find questions in part paper B, you may find questions in paper A. So tidal volume is normal air moving inside and outside. I would advise keep looking at this table also. Why this table is important? Because what examiners will do, they have not asked this question in FMG, but I will be discussing the relevant NEET PG related points also, uh, because you know that NEET PG type questions are being asked in FMG also. So look at this paper, look at this chart. What the examiner will do is they will put this entire table, but they will not write tidal volume, inspiratory reserve volume. They will write A, B, C, D, E, F, and then they will ask you which of the following curve represents tidal volume. So what is tidal volume? Look at this. Volume moving normal inside and outside, something like this. This is called as tidal volume. So whenever you have a graph like this, the total volume moving, amount of volume is something that you have done in physiology. So I will not go into the hardcore physiology part. Normal volume moving, that is tidal volume. What is inspiratory reserve volume? Inspiratory reserve volume means what maximum volume of gas can be inspired after the normal tidal expiration. So after normal tidal inspiration. So normal breathing you have done, that is normal. Then what extra you can take in? That is called as inspiratory reserve volume. So where the tidal volume peak is there of inspiration, anything up to maximum inspiration will be the inspiratory reserve volume. What is expiratory reserve volume? Come to the lower part. Expiratory reserve volume will be after a normal expiration, resting expiration, what maximum gas can move out of your lung. This particular part will be the expiratory reserve volume. So this is inspiratory reserve volume. This is expiratory reserve volume. But you need to understand that our airway cannot be fully empty of air. There will always be some air which is left behind, and that is called as residual volume. Right? So what is the residual volume? It is the air which is left in the airway despite the maximum expiratory effort. That is called as residual volume. What about vital capacity? When you have ERV plus IC, what is IC? IC is inspiratory capacity. So this particular part is called as inspiratory capacity. With IRV plus tidal volume, that is called as inspiratory capacity. If you combine along with expiratory reserve volume, this particular part is called as vital capacity. Vital capacity means total air between maximum inspiration and maximum expiration. That is called as vital capacity. And what is total lung capacity? The maximum amount of air possible, which includes the residual volume as well, which is about 5.8 to 6 liter, that is total lung capacity. These definitions you have done before. These definitions will come again and again. That is why I'm discussing them at the beginning itself. So these are some of the basics. What this flowchart is telling you is why this flowchart is important. This flowchart has been asked. I'm putting a small Q in older NEET PG exam. They will label it A, B, C, D and ask you identify incorrect match. A is inspiratory reserve volume, B is tidal volume, C is residual volume, and so on. So this is the next generation level of question which can be asked. You may ask me, sir, will it be asked in FMG? I don't know. I'm not an astrologer. I'm a medical educator. I'm a teacher. I'm a doctor. So I will stay in my domain. This has been asked in one of the other exam. So there is no harm in reading this chart like that, right? If you have seen something and somebody has told you that this thing can be asked this way as well, you will not panic in the exam. Many times panicking creates silly mistakes. So this is the first thing that you need to remember. Second thing, these definitions we have already explained to you, so you are supposed to go through them. I've just said the definitions only without, marking on the table. Let us start with the first few things. Two things examiner is interested in knowing: whether you know FEV1 and FVC or not. What is FEV1? So, volume of air which a person can exhale forcefully in the first second. Suppose after a normal tidal volume is over, the maximum air I can forcefully exhale out in the first second, that is called as FEV1. And what is the total volume of air which can be expelled after minimal inspiration? That is functional FVC, functional vital capacity. Why are these FEV1 and FVC important? They are the two parameters which are used to distinguish between obstructive lung diseases and restrictive lung diseases. So remember, any patient comes to you, the patient is having chronic respiratory problem. You feel it is not infection, it is not pneumonia. It could be asthma, it could be COPD, it could be some obstruction, it could be ILD. So what you will do? You will get a spirometry done and check for FEV1 and FVC. What is the importance? First MCQ. Whenever you calculate FEV1 and FVC, you take out the ratio. FEV1 by FVC ratio, if it is less than 0.7, what does it indicate? It indicates obstructive lung disease. It indicates obstructive lung disease. It indicates obstructive lung disease. Just a minute. I think there is some problem. Let me know if I'm audible or visible. Let me know if I'm audible or visible or not. Please confirm. अजीज, मुझे पता है आप कब से कह रहे हो कि फ्रीज हो गया है, लेकिन यू नीड टू अंडरस्टैंड आई कैन आइदर टीच और आई कैन लुक एट द स्क्रीन. Right? I am talking about concepts. I don't have a screen written in front of me. And it is not at my end, it is at the Hyderabad team's end. So I would come to know only there is a lag of 1 minute when I speak and when it reaches to you. So have some patience. The most important thing we need to have as doctors is patience. Tomorrow you will be handling a patient, young patient, kid, he's crying. What would you say? Jaldi karo. Rona band karo. The child will not listen to you. And don't even try that. So you have to develop some patience. Right? Okay. So what I was discussing was that this particular thing, I will start from where I think the screen got stuck. What I was telling you was that this particular table is important because NEET PG exam, older NEET PG exam, they put up this table and they said A, B, C, D, they mentioned it and they said identify the incorrect match of volume and the shown graph. So you had to pick up that tidal volume looks something like this. Above this, you have the inspiratory reserve volume. Below that, you have the expiratory reserve volume. This one, which cannot be breathed in or out, that is residual volume. If you combine all of them together, that is vital capacity. And if you include residual volume also, that is called as total lung capacity. One is definition. Second is how to identify in the table. You have to be mentally prepared. That is the first thing. Now, second thing is about FEV1 and FVC. FEV1 and FVC are the two values. Definition examiner will not ask. These are the two values which are asked in the exam. What is their importance? Because a patient comes to you. Suppose patient has a respiratory problem. You rule out infection. There is no infection in the patient. So what could be the respiratory problem? Patient could have asthma, COPD. Patient could have interstitial lung disease. Patient could have any respiratory problem, bronchiectasis or something. You do a spirometry. When you do spirometry, two values are obtained. One is FEV1 and second is FVC. FEV1 is volume of air which a person can exhale forcefully in the first second. So there is a machine known as spirometer which measures that. What is FVC? It is the total volume of air which can be exhaled after maximal inspiration. What is the importance? Importance has been asked in the exam. Any patient comes to you with respiratory disorder, infection is not there. Take the ratio of FEV1 divided by FVC. When you find that FEV1 by FVC ratio is less than 0.7, it indicates patient is having obstructive lung disease. The patient is having obstructive lung disease. There is an obstruction in the airway. And whenever the patient has FEV1 by FVC ratio equal to or more than 0.7, what does it indicate? It indicates the patient is having a restrictive lung disease. Even in a normal patient, you will find FEV1 by FVC above zero point 0.7, right? So, but if a disease is being thought of, less than 0.7. Earlier, it used to be zero point 0.8. It was revised a few years back. So now the cutoff used is zero point 0.7. So less than zero point 0.7 obstructive, equal to or more than zero point 0.7 restrictive. Then you can get, examiner can ask you, what are the techniques you take to measure FEV1 and FVC? To measure FEV1 and FVC, we need the help of spirometry. But there is a problem. Spirometry cannot measure that gas which cannot be coming inside and outside. In other words, residual volume and total lung capacity cannot be measured like this. For that, we have another investigation known as whole body plethysmography, also simply known as plethysmography. Plethysmography has many subtypes, many techniques. Mainly, it uses helium dilution technique, but those details will never be asked in your FMG exam. If it gets asked, it could be a physiology question, but certainly not a medicine question. So, what are the name of the two techniques to measure that? Spirometry. But spirometry can measure everything except two things, the residual volume and TLC. For TLC and a residual volume, what do you need? You need body plethysmography. Okay. Moving further, We have this flow chart. Any patient comes to you, he has FeV1 by FVC ratio less than 0.7, that is less than 70%. You will suspect the patient is having a obstructive lung disease. Now, there are, broadly speaking, two types of obstructive lung diseases. One is reversible obstructive lung disease, and second is non-reversible obstructive lung disease. Any obstructive lung disease, if you are suspecting, you give a trial of salbutamol. What is salbutamol? I'm writing in short. It is a short-acting beta agonist. We also call it as SABA. You give a trial of salbutamol in the patient. There will be two possibilities. The obstructive lung disease, the ratio improves. The ratio improves in the patient. If the ratio becomes better, that was a reversible disease. What does it indicate? The likely diagnosis in the patient. What is the answer? Yes, bronchial asthma. Bronchial asthma. However, if there is no improvement in the patient, if there is no improvement in the patient, you will suspect other diseases. It is a common mistake. We think that only COPD should be thought of. What is COPD? Chronic obstructive pulmonary disease. Other obstructive diseases like bronchiolitis will also have presentation like this, and bronchiectasis will also have presentation like this. So this will tell you that the underlying disease is not asthma, it is COPD, bronchiolitis, or bronchiectasis. It will be helpful in ruling out the options in the MCQ. If the patient is having a normal to high uh, FeV1 by FVC ratio, if it is equal to or more than 0.7, now it could be normal patient also, it could be restrictive lung disease also. In these patients, you will check for the absolute FVC value. FVC absolute value. If you find that FVC absolute value you need not remember, value varies according to age, gender, and underlying condition of the patient. So check FVC for that age and that gender. If you find that the FVC value is normal, only the FeV1 by FVC ratio is more than 0.7, you would say patient is having no respiratory disease. No respiratory disease. It is a normal patient. But if you find that FVC is low, in these patients, you will suspect the patient is having what lung disease? Restrictive lung disease. So patient is having a restrictive lung disease. When you solve MCQs, simple MCQs as well as complicated MCQs, you can easily solve by keeping these topics in your mind. Right? So no improvement, COPD, bronchiolitis, bronchiectasis with salbutamol, improvement, bronchial asthma. If it is high, more than 0.7, check for absolute value of FVC and decide whether it is a normal patient or there is restrictive lung disease in the patient. Now, let us do a table distinguishing between obstructive lung disease and restrictive lung disease, and we will be taking their examples also. What is the problem in obstructive lung disease? The problem in obstructive lung disease is air trapping. Air is getting trapped. In bracket, you would write it is a flow problem. It is a flow problem. Flow cannot occur. Whereas restrictive lung disease, there is a expansion problem. There is a reduced expansion is the issue. Reduced expansion is the issue. In bracket, I'm writing these patients have a volume problem. Volume problem. Now try to think what will happen in the patient. In an obstructive lung disease, there is a obstruction, and it is not a complete obstruction, it is a partial obstruction. Now, in between, although it is a rapid revision, but wherever needed, I will try to simplify concepts for you so that whenever you try to mug up also, it is also easy for you to do that. Because end of the day, we are going to become doctors, and I will use mnemonics, yes, but because it is medicine, so you can't have too much of mnemonics as much as in other subjects. So understand, obstructive lung disease means there is a partial obstruction in the airway. Okay, so what happens is inspiration can occur more easily, but during expiration, the airway tends to collapse around the obstruction. So what happens is with each breath, there is a trapping of air which is happening. So there is a expiratory flow problem That is obstructive lung disease. What is restrictive? The lung cannot expand due to fibrosis or due to fibromuscular condition. And so the total capacity of the lung is reduced. That is called as restrictive lung disease. What are the examples? The examples of obstructive lung disease include COPD. For example, a particular COPD known as emphysema. It includes bronchial asthma, or simply I am writing as asthma. It includes bronchiolitis. It is an infectious condition, and it includes bronchiectasis. What about restrictive lung disease? Restrictive lung disease can have two varieties. First of all, there can be parenchymal disease, which are affecting the parenchyma of the lung. Parenchymal lung disease, the typical example for this is IPF, idiopathic pulmonary fibrosis. It also includes asbestosis. Asbestosis. It also includes sarcoidosis. The second example for this, and the second example for this, intermittently, I'm having a look at your chat also. Second is extraparenchymal. Extraparenchymal. Outside the parenchyma. Extraparenchymal causes can be related due to chest wall. There can be due to chest wall causes. For example, kyphoscoliosis. Kyphoscoliosis. Or it can occur due to neuromuscular causes like MG. What is the full form of MG? I'm writing in short, myasthenia gravis. There is a huge list. List is there. You can always go through your detailed notes if you want. But we are discussing a summary of distinguishing between the two conditions. What about FEV1 by FVC ratio? I just told you it is less than 0.7 here. It is equal to or more than 0.7 here. What happens to fractional excretory flow between 25 to 75%? That becomes decreased because there is a flow problem, but it remains normal in restrictive lung disease. What about RV and TLC? Because air trapping is happening. So air trapping will cause TLC and RV to be high. Whereas restrictive lung disease, the lung cannot expand. So all types of volumes, including residual volume and TLC, will also be decreased. This particular point, dear friends, please highlight it. This particular point is your INI set MCQ 2021 November exam. You might be thinking, sir, INI set easy things are asked. Yes, FMG tough things are asked, and INI set easy things are asked. And if something is a INI set or NEET PG top MCQ already, the chances of it getting repeated is more. Ask your seniors, and those who have sit in the exam, they would know that questions do get asked. So RVTLC value has been asked once in the INI set. Don't worry, I'm not preparing you for INI set, but wherever the MCQ comes, we will be marking it. What happens to diffusion capacity of lung for carbon monoxide? It is a test that we do. DLCO means diffusion capacity of lung for carbon monoxide. It remains normal in a patient with asthma, but it becomes reduced in a patient with emphysema. If you go by the old papers of FMG, you will find another MCQ asked on this. The only obstructive lung disease where DLCO becomes reduced is emphysema. It is decreased in emphysema, whereas it is decreased in patients with restrictive lung disease. Can asthma have rise in can it have rise in DLCO? Some patients it can, but those are exceptions. Vast majority, it remains normal for that patient. The only exception is if the patient is presenting with status asthmaticus, it can be slightly increased. So that is an exception, and that is why we will not be writing increases in asthma. What is the advice you would give to the patient? What is the advice you will give to the patient? Now, in a patient of obstructive lung disease, we will say breathe slowly and deeply. We ask the patient to breathe like this. This is the advice you give in obstructive lung disease. Restrictive lung disease, breathe fast and shallow whenever the distress worsens. So we will ask the patient to breathe like this. Why is it so? There are hemodynamics involved, not hemodynamics. There are aerodynamics which are involved, which we need not go into right now. But this is the advice that you would give, and it is mentioned in Harrison as well. Okay, so the topic is done. This table is extremely important. It is asked in the exam. Let's go to the next page and have a look at this flow volume curve. This flow volume curve, have a look at it. Whenever you look at this flow volume curve, always we start from this particular point. We start from this particular point. This is your starting point. This is your starting point, right? The segment which is on the lower side, minus side, that is the inspiratory segment. And the segment which is on the positive side is expiratory segment. Why the inspiratory segment is negative? Because as you are inspiring, the negative pressure is becoming more negative. So flow is written in minus value. Whenever flow is coming out, the sensors are detecting the flow coming out towards it. So it is always written as a positive segment. So remember, we start from here, then inspiration happens. When inspiration begins, the volume which is present in the lung at that point is the residual volume. Okay, then inspiratory volume starts. This is the peak inspiration. Then inspiratory flow tends to fall. At the point at which maximum inspiration has been attained and no further inspiration can happen, this is the point where total lung capacity can be measured. Then the expiration starts. This is the peak expiratory flow point, and then the expiratory part ends and the new cycle of respiration begins. So what are the key points to know? First of all, it starts at point somewhere around 5.8 liter. The lower part is inspiratory, the upper part is expiratory. This point, what we measure is the residual volume. This point, what we measure is total lung capacity. These are the normal things that you need to know. You can know abnormal only if you know the normal values first. Now, what are the abnormalities examiner can ask you? Examiner will give you, he will say, a patient with a lung disease underwent spirometry. Flow volume curve is as shown in the image. What is the likely diagnosis? By looking at the image, you have to tell. Now, in this photograph, you can see that this is the normal value. I'm labeling it also. So they will label in the exam. This is a normal. And this is a patient's flow volume. Now, what has happened to this? Two things you can see. Can you see that it has moved towards the left? Shift to left has happened, number one. Second, in the expiratory segment, there is a concavity which is getting produced like this. Concavity. So, I'm writing here, whenever you have a flow volume where there is shift to left as well as concavity getting produced in the expiratory segment, the patient is having obstructive lung disease. Obstructive lung disease, right? What are the variations of this question? First of all, they can show this photograph and ask you diagnosis. Your answer will be obstructive lung disease. Whatever obstructive lung disease is given, you will mark it. Second, they will say obstructive lung disease was there. Curve is shown. After giving salbutamol, the curve shifted to right and became normal. What is your diagnosis? Tell me in the comment section. Tell me in the comment section. On giving salbutamol, the curve shifted back to right and became normal, and the concavity disappeared. What is your diagnosis? Absolutely right. Amit, Abdullah, Sakshi, asthma. Absolutely right. If it doesn't change, then it should be other diseases like emphysema or COPD should be thought of. Right? First thing. Second thing, look at this curve. This is a normal patient's curve. And this is the curve which has shifted to the right in the patient. Now remember, whenever there is a shift to right happening, whenever there is a shift to right happening, or the overall dimension, overall size becomes narrow, overall size becomes narrow, the patient is having a restrictive lung disease. The patient is having a restrictive lung disease. Restrictive lung disease. Also, you need to know that in whenever there is a shift to right, that will indicate a extra parenchymal variety, whereas in parenchymal, only the size will reduce in the patient. But again, examiner will not ask you to go so deep. So whenever there is a shift to right happening or overall size becomes narrow because it is a volume curve. So overall volume is reducing, it will be a restrictive lung disease in the patient. And absolutely rightly said, these patients, because it becomes sharp like this, so some patients may have a beanie cap appearance. Beanie cap is plus minus. It is not always seen, but if the uppermost expiratory curve becomes pointed, that is called as beanie cap. I'm just highlighting here. Beanie cap may be plus minus. And tomorrow examiner can ask you as one liner, beanie cap on flow volume curve indicates which lung disease? It indicates restrictive lung disease in the patient. So good, Royal Khan. Absolutely right. Moving further, look at this curve. What is happening in this curve? In this curve, this upper one is the normal curve. And here you are finding this is the curve of the patient. I am highlighting in red. Originally it was red, but due to some formatting, the red color was lost. So the red colored one is the patient. Now what you can see in the patient, I'm using the technical words also because there is a possibility tomorrow examiner may not show you the photograph. They will simply mention in the line and you have to imagine and tell the answer. So whenever in a flow volume curve, the inspiratory curve as well as expiratory curve are flattened symmetrically. They are flattening symmetrically. What does it indicate? If they are flattened symmetrically, that indicates fixed airway obstruction. It indicates fixed upper airway obstruction. Fixed upper airway obstruction. And the typical example for fixed upper airway obstruction is tracheal stenosis. Tracheal stenosis. Tracheal stenosis. What is the overall most common cause of tracheal stenosis? Most common cause of tracheal stenosis is prolonged intubation. MCQ point. So this is your medicine and anesthesia integrated and surgery integrated question. So prolonged intubation patient, after he has developed tracheal stenosis, what will happen? There will be a flattening of the curve. Flattening of the curve in these patients. If you have already watched 14-hour video in my channel, great. Some of the things I'm discussing because topic is same, I am the person same, so things will be same, but many things will be different and many things will be updated because Harrison 22nd edition has come in, right? So next curve, look at this next curve. What is happening? This is the curve of the, this is a normal curve and this is a curve of the patient. I'm highlighting in the red. It has become a circular. So whenever examiner says circular flow volume curve, circular flow volume curve, what does it indicate? Circular flow volume curve indicates neuromuscular weakness. Neuromuscular weakness. And neuromuscular weakness, what is the most common example? It will be seen in patients with myasthenia gravis. Absolutely right. Myasthenia gravis. Let us write NEET PG MCQ 2024. What is the most common HLA association of myasthenia gravis? It is HLA B8. That is your MCQ one-liner. Wherever possible, we will be incorporating all integrated MCQs at one place because end of the day, what we want, MCQ should be right. How we got it right does not matter. Obviously, concepts will be useful, but most common HLA associated is HLA B8. Many of you, you know these answers well. So whenever you start thinking, sir, my preparation, I'm thinking it is not going great, you need to trust yourself sometimes. Next thing, look at the next curve. Now in the next curve, what is happening? This red color curve is the curve of the patient. This is the curve of the patient. In this curve, what you can see is the upper part is normal, but only the inspiratory segment is flat. When only the inspiratory segment is flat, what does it indicate? It does not indicate fixed airway obstruction. Fixed में तो दोनों part affect होंगे. There will be variable airway obstruction. But which airway obstruction? Variable extrathoracic airway obstruction. Variable extrathoracic airway obstruction. Can you give an example? Can you give an example? Have you heard of croup patient? Laryngotracheobronchitis, right? Also caused by parainfluenza virus. That causes a variable extrathoracic airway obstruction. So all conditions which have stridor in them, remember, they all will present with this kind of flat curve. Only the inspiratory segment will be flattened in these patients. Okay. And finally, look at this curve. When this patient, what is happening? Only the expiratory curve, the upper one, the positive one, that is getting flattened. So if there is only expiratory segment getting flattened, only expiratory segment getting flattened, the patient is having variable intrathoracic, variable intrathoracic airway obstruction. It will not occur in asthma. It will occur in some rare disorders where the tone of the bronchus changes with time. So there are some rare causes. You need not go into detail. Yeah, and all of these patients will be having wheeze on auscultation. They will be having increasing and decreasing wheezing on auscultation. So remember, if examiner says which curve is associated with stridor, this curve will be associated with stridor. And if they say which curve is associated with intermittent wheezing in the patient, this type of flattening of curve where the expiratory segment is flattened, that will be associated with wheezing. Absolutely right. Great. Kuti Padkini, Royal Khan is writing retrosternal goiter. Absolutely right. Great. See, you people have prepared so well. So you just need to trust your preparation. How long the class will go depends upon my ability to sit and your ability to sit and listen. At least till 10:15, 10:30, the class will go. There will be breaks in between that I will let you know. Only 10 minutes break in between. Let us solve an MCQ. Look at the MCQ and give me your answer. FMG August 2020 MCQ. 60-year-old male patient is presented with complaints of dyspnea on climbing stairs. This flow volume curve is shown in red. As I said, this is the red curve. That is the patient. And his heart sounds and breath sounds are normal on auscultation. There is dyspnea on climbing stairs. What is the likely diagnosis? The overall dimension is reduced and it has slightly moved towards the right. What does it indicate? The patient is having, what is the answer? Restrictive extraparenchymal disease. Let me tell you a fact. When you listen to topper interviews, people will often say, paper was easy. When you hear someone who has not been selected, paper was very tough. Paper is always the same. Minor variations occur, like last exam, ophthalmology was tough. Previous to that, surgery and biochemistry was tough. But overall, the paper level remains the same. If you are well prepared, paper is easy. If you are not well prepared, paper is tough. What happens sometimes is, suppose you are very good in OBG and OBG comes very tough. So then it becomes a problem for you. But if you are good, I'm not saying brilliant, I'm saying good or above average in all 19 subjects, you have a better chance of cracking the exam rather than doing some subjects very good and some subjects very bad. And so last few weeks close to the exam, try to bring all the subjects up to a certain level. Also, revise all the 19 subjects according to the weightage and according to their strength and weakness. Try to give one mock test or GT so that you know what are the areas which are strong or persistently weak in me. So you can give more weightage to the weak subject. And lastly, whatever these revision sessions you are attending, if you listen to them only once, you may understand, but you will not be able to recall. You need to listen to everything 2 or 3 times. So the edited part of this video will be made available shortly in this channel. So once this is available and you have already listened once, you have already annotated the file, when you are doing revision or solving MCQs, now listen in 1.5x. It will save time and it will make sure that things will then echo in your mind. So please use them judiciously. At the same time, without solving MCQ, there is no point discussing all this. But because we are discussing a heavy duty subject and we started a bit late also, there was a technical interruption as well. So I just forgot to ask. I hope all of you are doing good. And come what may, never lose that smile on your face. Because that smile makes you think that, okay, exam is just a part of life. I am giving my 100%, but you have to stay as happy as possible and as tension free as possible. Some people say, sir, बहुत anxiety हो रहा है. It's okay. Try to distract your mind. Mind can be easily distracted. Take a break and come back. Some people say anxiety नहीं हो रहा. That is more dangerous. You should have anxiety, but it should be a positive anxiety that I have to push myself. I'm already reaching the threshold. I have to cross this exam. 17th January, your life is going to change for the better. And if something good is happening, you should manifest it. You should think positive about it and ask yourself, what am I doing so that it stays positive? Right? That's the only thing. Positive mindset is very important. Let us continue. Next topic, next thing. कोई बात नहीं, 3 मार्क्स से ही तो हुआ है. हाउ आर यू सर? आई एम डूइंग गुड. आई कैन डू बेटर, बट आई एम डूइंग गुड. Right? That is the philosophy I live in. I am doing good, but I can do better. I am taking a bath daily, working out a bit daily when I get time. I can do better. I am earning money, but I can do better. I am teaching you, but I can do better. What if you feel that you are doing good, you feel good at the same, and you are thankful to the nature for the opportunities given to you. At the same time, if you say sab ho gaya, sab aata hai, then you stop evolving yourself. So be on evolution. If you are giving a GT and your score is already 160, 170, great, great. But why not 190? Become a bit greedy. Okay, let's come back to the topic. Diffusion capacity of lung for carbon monoxide. Where does it increase? Where does it decrease? Now, many of you asked me कि सर कोई इसका mnemonic बता दो, बहुत confusion रहता है. Diffusion capacity of lung for carbon monoxide has been asked in NEET PG once. It has been asked in old paper of FMG once. So we have to do it. The mnemonic for DLCO increased. There is a mnemonic. Abhishek Sharma. I hope you all know Abhishek Sharma. He is the next big thing in our Indian cricket. Abhishek Sharma plays cricket. Easy to remember. The first words are the four important causes of rise in DLCO. A stands for alveolar hemorrhage. It is not anemia, alveolar hemorrhage. Do you know any disease where alveolar hemorrhage occurs? For example, there is a disease you must have heard the name good pasture syndrome. Good pasture syndrome. S stands for shunt. Which shunt? Left to right shunts. Left to right shunt example is ASD, VSD, PDA, etc. P stands for polycythemia. Polycythemia. Because more RBC mass, more hemoglobin will bind more carbon monoxide. So diffusion capacity of lung will increase. And C stands for congestive cardiac failure, also called as congestive heart failure. So this is the mnemonic for increase in DLCO. It's a simple one, but it covers all the points. There may be other causes also, but we are trying to cover the ones which are asked in the exam. And DLCO decreased. That simple way to remember mnemonic for this, VIP. जितने VIP लोग होते हैं वो हमेशा लेट आते हैं. VIP people are late. That is the mnemonic for DLCO. That is the mnemonic for DLCO being decreased. Let us write down what is the full form. V stands for Valsalva maneuver. I hope you all know what is Valsalva. You know, closing the two nostrils like this, and with a closed mouth, you try to push air through the eardrum. That is Valsalva maneuver. I, what does I stand for? It stands for interstitial lung disease. P, what does P stand for? It stands for pulmonary hypertension, also called as pulmonary arterial hypertension. I'm writing in short PAH. L, L stands for lung resection. Whenever lung volume loss happens or lung damage happens, overall volume loss, that can cause fall in DLCO. Then A stands for anemia in the patient. A also stands for a drug known as amiodarone. Amiodarone is a antiarrhythmic agent, but it also has thyroid side effects and it can cause fall in the DLCO. T stands for thromboembolism. You know there is a disease known as pulmonary thromboembolism we will be discussing today. And E stands for emphysema. E stands for emphysema. So this is the mnemonic. This is the list for you. Even if many of the things you might have read already, but if you keep adding these points to your notes, they will at least make it easy for you. There is a concept behind everything, but because exam is less than 2 months away, we cannot afford, we have to cover a lot of ground. So diffusion capacity of lung for carbon monoxide. While reading, if you have any doubt, extra doubt in your mind, say to yourself, if it is relevant to the MCQ only, then I will ask, other I will not. But still, if you feel like, you are most welcome to reach out to me. Then we come to the GINA guidelines for asthma. What is GINA? Global Initiative Against Asthma. They give you standard guidelines which are mentioned in Harrison, and they are followed by all the standard places, including in India. Where is the latest update? 2025 latest update has come. So you are supposed to remember the latest guidelines. For the purpose of asthma, see, asthma diagnosis requires two things. Listen to me carefully, then we write and annotate the points. For the purpose of diagnosis of asthma, two things are needed and both should be present. One, there should be some clinical feature suggesting asthma, and that feature should be variable. Variable means sometimes increasing, sometimes decreasing. Okay. Second, there should be abnormal spirometric value. I repeat, two things should be there. One, there should be variable respiratory symptom. Second, there should be abnormal spirometric value. And when you talk about spirometric value, it should be expiratory value, which should be abnormal. If you have any one out of this and any one out of this, then you say patient is having asthma. Let us go into the details. So first thing to understand, it is diagnosed if both are present. First, history of typical variable respiratory symptoms. Wheezing should be there, or shortness of breath, or chest tightness, or cough. Any of them can be there. These symptoms should be variable in time and intensity, sometimes more, sometimes less. Worse at night or awakening the patient from sleep, or they should be triggered by some agent like viral infection, cold air, exercise, laughter, allergens. So at least one out of these symptoms has to be there. Wheeze, shortness of breath, chest tightness, and cough. And second, on spirometry, there should be confirmed variable expiratory airflow limitation, at least one or more of the following. What are the things we look out for? First of all, you give you check the positive bronchodilator responsiveness test. What we do is first you check FEV1 or FVC. Okay, first you check. Then you give salbutamol and after 20 minutes repeat the test. If now the FEV1 improves, you will call it as diagnostic of asthma. Okay. So how much it should increase? It should increase by equal to or more than 12%, or it should increase by equal to or more than 200 ml. It should increase by equal to more than 12% or equal to more than 200 values you have to mark up. Second, you over a 2 week period, you check what is the peak expiratory flow in the morning and in the evening. This is difficult to do, but these days you have portable spirometric devices which can only check for PEFR value. So we ask the patient, do in the morning, do in the evening, 6 a.m., 6 p.m., and write in your diary. Now, patient comes to you and he has a diary record of 2 weeks. If you find that there is a variability in twice daily PEFR, peak expiratory flow rate by equal to or more than 10%, then again it is a criteria. Third, you give inhaled corticosteroid and check FEV1 after 4 weeks. If FEV1 rises by 12% or peak expiratory flow rate rises by 20%, then it is a criteria. Fourth, you perform a bronchial challenge test. First of all, you do FEV1. Then you give methacholine or hypertonic saline or make the patient do exercise and check again. Now FEV1 falls. That is also a test for asthma. And finally, excess variation in lung function. FEV1 varies by equal to more than 15% or PEFR varies by equal to or more than 20% between two visits to the hospital. That is also diagnostic. Now you might be thinking, sir, why it is so tough? These are not tough, but it is just that we are not doing them and you have not attended the spirometric clinics right now, so you are finding it a bit tricky. Remember, spirometry is essential for asthma in age above 6 years or 7 years if available. Below 6 year, you cannot do spirometry. So in young children, diagnosis is made based upon symptoms alone plus improvement in symptoms with bronchodilator. Okay. But above 6 years of age and adults, it is spirometry, which is the investigation of choice. Now, sometimes examiner asks you to distinguish between type 1 versus type 2 asthma. You need to understand that type 1 asthma is rare, whereas type 2 asthma is the one which is common. So when we talk about asthma, which is the variety we are talking about? Type 2 asthma. Type 1 asthma is the one in which there is a predominant neutrophilic infiltration of the bronchi. Type 2 asthma is the one in which there is eosinophilic infiltration of the airways. In type 1 variety, the IgE value is either normal or slightly increased. Whereas in type 2 asthma, the IgE value is significantly increased. The allergic one is the type 2 asthma. Type 1 variety, which will show no response, it will show poor response to steroids. Whereas type 2 variety will show good response to steroids. It will show good response to steroids. Now, why are we distinguishing between them? Because for type 2 asthma, new biomarkers have been updated, and this is a 2025 update. I'm putting a big star here. It could be a fresh MCQ, not only here, but I have put it as an update for the NEET PG groups and for the INI set groups as well. It was not asked in this INI set, but doesn't matter. It has the likelihood of being asked. For the first time, guidelines say there are blood biomarkers or there are other biomarkers where spirometry is not needed, which will indicate asthma in the patient. But biomarker available for what? Only type 2 asthma. Two biomarkers are available. First of all, we can check FeNO value. What is FeNO? FeNO stands for fractional expiratory nitric oxide. This value is increased significantly in type 2 asthma, but it is a costly test not available. As an alternative, the guidelines say patient with variable respiratory symptom, if spirometry is not available and you find increased levels of blood eosinophils above the upper limit value for that age, that is also a marker and it can be a reason to start therapy for asthma even if spirometry is not available. Very, very important. Add it somewhere, see it again close to the exam. Details how do you do that or the absolute values will not be asked, but at least the names of the biomarkers are important. Right? So these small little updates, they do matter. People will ask, sir, 1 point, what is the possibility it will be asked? You never know. Maybe it is the opening question in your exam. And if you don't remember it, that guilt will bring your whole paper down. How many times it has happened that you have left a particular topic thinking, क्या possibility है कि आएगा? And it gets asked. I have a past like that. If you have a past like that, don't play chances, don't take chances. A lot of students messaged me last few days as well. सर आप इंस्टा लाइव क्यों नहीं कर रहे? Because I have been busy taking classes and plus this class also I'm taking. Then some people said, sir, आप और राजीव sir live कब आ रहे हो? Rajiv Dhawan sir is coming to India few days later. Right now, I think he'll be taking a flight from Canada tomorrow. So once sir is back, we will do an Insta live. Third thing, sir, I have got only 140, 145, 142, 136 in my last GT. Do I have a chance? Yes, you do have a chance, but you need to see what is going wrong. Analyze the last two GTs, not single. Single will be too risky. Two or three GTs. What are the five subjects, apart from short subjects, what are the five subjects where your score is lowest? Those are your problem areas. Start working on them. First thing, FMG last 6 year papers, NEET PG last 5 year papers, mug them up. Any topic more than two times, read from your notes, attend the rapid revision along with the workbook. See the response. You will find it works. Your score will slowly start rising. If it doesn't work, obviously you can reach out to the specific faculty. And in pediatrics or medicine, you are most welcome to reach out to me. But just try it out. Don't do blind preparation. Do it in a focused way. And don't try to read everything. You can't. Whatever you are reading, make sure you are able to revise it also once the time comes. Okay. So these are, I'm just trying to give you small little things in between so you can also take that woe. Some information percolates inside. I'm answering your queries also and then going to the next topic. Treatment of asthma. Latest update. This is again different. Now let me tell you, I have a bad habit. It's a bad habit for me professionally, but it's a good habit for all of you. The bad habit is I always make it a point that before my sessions I go through what is there in all the platforms and all the videos and other places. Unfortunately, anything which has gone on already recorded or already printed cannot be changed. And so you need to remember this. This is the latest guidelines of asthma. They have simplified the guidelines. If you read the older guidelines, there was step 0, step 1, step 2, step 3, step 4, step 5. Now they have combined these steps together and they have simply said simplified therapy. What is the therapy that you will do? They say that any diagnosed patient with asthma, how would you start therapy? If the symptoms are less than 3 to 5 per week and overall lung function is normal, you will start AIR therapy. What is the full form of AIR? AIR stands for airway. What is the full form? Yes, Samreen Qureshi, type 1 and type 2, that intrinsic and extrinsic ones are no longer followed. Okay, that intrinsic one is no longer followed. Anti inflammatory reliever therapy is recommended. What is anti-inflammatory reliever? Earlier, what people were doing was they were giving salbutamol puff. Some people were adding inhaled corticosteroid. Some people were not giving salbutamol. Some were giving formoterol, and there was a lot of variation. Guidelines were not homogeneous. Now they have said any patient who, whenever he gets symptoms, he should take a puff of ICS formoterol. What is ICS? Inhaled corticosteroid combined with formoterol. I hope you know formoterol is a beta agonist. It is fast acting as well as long acting, right? So ICS formoterol, that is budesonide or beclomethasone, either of the two can be used combined with formoterol. इंडिया में सबसे commonly क्या मिलता है? Budesonide with formoterol. That combination therapy is to be used. Suppose I am a asthma patient, whenever and I fall in this category, my normal lung function is there, symptoms are less than 3 to 5 per week, I get only twice a week. So whenever I get symptom, puff of ICS formoterol, that's it. Do I need to take anything daily? It is not needed. In fact, the older steps 1 and 2 have been combined here. So steps 1 as well as step 2 are combined in this particular step. It's a very important thing. You have to remember the latest guidelines. Second thing, so people will ask, sir, ये latest पूछा जाएगा? People making your exams are not MBBS students or QBank editors. They are people who are HODs, big people, prominent people, whose only work is to do this. People whose experience is more than my age and your age. So obviously, any change happens in asthma, they would have contributed as a Indian as a for the Indian data to be included in it. So always read latest medicine, pediatrics, PSM, pharmacology. Read latest. Anatomy you read old, chalega. Physiology read old, chalega. Anatomy वही है, nothing change. But these topics, changes do happen and they are asked in the exam. So this is step 1. I'm going slow. I will pick up pace when the topics is easy. If the symptoms are equal to or more than 5 times per week and waking the patient at night, or there is decreased lung function, you will use low dose MART daily. Now it is not SOS, it is not as needed. Daily use करना है. और क्या use करना है? AIR use नहीं करना, MART use करना है. तो आप पूछेंगे सर मार्ट और एआईआर में फर्क क्या है? Subtle differences are there, dose difference is there, and how you are using it, that is different. So that is a practical thing. They will not ask MART use करना है. What is the full form of MART? Maintenance and reliever therapy. जो स्टीरॉइड है वो काम करेगा मेंटेन करने का. स्टीरॉइड विल एक्ट एज अ मेंटेनर. रिलीवर ऑफ ब्रोंको कंस्ट्रिक्शन विल बी डन बाय फॉर्मोटिरॉल. तो यूज सेम करेंगे. क्या करेंगे? आईसीएस फॉर्मोटिरॉल. लेकिन डिफरेंस क्या है? यहां यूज कर रहे थे एसओएस. एसओएस मींस व्हेन इट इज नीडेड. यहां यूज करेंगे डेली बेसिस पे. एंड कौन सा यूज करेंगे? लो डोज मार्ट. If there are daily symptoms, waking at night with decreased lung function, all three are present, or there has been a recent exacerbation which required hospital care, you will start medium dose MART daily. यूज वही करेंगे लेकिन उसका डोज जो है डेली बढ़ा देंगे, डबल कर देंगे. दैट इज कॉल्ड एज मीडियम डोज मार्ट. एंड इफ पेशेंट इज स्टिल नॉट इंप्रूविंग ऑन दैट, पुअर कंट्रोल इज देयर, frequent exacerbations are there, three possibilities. Either you can consider adding LAMA. What is LAMA? Long acting muscarinic agonist. Long acting muscarinic agonist. Example, tiotropium. There are two drugs, iotropium and tiotropium. Tiotropium is the one which is longer acting and recommended according to GINA guidelines. Or You can give a trial of high dose mart. The problem with high dose mart is steroid also becomes high dose, and so there are some side effects. And third, you can consider biological agents. What is the role of oral steroids? Oral steroids can be given for a life-threatening episode, but they are not useful in the definite management in such patients. So, what are the biological agents useful in asthma? Biological agents used in asthma. Use today examiners are not everyone there, are they? They won't ask about updated things. Uh, See, I will not comment upon what other people have the opinion. My personal view is, give you an example. Let me give you an example. Nobel Prize was announced in medicine around I think September, October. INI said it got asked in the exam. Have you noticed that COVID-19 was there in 2020 and 2021? So in 21 paper, 22 paper, there were questions on COVID. But COVID went away, questions stopped coming. Nipah virus outbreak happened, and drug of choice for a disease changed. I'm just forgetting the name of the disease. They got asked in the exam. So see, if there is a rare topic or the update has happened very recently, then obviously it will not be possible that examiner will be putting close to it. But don't you think, being doctors, it is important to read latest and not, stay justify कि नहीं, अपने आलस को जस्टिफाई नहीं करना है, हमें है ना, हमें लेटेस्ट पढ़ना है और हमें करेक्ट पढ़ना है. दैट इज ऑल आई कैन से. बाकी देखो, एग्जामिनर क्या डालेगा और कौन एग्जामिनर है, वो पढ़ के आ रहा है या नहीं पढ़ के आ रहा, there is no way to know that. So let's us read the latest. That is the most important thing. So what about considering biological agents? Yes, long acting muscarinic antagonist. Really sorry, antagonist. It is tiotropium bromide. Biological agents useful in asthma. This is extremely important from exam perspective. Very, very important from exam perspective. And it is integration with your pharmacology as well. Pharmacology as well. Right? So biological agent क्या क्या है? देखो, anti-IgE. What is anti-IgE agent which is approved for use in asthma? Omalizumab. Second, anti-interleukin 4 receptor alpha. The agent is dupilumab. Third, anti-interleukin 5. We have mepolizumab. And fourth, anti-TSLP. What is TSLP? TSLP stands for thymic stromal lymphopoietin. It is involved in maintaining low-grade inflammation in the airway. So anti-TSLP, tezepelumab, tezepelumab. Are there other antibodies? Yes, almost 11 monoclonal antibodies are there. But from exam perspective, what are the ones which are at least available in India? Approved by FDA, mentioned in GINA, available in India. These are the four important ones. Once you have remembered these four antibodies in asthma, you want to add more, most welcome to do it. But at least these four should not go wrong, right? And whenever now there is always a view ki which one is to be used where. Generally, 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 omalizumab is the first one which is started because number one, it is cheaper also, and secondly, it has maximum data safety available as well. But if they say that eosinophilia is very prominent, then sometimes we directly go over to dupilumab or mepolizumab as well. Now, these are complex guidelines. When you are solving MCQs in Q banks, particularly some custom modules where NEET PG and AIMS questions are added, you will find questions related to which one is to be preferred over what. Unlikely this will be asked in FMG because the data for that is lacking and that data keeps on changing very frequently. So the new GINA guidelines are ambiguous on this. I'm telling the word ambiguous, and that is why examiner is unlikely to put fine details. These are useful in refractory asthma. Yes, they are useful in refractory asthma. Refractory asthma. Right. In less than 6-year-old, how can you know lung function, or should we go with only clinical feature? I just told you, less than 6 year, you cannot depend upon spirometric value. The clinical suspicion comes into play, but that will be pediatrics. That will not be medicine. And that will not be asked for FMG students. That will be asked for people who are preparing for the PG entrance exam. Okay. So asthma, Important updates done. Let us pick up the speed. Easy things. What is SAMTUS? It is not SAMTUS. It's a spelling bit. SAMTUS triad. SAMTUS triad is an PYQ NEET PG asked 3 years back. Three things which are a part of SAMTUS triad. What are these three things? First of all, these patients have asthma. Second, they have increased risk of developing nasal polyps. And thirdly, there is hypersensitivity, increased sensitivity to aspirin. If they don't use the word aspirin, non-steroidal anti-inflammatory drugs they mention, that will also be correct because cross sensitivity is seen in these patients. So SAMTUS triad will be a triad of these three things, right? Good. Drugs useful in acute severe asthma exacerbation or status asthmaticus. Status asthmaticus is no longer called as status asthmaticus. We call it as drugs useful in acute severe asthma exacerbation. Exacerbation means worsening. So acute severe asthma exacerbation, what are the drugs which are useful? There was a question asked on this in INI set exam 2 years back. The question was, all of the following drugs are useful except, and it was a multiple correct option. So from exam perspective, you should know what are useful. Oxygen is useful. Steroids are useful. Two steroids are indicated for use. Either you can go for prednisolone or you can go for hydrocortisone. Third, you have salbutamol nebulization, which is useful. Ipratropium is useful. Tiotropium is generally preferred for maintenance therapy. Ipratropium is the one which is more useful for acute attack. Ipratropium is useful. Uh, in refractory cases, you can consider magnesium sulfate. You can consider IV theophylline, or you can consider IV aminophylline. Although they are seldom used, but these drugs at least can be useful. But where is no role of the drug? LABAs. LABAs is long-acting beta agonist. For example, salmeterol. They have no role. And montelukast, which is a uh, oral drug. It is an oral drug which is useful in the maintenance therapy in exercise-induced asthma. It has no role in the management of any acute exacerbation in the patient. So salmeterol and montelukast, this is a previous year question that you need to remember from exam perspective. Moving further, they have given some random empty space. You can utilize this space to write additional points whenever you are revising. Moving further, let us talk about COPD. Now, COPD is chronic obstructive pulmonary disease. Two broad types are there, type A and type B. Type A varieties are the ones which are called as emphysema, where there is a permanent irreversible dilatation of the terminal of the alveoli and destruction of the alveolar wall. And second variety is type B, where there is chronic bronchitis. Emphysema patients are also called as pink puffers because cyanosis is not there, but these patients have a tendency to puff away. Both of them are associated with smoking. Emphysema is the one which is associated with more aggressive smoking. So pink puffers. Chronic bronchitis is the one where cyanosis is there, and these are the ones who are having blue bloaters. Emphysema patients always have wasting which is present. Wasting means loss of waste is there. And blue bloaters are the one where weight gain along with productive cough is the hallmark. These are the patients who are having productive cough as the hallmark. Now, this is the tracheobronchial tree. It has been shown two types of emphysema can be seen. First variety is the one in which the entire lobule of the alveolus becomes involved. It is called as panlobular emphysema. It is also known as pan-acinar emphysema. You can get a pathology MCQ. Panlobular or pan-acinar emphysema is seen in which condition? This is seen in patients with alpha-1 antitrypsin deficiency. But if the examiner says there is centrilobular emphysema, only the central part of lobuli, this particular part is getting dilated. But the central but the terminal parts are still, relatively better off. This will be seen typically in patients with smoking associated disorders. These are the ones which are associated with smoking associated disorders, particularly COPD or emphysema. COPD or emphysema. Let us move into the gold criteria for COPD classification of severity. Gold criteria is important. I'm writing here. There was an MCQ asked on this in INI set November 25. INI set November 25, there was a question asked on this. So gold criteria says that there are four stages which are defined and they are decided based upon FEV1 by FVC ratio, which is a mandatory criteria, and then predicted FEV1 percentage. You have to divide. One is mild, two is moderate, three is severe, four is very severe. FEV1 by FVC will be less than 0.7 in all of these patients. It will not be responding to bronchodilator. If the FEV1 percentage is more than 80%, that is mild COPD. If it is 50 to 80%, that is moderate COPD. If it is 30 to 50%, that is severe COPD. And if it is less than 30%, it is very severe COPD. Running short on time, just focus on these particular points. Just focus on these particular points. And what is the treatment of COPD as per the gold criteria? Now, this is something we need to understand. For the purpose of treatment, there are additional things that we do. We first check what is the MRC dyspnea grading. Four grades of dyspnea are there. One, two, three, four, right? Those dyspnea grades is a clinical thing. Then there is a score we calculate called as CAT score. And we see whether the CAT score is less than 10 or more than 10. And third, we see how many exacerbations or worsening has happened. Worsening can be of two types. One worsening where patient comes to OPD and goes back home. Second worsening where patient requires hospitalization for minimum 24 hours. Then you decide what is the class of COPD. Class A, dyspnea grade is 0 to 1, CAT score less than 10, 0 to 1 moderate exacerbation. Moderate exacerbation is the one which can be managed by the patient or which requires OPD visit but does not require hospitalization. These are the patients in whom the therapy of choice, in these patients will be short acting beta agonist, that is bronchodilator given as needed. As needed means whenever exacerbation happens, you give short-acting beta agonist. But it is seen that giving short-acting beta agonist, eventually side effects start coming or responsiveness to SABA tends to fall down. If the patient still stays in class A, you can switch over the patient to short-acting muscarinic antagonist. So ipratropium bromide can be started, but it will be given as needed. What about class B? When the dyspnea grade is 2 and above, CAT score is equal to or more than 10, these values examiner will mention in the question. But there is no hospitalization. This is class B. In class B, you have to give long-acting beta agonists, but they are given daily. They are given daily or regular is the word used for that. So not SOS basis, long-acting beta agonist. Alternative in these patients is LAMA. Lama example will be, I've given the example already, tiotropium bromide will be your example. Then we have class C, dyspnea grade 0 to 1, CAT score less than 10, and at least two or more moderate hospitalizations, not moderate hospitalization, it's a misprinting, moderate exacerbations, or at least one hospitalization. If at least one hospitalization has happened, but grade is less than 2 and CAT score is less than 10, that will be class C. In class C, you have to give long-acting muscarinic antagonist regularly. And class D, where everything is severe, dyspnea grade equal to more than 2, CAT score equal to more than 10, two or more moderate exacerbations. Exacerbation means worsening, or at least one hospitalization has happened. Treatment in these patients will be combining long-acting muscarinic agonist with LABA. Or you can consider inhaled corticosteroids with LABA. And if refractory patient is there, there is no response, which agent can be added? It's very, very important. And it is prominently mentioned in the new Nelson. Older Nelson, it was just mentioned as a footnote. New Nelson prominently mentioned refractory patients, you can consider adding azithromycin, oral azithromycin in these patients. Remember that azithromycin is a macrolide, but it is a very, very versatile agent. It not only has antibacterial action, it also has modest anti-inflammatory action. And in patients of COPD class D, and severe cystic fibrosis with recurrent pneumonias, we are actually using azithromycin on a weekly basis. Either twice weekly, thrice weekly, बहुत तरह के regimes हैं, details will not be needed. So which antibiotic can be given for anti-inflammatory action in COPD and cystic fibrosis? What will be your answer? That is why I put a star. Azithromycin will be your answer, right? Azithromycin is resistant in many people. The reason azithromycin resistance is high is because in India we take azithromycin. Any sore throat, people take azithromycin. Any sore throat, people take azithromycin. Let me tell you a fact. Azithromycin resistance is not that common yet. It is that you are taking azithromycin for a wrong indication. That is the reason azithromycin doesn't work. You will learn it once you cross over to this side and start treating the patient. Then you understand that azithromycin is still a very, very good drug, but it is not a magic wand that, it's not Harry Potter wand that you just use like this and the patient gets gets correct. So azithromycin is the only agent which is antibiotic with anti-inflammatory action in respiratory tract. Remember this point, okay, will be useful in the coming days. Moving further, we have some case scenarios to you. Let us talk about some case scenarios. Now we can pick up the speed. These are easy scenarios. First of all, examiner will say there is a patient with asthma or cystic fibrosis. He comes to you with productive cough. It can occur in asthma, cystic fibrosis, but there is brown sputum. First clue in the question, thick brown sputum and brown plugs are present. The patient has difficulty in breathing, and second clue in the question, raised immunoglobulin E. Asthma or cystic fibrosis, brown sputum, raised IgE, not responding to the conventional management. What is the likely diagnosis? The patient is likely suffering from a disease known as ABPA. What is ABPA? Allergic bronchopulmonary aspergillosis. This is an allergic reaction in response to aspergillus infection. So it is an allergic reaction. What is the cause? It is hypersensitivity to fungus. What is the name of the fungus? Aspergillus fumigatus. The name of the fungus is Aspergillus fumigatus. What is the cardinal diagnostic test? Put a MCQ here. Specific immunoglobulin E against Aspergillus. We don't check total IgE. We do a costly test known as Aspergillus specific IgE. It is not easily available, but this is considered the cardinal diagnostic test. In other words, you can call it as a gold standard investigation also. What happens to circulating levels of IgE? The total IgE levels are increased. They are more than 1000 international unit per ml. What will CT or chest X-ray show? Another MCQ. This is an MCQ asked in radiology part of FMGE PYQs. You will find CT or chest X-ray shows bronchiectasis. What type of bronchiectasis? Bronchiectasis means destruction of the wall of large bronchus. Central bronchiectasis is seen in these patients. Normally, it is peripheral bronchiectasis which is more common. But in asthma patient, cystic fibrosis patient, ABPA patient, what type of bronchiectasis is seen? Central bronchiectasis is seen. Three types of questions you will ask. You will be asked, very, very important. If they ask you what is the treatment of choice in the patient, the treatment of choice is combination. See, it is an allergic reaction. You need to understand one thing. For treatment, when the patient is first diagnosed, you need to number one, control the inflammation. For that, you need steroid. Plus, there will be aspergillus in the body. You have not used antifungal. So you have to use antifungal agents as well. But if the patient is not improving, then you will add omalizumab to control the inflammation because it is IgE mediated reaction. But for every worsening which is happening, you need not give antifungal because exacerbations can occur in the absence of active fungal infection also. Okay, so whatever I just said, you can listen to it again when you are listening to the video. Treatment of choice in these patients will be prednisolone, that is corticosteroids, combined with antifungal agents. What are the two antifungal agents of choice? The first line agent is always itraconazole. If itraconazole is not tolerated, you can go for voriconazole. Remember, fluconazole does not work in aspergillus. Fluconazole does not work in aspergillus. So either itraconazole or voriconazole is useful. Uh, who is not interested in the lecture? I don't know. Mm, let us stick to the class only. Let us stick to the class, है ना? देखो यार, let me put in a very simple thing. I There is something you need to understand. There is a thing known as ideal thing, and there is a thing known as practical thing. Ideally क्या है कि you get up at 5 a.m. in the morning, you exercise, you take a bath, you read something, then you take breakfast, then whatever of work is there, you reach before time, then you are eating healthy foods like quinoa and oats and avocado toast and black coffee. You are not using abusive words with anyone. You are being nice to everyone in this world. Then you have a good family. You have a good, spouse or a girlfriend or a boyfriend, loving parents. Then you have a lot of money. You have a driver, no risk of you have air purifier in your car, in your room. So no air pollution. Then you come back, watch a movie and sleep off. This is ideal life. Ask yourself how many people are actually leading this ideal life, except for some influencers who only project that, right? We all aspire for it, but we don't have this life. What is the practical life? You get up in the morning, you're doing something daily which is making you move towards your goal. You're talking to your parents, they are, kind of okay with you, you are kind of okay with them. You may or may not be in a relationship, but you are working fine, and you are eating at least something, that your work is going on. This is practical life, which is ideal. The first one is ideal. But what is practical? Practical is the one we end up with. Many times by choice, many times by circumstances. Ideally, you should be reading medicine, all these topics, system wise in details, and you should read them in about, minimum 8 to 10 days. Minimum, right? Understanding meaning of everything. But do you have the time, number one? Do you have the capacity for that in such close to the exam, because you have to read it 2 3 times? Third reason, do you actually need it? Because you're not going to become an internal medicine specialist, you are going to crack the exam. So whatever is the best time available to us, we are trying to cover maximum ground in that, without running like a bullet train, without making blind random mnemonics. All the topics which I have collected, all the points I have collected, I have gone through Harrison myself, I've gone through the MCQs myself, made notes, changed the file, then made the file again. So somebody has done this thing for you. So this is not ideal, let me tell you, this is not ideal. So this is bare minimum that you can do. If you want a fighting chance, this one will be the base. Read more, I would say, read more, but don't leave these topics, right? If you were thinking कि बिना medicine के चला जाऊंगा, this will give you a very good fighting chance. That is the whole purpose. So I hope you understand. I train students for super specialty also. There is a video of mine on ABPA, because it occurs in children also. That video is 1 hour long. So, what is the point of me teaching all that? You don't need that information, right? So, let's do what we can. And that is my perspective. If whatever is you want to do, it's a free country, democratic country, free to follow or not to follow, right? That is the advice I can give based upon some of the queries which were asked to me. Ah, treatment of choice, steroids with antifungal. Refractory cases, what you will add? Omalizumab. And for exacerbations, that is worsening, what you will do? You will use only steroids. Why this point is important? Because there was an MCQ on this statement based question, not in FMG. It was asked in old AIMS paper, not NEET, INISET. AIMS before 2020, there was AIMS. It was not INISET. The INISET exam came by clubbing of the exam. So there was a question that a patient has been treated appropriately for ABPA. 1 year later comes to you with another acute exacerbation. Which of the following will be used? One of the option was steroids alone. One of the option was antifungals alone. Third was steroid with antifungal. Fourth was steroid, antifungal, and biologicals. What is your answer? Steroids alone. Because exacerbations can occur in the absence of fungal pathogens also. This is the funda that you need to know. This is the funda I'm telling you while discussing the topic. So first scenario is done. Second scenario. Second scenario. Respiratory infection or CVS condition is there, right? So patient will say there is a respiratory infection or there is a cardiovascular disease in the patient. Examiner will mention these words: decreased air entry is there, air entry is reduced, and this is the most important point, I'm highlighting it here. Stony dull percussion note. Stony dull percussion note always indicates presence of fluid in the lungs. Remember that. Stony dull percussion note always indicates fluids. If you see chest X-ray, there will be blunting of the costophrenic angles because there is fluid getting accumulated in the costophrenic angle, and there is appearance of S-shaped Ellis curve. It is something which is more of a uh, radiological described sign. We don't, pay much attention to it, but if they mention this word, the likely diagnosis in the patient is clearly pleural effusion. Pleural effusion. Right? So pleural effusion is the answer. Look at this table. Lights criteria for pleural effusion, very important. And there was a question asked on lights criteria indirectly in the recent uh, FMGE exam also. So we will see the question. So based upon lights criteria, pleural effusion can be of two types: low protein and high protein. Low protein is called as transudative. High protein is called as exudative. How do we calculate? How do you say transudative versus exudative? We take the protein value, the ratio between the pleural protein divided by serum protein. If the pleural protein is less than 0.5 of the serum protein, that is transudative. If it is more than 0.5, it is exudative. Then we check for LDH value. If the LDH value is less than 0.6 of the serum fluid in the pleural space, then it is transudative. If the pleural LDH is more than 0.6 times, that is more than 60% of the serum value, that is exudative. Third, if you don't have a absolute value, if you see that pleural LDH is less than two-thirds, equal to or less than, this word is missing here, equal to or less than two-thirds of the upper limit, then it is transudative. It is more than two-thirds of the upper limit of the normal value, then it is exudative. What are the common causes? Causes you need to remember. Multiple MCQs on this has been asked. Multiple MCQs have been asked on this. So transudative will be seen in systemic diseases like hypoalbuminemia, like cirrhosis, nephrotic syndrome, CCF, constrictive pericarditis. They will all have transudative effusion. On the other hand, exudative pleural effusion will be seen in autoimmune disease, for example, SLE, esophageal rupture, infections. Highlight this word, parapneumonic. This was the question which was asked. TB, fungal, empyema. What is empyema? Pus in the pleural cavity. Malignancy, pancreatitis, post-CABG, and pulmonary embolism. These all will have exudative pulmonary embolism. Writing in the bracket so that you don't miss it. And this is the photograph where they will show the photograph and ask you the diagnosis. Can you see that there is fluid, there is blunting of the costophrenic angle here? And what is S shape? It is a shape in which as you move from medial to lateral, the fluid level tends to rise. It reaches a peak over here, and then when you move posteriorly, it starts falling again. So it forms a S-like shape. That is called as the Ellis S-shaped curve. It is a more of a fancy word. It is something we do not pay attention in real life. If there is costophrenic angle getting obliterated like this, along with stony dull percussion node, the likely diagnosis is pleural effusion. Look at the MCQ. Treatment of pleural effusion depends upon the cause. Remember the word. Putting a treatment, I'm writing, mostly it depends upon treating the cause. Mostly you will treat the cause. However, in parapneumonic effusion, what is parapneumonic effusion? Due to pneumonia, fluid is accumulating. There is no separate treatment needed. Antibiotics for underlying pneumonia are good enough. No separate therapy is needed. But empyema, if it occurs, that will require IV antibiotics along with intercostal tube drainage. Intercostal tube drainage. So mostly it depends upon treating the cause in the patient. राइट एक्यूट अटैक ऑफ अस्थमा डॉक्टर केवल मैंने ड्रग्स का बता दिया आपको उसके ऊपर क्वेश्चन सॉल्व करो डायरेक्ट क्वेश्चन नहीं आता है दे विल सिंपली आस्क यू कि विच ऑफ द फॉलोइंग कैन बी यूज विच ऑफ द फॉलोइंग विल नॉट बी यूजफुल दैट लिस्ट आई हैव ऑलरेडी टोल्ड यू सेम वाज द क्वेश्चन आस्क्ड इन आईएनआई सेट आल्सो इनफैक्ट क्वेश्चन जो पूछा गया था वो आईएनआई सेट का ही रिपीट क्वेश्चन था सो सॉल्व द क्वेश्चन इन केस देयर इज एनी डाउट मोस्ट वेलकम टू रीच आउट टू मी मेरा Telegram or Sara groups आपके पास link is available. Now look at this FMG January 2025 MCQ and tell me the answer. Look at this question and tell me the answer. A patient with a history of pneumonia develops pleural effusion. So pneumonia with pleural effusion, what kind of pleural effusion it is? Parapneumonic. Parapneumonic is exudative or transudative? This is all you need to remember. Exudative, right? If it is exudative, look at the options. Pleural protein ratio compared to serum less than 0.5, wrong. It is more than 0.5. Pleural LDH less than two-thirds of serum LDH, wrong. It is more than two-thirds. Pleural LDH less than 0.6 of serum LDH, wrong. It is more than 0.6. What is the odd one out? pH is not used to distinguish. An odd one out here is B, which is your correct answer. Many times you don't know the answer, but answer is reached by ruling out the options. So by ruling out the options, you can easily reach the correct answer. So if you have a question like this, don't panic. What is important is if a future question gets asked, you have to remember what are the causes of transudative and what are the causes of exudative pleural effusion. Okay, let's move further. Next scenario, examiner will say there is a patient having hemopsis. What is hemopsis? There is bleeding in the sputum. Hematuria, that is, there is bleeding in the urine, and anti-GBM, anti-glomerular basement membrane antibodies are present. Whenever you have a diagnosis like presentation like this, patient is suffering from an autoimmune disease known as Good-Pasture syndrome. In Good-Pasture syndrome, what is the cause of hemopsis? It occurs due to alveolar hemorrhage. The cause in the patient is alveolar hemorrhage. Now, let us go one by one. What is the age and gender for Good-Pasture syndrome? Now, there are two peaks of Good-Pasture syndrome which are seen. One peak occurs in the mid adulthood and young adults, and second is the one which is seen in older age group. In the older age group, male and female are equally affected, but this is one autoimmune condition where males are slightly more affected compared to female, and it is 20 to 30 year, which is the common age group. And the risk is significantly more, or the bleeding in these patients is particularly triggered in smokers. So smoking does not cause Good-Pasture syndrome, but smoking triggers acute complication or acute alveolar hemorrhage in the patient. So smoking in general is bad, but it is very bad in Good-Pasture syndrome. So what is the most common auto antibody which is seen in these patients? There is IgG type of anti-GBM, anti-glomerular basement membrane antibody, which is seen. This anti-GBM antibody is directed against what? It is directed against alpha 3 NC1 domain of type 4 collagen. Alpha 3 NC1 domain of type 4 collagen. This particular point is also your MCQ. This is integrated with pathology part, which antibody produces this disease. So these tables of antibodies is something you read in pathology also. If there is isolated renal involvement in Good-Pasture syndrome, we don't call it as Good-Pasture syndrome. The term anti-GBM disease is used in them. So when they say anti-GBM disease, these patients will not have alveolar hemorrhage. Now, what is the treatment of choice? Now, to remove, if the patient is presenting acutely, you need to start steroids and do plasmapheresis for the removal of these antibodies. So you will do plasmapheresis if the patient presents with severe disease with increased autoantibody titers. However, in general, for the attainment of remission, controlling the disease, the drugs, the therapy of choice, if they ask, you would write like this: we use a combination of choice. A combination of steroids, that is prednisolone, is combined with cyclophosphamide in these patients. So steroids along with cyclophosphamide are useful. Cyclophosphamide is not only an anti-cancer agent, it also has good immunosuppressive action. And in many vasculitis and many autoimmune diseases, cyclophosphamide is one of the frontline agents. So this is your Good-Pasture syndrome. Let us move towards this disease. If you have written, I'm changing it. Next question. Examiner will say there is known infection patient, or there is respiratory disease or trauma. And there is dyspnea, that is sudden onset shortness of breath. Generally, it is sudden onset. So, sudden onset shortness of breath will occur. There will be decreased air entry on one side. Decreased air entry on one side can be seen in pleural effusion also, but there will be unequal breath sounds. There, the important point was there will be stony, dull percussion note. Here, there is hyper resonant note in one affected side. And chest x ray shows deep sulcus sign and loss of vascular markings on the affected side. What is deep sulcus sign? On the affected side, there will be a sign like this where air will be trapped. And this sign will produce a deep sulcus like appearance, and there will be complete absence of vascular markings in that particular segment. Whenever you have a presentation like this, what is the likely diagnosis? The patient is suffering from pneumothorax. 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 Okay. Now, if there is, what is the treatment of pneumothorax? If it is, I'm giving the heading, if there is sudden onset pneumothorax or fall in SpO2, you should suspect the patient is having a variety of pneumothorax called as tension pneumothorax. Tension pneumothorax needs to be relieved as early as possible. And the immediate therapy of choice in these patients will be needle decompression. The first step in pneumothorax will be do needle decompression. Do needle decompression. Now the question arises, MCQ point. What is the site of doing needle decompression? Site of doing needle decompression. If it is a child, then you do needle decompression in second intercostal space in the mid clavicular line. You do it in the second intercostal space in mid clavicular line. But if it is an adult patient, you will do in the fifth intercostal space in the mid axillary line. So be careful what is being mentioned. These are the standard guidelines for doing. After doing needle decompression, later you will put intercostal drainage tube insertion. But this site of putting needle is important, and already previous year question has been asked. It is integration between surgery, anesthesia, and medicine. And pediatric part also I have mentioned. So child ke andar second intercostal space, make sure it is mid clavicular line. In case of adult, it is the mid axillary line where we put it in the fifth intercostal space. FMG July 25 MCQ. Options are not there. Question was something like this. This is the latest MCQ. After failed subclavian catheterization, when you are putting subclavian vein through here, there is always a possibility of hitting the apex of the lung. There is increased work of breathing, BP falls and pulse rises. What is the likely diagnosis? Likely diagnosis is pneumothorax in such a patient. So what needs to be done? Do urgent X-ray and consider needle decompression. Pneumothorax is a known complication of subclavian catheterization. Now, it is predominantly a uh, anesthesia topic integrated with medicine and surgery, of course. So, pneumothorax is your answer. Pneumothorax is your answer. Okay. See, I've already moved ahead. Whatever doubts you have, you're most welcome to reach out to me later. And I will take up the doubts. I will clarify them tomorrow also. I'm coming tomorrow also. So don't worry. Anupriya, PDF has been shared in all the groups. If you are active on the Telegram group, I have shared it there. On Dr. Bhanu Prakash group also, the PDF has been shared. For now, you can listen to the session. And when we take a break, you can drop a message. I will share it with you. Okay. Next thing, examiner will say, productive cough. Cough is more in the morning. Now, cough is showing change with posture and change with diurnal variation. Productive cough more in the morning, yellowish sputum, and the sputum amount increases with change in posture. So, something getting collected in a dilated space. Fever plus minus, another clue, clubbing of the digits. The patient is suffering from a disease known as bronchiectasis. So, what is the likely diagnosis in patient? It is bronchiectasis. If you go through medicine MCQs of July 25, January 25, last 24 both exams and 23 both exam. In medicine, at least 5 to 6 questions are only based upon tell the likely diagnosis. It is just that every time examiner keeps, conjuring up new ways of asking you. So if you know the buzzwords, you can either reach the correct answer or you can rule out the option to reach the correct answer. And that is why these small boxes which I am discussing, you are supposed to remember every word of them because many times easy question. It is just that you know the buzzword, you know the keyword, you know the answer. So bronchiectasis, what is bronchiectasis? It is definition they will not ask irreversible dilatation of the lower larger tracheobronchial tree that is called as bronchiectasis. What is the investigation of choice? Investigation of choice is a previous year question. It is HRCT, high resolution CT scan of the chest. And what are the radiological signs which are seen in these patients? Three types of radiological signs. देखो रूल आउट करना जो है दैट इज अ क्लिनिकल स्किल द मोर एमसीक्यूज यू सॉल्व द बेटर यू बिकम इट्स लाइक बॉलिंग अ बाउंसर how to bowl a bouncer somebody can teach you but unless you practice it as a bowler you will not be able to do. I'm just really giving a cricketing analogy. At the same time, if you become good in bowling bouncers like Bumrah is, at the same time never try to use words like Bumrah used. You all know what happened when he used to, never do, in your hostel rooms, it is okay. In your personal life, you do some body shaming, that is fine. But in professional life, it's not appropriate. It does, you don't come out as good, somebody listens to you. Because all of you tomorrow are going to be doctors. You are doctors, but legally doctors. Legally, in the sense, you will be able to practice. And people will be looking up to you. The way you dress, the way you talk, so it should be appropriate, right? And when life gives you short stature and humiliates you a bit publicly, be like Temba Bavuma. The sad part is he performed against India, but he really made his performance speak. Let your performance speak on 17th January. If you feel lack of motivation is happening, think of the people who have troubled you, who have taunted your parents, and cast aspersions on doubts on your ability to perform. Success is the best revenge. One result, one success message sent to your doubters with humility, with folded hands. Thanks for your words, but I have performed well and I have cracked the exam. Life gets closure and you move ahead in life and let it be a motivating factor, right? You may not actually do it. Again, we are different people, all of us, but use it as a motivation that phase in life I have to attain. Okay. So, investigation of choice, HRCT chest. Yes, absolutely. See, cricket, if we start talking about cricket, we'll get carried away. We have to finish all these points and take the first break also. So, what are the radiological signs of bronchiectasis? Three radiological signs are described. It is a NEET PG MCQ. The question was all of the following are radiological signs described in bronchiectasis except. So, three signs were mentioned. You have to remember all the three signs. So, first sign is tram track sign. It is not tram track calcification. Tram track sign. Tram track calcification is a feature of Sturge-Weber syndrome that we will discuss tomorrow. कल आएगा वो. Second is signet ring sign. Signet ring is seen in malaria also, and signet ring sign on radiology is seen on bronchiectasis. What is a signet ring? You have a ring like this, and then there is a हीरा like this, वो हीरे वाला अंगूठी, that is called as signet ring, right? So signet ring sign will be rings like sign, something like this. And third, there will be tree inward appearance. If you are already wearing a ring like this, you can have a look at it. If you're not wearing a ring like this, don't worry, your time will come, but not now, after 17 January. So tree inward appearance. So these are the three radiological signs described in bronchiectasis. What is the treatment in these patients? Treatment of bronchiectasis is treat the underlying cause. So generally it is infection. So you will use IV antibiotics. Harrison says these antibiotics should cover Pseudomonas and H. influenza. So generally we go for third generation cephalosporins. So most commonly we use third generation cephalosporins. Plus we allow more chest drainage to occur. So you give chest physiotherapy so that the mucus, the sputum which is collected in the dilated vessels, that can come out. The drainage of the chest improves, plus minus nebulization in the patient. And obviously, if it is due to underlying reason, you will be correcting the underlying cause. This is the treatment of. Yes, honeycomb appearance can also appear in a few patients. See, that is what I'm saying. There are, if you go into radiology, there are so many radiological signs which have been described. The only thing is we can't remember everything. See, radiology makes sense only after you have done all the other 18 subjects. So I'm covering this particular point here because it was a previous year question. And these were the three options mentioned in the question. So the fourth one was your answer. So obviously there are more signs. So you are supposed to read radiology. But here I'm talking like a clinician. The most important things or the characteristic points are the ones I am discussing. And then we come to pneumonia. How pneumonia question will be asked to you. Examiner will say fever and cough is there. There is shortness of breath. Bronchial breathing will be the clue. And chest x-ray will show either lobar consolidation, in one lobe there is consolidation, or diffuse infiltrates are there. Generally, lobar consolidation occurs in typical bacterial pneumonias, and infiltrates in both the lungs, hilar infiltrates, they can occur in bacterial causes, they can occur in viral causes, they can occur in some opportunistic pathogens as well. So fever, cough, bronchial breathing, consolidation or infiltrate, we are dealing with infection and inflammation of the lung parenchyma, that is pneumonia. Pneumonia. The diagnosis is pneumonia. Rahmatullah Kamal is saying bus da sarji. I don't know what you mean by that. So this is pneumonia. Now let us talk about one-liners on pneumonia. Pneumonia is a sure topic in exam. If you go to pediatrics, IMNCI guideline of pneumonia, sure topic. If they don't ask there, you come to medicine, you have all the one-liners and you have criterias and you have treatments of pneumonia. So pneumonia, you do from pediatrics, you do from medicine, you go into the exam knowing that pneumonia, something is going to be asked, right? So let us talk pneumonia, one-liners. Overall, most common cause of pneumonia is Streptococcus pneumoniae, also known as pneumococcus, also known as pneumococcus. What is the cause of nosocomial pneumonia? Most common cause is Staph aureus. Most common cause of pneumonia in COPD patient given in Harrison, Haemophilus influenzae. HIV, if they say overall most common cause, overall most common is different. Overall most common will be pneumococcus, that I will write separately. But if they say CD4 count related, CD4 count less than 500, these patients have a tendency to develop Mycobacterium tuberculosis infection. It will not be a true pneumonia, but it will mimic pneumonia-like presentation. CD4 count less than 200, patient will develop pneumocystis jirovecii infection. Previously, it was called as pneumocystis carinii. And CD4 count less than 50 cells per millimeter cube, it will be atypical mycobacteria. Atypical mycobacteria. For example, MAC. What is the full form of MAC? Mycobacterium avium intracellulare. Mycobacterium avium intracellulare. If question says lobar consolidation and bronchial breathing in AIDS patient, lobar consolidation will be typically produced by pneumococcus. And pneumococcus is also the common cause if CD4 count is not mentioned. Whatever the CD4 count, if they simply say most common cause of pneumonia in AIDS patient, where HIV positive patient already AIDS has developed. I hope you all know AIDS and HIV are not the same. HIV positive patient turns into AIDS, right? That subtle difference you'll be reading in microbiology. And if they say pneumonia with hyponatremia and diarrhea, hyponatremia means low sodium level and diarrhea with pneumonia. Always think of Legionella pneumophila as the likely pathogen. In these patients, the risk factor will be contaminated water conditioning or AC units, from where aerosols can spread into the closed room and spread Legionella pneumonia. And drug of choice in these patients, you can use either fluoroquinolones. These days, levofloxacin is very useful, or you can go for azithromycin. fluoroquinolones or azithromycin. MCQ, CD4 count less than 50 is an MCQ. COPD is an MCQ. Overall most common cause is an MCQ. Okay, Rahmatullah, you are from Afghanistan. Hi. Thank you, Senthil. Thank you so much. I'm trying to cover the best I can. So, the points done. Let us have a look at FMG January 23 MCQ and give me the answer. FMG January 23. Look at the question and give me the answer. HIV positive patient, pulmonary infection, CD4 count is less than 50 cells per millimeter cube. Sputum was positive for acid fast organism. Acid fast are mycobacterium. All mycobacteria are acid fast. They will stain with Zeal-Nielsen stain. So two clues, CD4 count less than 50, acid fast organism. Answer is B, Mycobacterium avium intracellulare. Mycobacterium avium intracellulare. Nosocomial pneumonia is hospital acquired pneumonia. Nosocomial pneumonia is hospital acquired pneumonia. Okay. Next, what is the predictor of mortality and where do you want to treat the patient? For that, we have a criteria known as Curve 65 criteria. Curve 65 criteria. NEET PG. Recently, it was asked. I said, recently it was asked. Would it be asked in FMG exam? You will tell me when we come for the recall. So there is a curve 65 criteria. It predicts mortality and it tells where you are supposed to treat the patient. Should you admit the patient? Should you treat on OPD basis? So curve 65, five components are there. CURB and 65, which is the age. C stands for confusion. So check for sensorium of the patient, whether he's oriented or disoriented. Second, you check for urea. Any urea value more than 7 millimoles per liter, that is a positive finding. You are giving a score of 1 each for if they are present. Then R, respiratory rate. If respiratory rate, it is not a newborn, it is not a child. So any adult with respiratory rate 30 per minute or more, give score of 1. Fast breathing will be there. B, BP abnormality. Either systolic BP is less or diastolic BP is less, or both. But you will take it as one value. Either systolic BP less than 90 or diastolic less than 60, one score. And age more than 65, one score. Then you calculate the total score. If the curve 65 total score is 0 to 1, it is risk group 1. Mortality is only 1.5%. Low risk, you can give antibiotics at home. If the curve 65 score is 2, risk group is 2, mortality is 9.2%, you have to decide if the patient is having any other comorbidity, counsel the patients, relatives, you feel that they are well off, but they live quite far away. So counsel them, get admitted, start antibiotic, later on we can discharge. But if the patient is very poor, no beds available, you will start with OPD care, but make sure that they are coming very frequently for the change of antibiotic. And if the score is between 3 to 5, there are scenario questions, tough scenario questions asked on this in INICT. So please spend some time in your local vernacular language, whatever it is, speak it out, discuss with your friend, or look at your mirror and talk to yourself and say it out what you are going to do. If it is total score 0 to 1, manage at home. Score 2, 9.2% mortality. So either ways it can go. But if it is 3 to 5, risk group 3, 30-day mortality without therapy is 22%, admission, and you have to manage as severe pneumonia. Okay, curve 65 criteria 3 to 5 is the criteria for severe pneumonia. This is also an MCQ. When do you say severe pneumonia according to curve 65? I've put a small q here. Which is better? Harrison says either of the two can be used, but curve 65 is the one which is more commonly used. And this is the one on which questions are asked. PSI questions are generally not asked. And end of the day, Harrison also talks. Harrison says more than the scoring systems, it also depends upon the assessment of the physician, which is actually true. Scoring system can only help you medico-legally. Eventually, it is your clinical skill which will help you to decide what and where you want to treat the patient. So the question is, where do you want to treat the patient? For that, I have kept a lot of space. Why? Because I will be writing the updated Harrison guidelines. Updated Harrison 22nd edition guidelines. So I'll go slow, but this is an important point. So first of all, treatment of choice. If you are doing on OPD basis, you have, see, whether to decide OPD basis or not, we have already decided, right? Curve 65 criteria. If you are managing on OPD basis, first possibility, patient has no comorbidity. No comorbidity, only pneumonia is there. So what are the things you will do? You will use the patient. The first line therapy will be oral amoxicillin. You don't give amoxiclav, you give oral amoxicillin. Plus minus, you can consider combining either doxycycline or macrolide. Which macrolide do we use? Write in bracket azithromycin. You can combine one of the two with amoxicillin. What are the alternatives? This is the first line therapy. Alternative will be oral doxycycline alone, or you can go for oral azithromycin alone. Second possibility, if the patient has comorbidity. Comorbidity means there is some additional more problem. For example, there is uncontrolled diabetes also in pneumonia patient. Now there is a comorbidity or very severe hypertension in the patient, or patient already had, some other recurrent infection or some hospitalization for some other event. Maybe he had appendix surgery some months back, some weeks back. So comorbidity is there. Now what you will do? You will treat on OPD basis, but in these patients, you will use oral amoxiclav. Now you will combine amoxicillin with clavulanate combination. Oral amoxiclav will be used, and you will combine it. Amoxiclav will be combined with either doxy or azithro because it is a comorbidity which is present. And second alternative, which is the one that we follow these days, you can use oral respiratory specific fluoroquinolones. Respiratory specific. What are the respiratory specific fluoroquinolones? You know the answer. It is either levofloxacin or moxifloxacin or going changes compared to what you might have read in your usual medicine notes. If you don't remember the usual medicine notes, this you have to remember. There is a possibility you may get question on this. इस टाइम के एमसीक्यू नॉर्थ साइड में भी पूछे जाते हैं. काजल गौतम, आई हैव नॉट सीन द इमीडिएट recent paper, but as far as I know, sometimes they do ask questions like this. But in north side, they will not go into that details. They will simply ask you where you use oral and where you use combination therapy. They will not give very close option. The options will be more broad. So this will work for your exams also, but you don't need to go into the doses and fine details, except for pediatrics and gynae, where they will ask the doses also. So this is regarding the OPD basis treatment. Second is inpatient therapy or inpatient basis. Inpatient basis means you are admitting the patient. I'm writing in bracket hospitalized patient. In inpatient basis, if it is non-severe, you have admitted, but the patient is otherwise stable and there is no shock or any septicemia feature or other things. Non-severe patient, you will use beta lactams. You can use either penicillins or cephalosporins. Generally, we use cephalosporins IV, and they are combined with macrolides. They are combined with macrolides. They are combined with macrolides. Or you use fluoroquinolones alone, but you admit the patient and monitor in the hospital. If there is a patient with severe pneumonia and he's admitted in hospital, then you have to combine beta lactams with fluoroquinolones. And if finally, last point, if the patient had any recent hospitalization in the last 2 or 3 months, or any recent hospitalization was there, you will add vancomycin. You will add vancomycin or piperacillin tazobactam. Think and tell, why are we using vancomycin? Vancomycin is being added for MRSA cover, and piperacillin tazobactam is being given for Pseudomonas cover. It is being given for Pseudomonas cover. You will now which one to add? That is a decision of the treating physician. Examiner will not ask you to choose. Right? Good. Good. Yes, Samreen Qureshi, it depends upon the age. Age we have already considered curve 65 criteria to decide the type of hospitalization, right? So this is a summary. This is based upon two tables given in Harrison 22nd. Minor differences are there compared to the older Harrison. So it's a topic which is important and is being taught in the current NEET PG classes also, that this is a very important topic for the NEET PG exam. It is not only for NEET PG, it is also important for INISET. So I've kept empty space and I had to explain and write. And those who are looking at their watches, yes, we are well on track. Don't worry. One third class is already done. Some topics will be easy. They will take less time. The difficult things I have kept in the front only. When Virat Kohli plays well and he's in form and he's chasing, he's able to get the team home through the final score. So don't worry on that. So one-liners on pneumocystis jirovecii pneumonia. There are one-liners asked. First of all, pneumocystis jirovecii commonly causes infection in HIV positive patient. Something you already know. And what type of pneumonia it causes? It does not cause lobar pneumonia. It causes interstitial pneumonia. And when you do chest X-ray, there will be bilateral interstitial infiltrates present on the both sides. What will HRCT test show? HRCT test findings are important. These patients you will find diffuse ground glass opacities. Diffuse ground glass opacities. They are also written as GGOs. Remember that GGOs can occur in COVID-19 pneumonia also, but COVID-19 questions are being asked. If you last time did not do medicine and got 145, which it means just maintain the same level in other subject and finish off medicine, you will easily score very well, right? We will take a break. Just stay with me for the next 5-7 minutes. We will take a break soon. Investigation of choice. Bronchoalveolar lavage fluid we take and apply GMS stain. GMS is a silver stain. Gomori methenamine silver stain. It will be positive for cyst. And if they ask you drug of choice, treatment के लिए भी prophylaxis के लिए भी same drug is useful. Cotrimoxazole. It is a sulfonamide. Sometimes they don't write cotrimoxazole. They write TMP SMX. That is the other name for cotrimoxazole. Trimethoprim sulfamethoxazole combination, that is called as cotrimoxazole. And next thing, last topic. After that, we will take the break. So just stay with me for the next 2 minutes. Okay. Examiner will give you this scenario: old age patient, bedridden patient, post-operative patient, sudden onset dyspnea. Sudden onset dyspnea can occur. See, you need to understand now. I'm summarizing as we are discussing. Sudden onset dyspnea with stony dull note, it will go in favor of rapidly developing pleural effusion. Sudden onset dyspnea in a patient where there is a history of asthma or allergies will indicate an acute exacerbation of asthma. Sudden onset dyspnea in a patient where there is resonant note happening and one side breaths are decreased, that will indicate pneumothorax. And if they say sudden onset dyspnea with tachycardia, pleuritic chest pain, and chest pain is worsening on inspiration, it indicates patient is developing pulmonary embolism or pulmonary thromboembolism. It typically occurs in old age patient, bedridden patient, post-operative patient, particularly total hip replacement patients. Fracture femur patients are more prone to develop this. The likely diagnosis in these patients, I'm putting it above, it is pulmonary thromboembolism. Pulmonary thromboembolism. Sometimes the word thrombo is not included. They use the word pulmonary embolism. They are the same disease. Don't get confused. Embolism, pulmonary thromboembolism, these words are synonymously used by the examiner. This is your old NEET PG MCQ. All of the following are seen in thromboembolism except pulmonary edema is not seen. You may get a simple one-liner. Pulmonary edema is not a feature of thromboembolism. Now, what are the risk factors? Important risk factors. First of all, it occurs in old age. Second, it occurs in prolonged immobilization, if the patient is immobilized for a long time. Third, it occurs in post-operative patients. What are the two surgeries in which the risk is more? Post-operative, if there is total hip replacement, the risk is more. You need to give prophylaxis. Second, any patient where invasive management of fracture neck of femur surgery has been done. Fracture neck femur surgery. You will have higher chances of developing pulmonary embolism. Fourth, it can occur in nephrotic syndrome. Nephrotic syndrome is a procoagulant prothrombotic state. Fifth, it can occur in factor V lead-in mutation. It's some genetic cause of thromboembolism, can occur in young adults. It can also occur as a part of APLA syndrome, anti-phospholipid antibody syndrome. These are the important risk factors. Actual list, there are almost 15, 20 causes. These are the important ones which examiner will be asking. So these patients will have first develop a deep vein thrombus, either in the calf veins or in the femoral vein, that will dislodge and then cause embolism. What is the screening test in these patients? Screening test is one liner. Screening test in these patients is blood for D dimers. When you check blood for D dimers, these D dimer levels will be increased in the patient. But remember, D dimers can be increased in DIC also. So DIC can also have rising D dimer. So one possibility of D dimer is this patient, that is pulmonary embolism. If you do if you do ECG, what you will find? Most common ECG finding is tachycardia. What kind of tachycardia? Sinus tachycardia. No fibrillation, no flutter, just normal rhythm, but the rate is increased. But if they say characteristic ECG finding, there is a finding known as S1Q3 T3 pattern. S1Q3 T3 pattern. S1Q3 pattern is also known as McGinn-White sign. McGinn-White sign. McGinn-White sign. Good. Many of you have done it well. S1Q3 क्या होता है? There is a abnormal S wave in lead 1. There is abnormal Q wave in 3 and inverted T wave in lead 3. That is called as S1Q3T3 pattern. ये कैसा दिखता है? This is something I will show the photograph tomorrow also. And this is something I have discussed in my detailed videos. They are there on my YouTube channel link I showed. So you can go through it. I think video number 2 or video number 3, I have discussed the pattern. How does it look like? Because it's a rapid revision we are doing, ultra rapid revision. So just remember S1Q3T3 pattern. And examiner will give you other clues also along with the ECG strip if they put up a question. What will you find on chest X-ray in these patients? Now, chest X-ray, look at this. 3 chest X-ray findings are important. Look at the first finding. Can you see in this patient, this consolidation has happened. It is a wedge-shaped demarcated area which has formed. This is called as Hampton's hump. Right? So what are the 3 signs? There will be Hampton's hump. This patient is having Hampton's hump. Hampton's hump. There will be a wedge-shaped demarcated consolidation in one of the segments of the lungs. Second will be watermark sign. Watermark sign. What will watermark sign show? Watermark sign indicates in the local area, the blood vessels will be less prominent. It is difficult to identify. You can just remember theoretically focal leukemia. And third will be Palas sign. Palas sign. What is Palas sign? There will be enlarged descending right pulmonary artery. Enlarged descending right pulmonary artery. So in this photograph, this is a very characteristic photograph. You can see a hump present. This is Hampton's hump, which is present in this patient. Hampton's hump is present in this patient, right? Now, what will echocardiography show? Now, echocardiography shows a sign known as McConnell sign. But many people do not understand what is the meaning of McConnell sign. If the examiner writes in explanation, you will not be able to know that this was McConnell sign which is being taught. So when you do echocardiography, you will find that there is a right ventricular dysfunction. What kind of right ventricular dysfunction? You will find that there will be increased cardiac motion at apex of right ventricle, but decreased or absent motion in mid wall of the right ventricle. This abnormal motion of right ventricle is called as McConnell sign. And this is a feature of pulmonary thromboembolism. But what is the investigation of choice? Investigation of choice in none of these. It is CT, pulmonary angiography. It is also known as CT angiography or CTPA. CT pulmonary angiography. It is a one-liner question already asked in December 21. There was another question asked in 2023 exam of FMG. I'm writing it here. Which is the investigation of choice to locate origin of thrombus in embolism? Then they are not asking to find the cause embolism. They are asking you to find the location. And for that, you need to do ultrasound Doppler study. You need to do ultrasound Doppler study. So ultrasound Doppler will be needed in these patients to locate the origin of thrombus in embolism. You can just write. As you can see, I'm spending more time. The place where I'm spending more time, more chances of, more important, more chances of getting asked. If you just do the one-liners, I would not, be content, because who knows, the things we read leave maybe at least the important things we have to know. And gold standard investigation will be angiography. Gold standard investigation will be angiography. Now, what is the treatment that we do? Treatment is very simple. If examiner says that there is a pulmonary embolism patient where there is a small embolism or submassive embolism and there is normal BP, there is no hypotension, in these patients, you will start the patient on low molecular weight heparins. For example, is a drug known as enoxaparin. Subcutaneously, you can start enoxaparin in these patients. But if there is a massive, there are radiological criteria for that, and there are angiographic criteria for that. So they will mention it, massive is there. Massive pulmonary embolism, or the systolic BP in patient is less than 90 millimeters of mercury. Hypotension is happening. In these patients, you have to do thrombolysis. Good. Good. I'm very happy most of you are answering very nicely. Thrombolysis will be done. And what agent will be used? Alteplase is the agent you will be using. And after thrombolysis, you will be putting the patient back on low molecular weight heparin. And thrombolysis has to be done within 12 hours of the onset of illness. Within 12 hours of the onset of illness. And finally, how can you do prophylaxis or prevention? Prophylaxis can be done by, in a high risk patient, risk factors we have done, compression stockings should be used along with low dose conventional heparin can be added in these patients. This is useful for prophylaxis. Let us solve an FMG MCQ. 60-year-old bedridden patient develops sudden onset breathlessness and acute chest pain. What is the best investigation to make diagnosis? Bedridden patient, old age, sudden onset breathlessness, chest pain. It is not pneumothorax. It is not pleural effusion. It is not asthma exacerbation. What is the likely possibility? Acute pulmonary embolism. What? They are not saying screening investigation. Best to do make the diagnosis. They are saying best to make the diagnosis. CT pulmonary angiography, which is used. Warfarin is used in high risk patients, not in low risk patients. If there is a previous history of pulmonary embolism, then warfarin can be used. Warfarin has a problem of bleeding. It is a more, kind of unsafe agent when bleeding tendencies are there, particularly in old age. So, see pulmonary angiography. Can we do thrombolysis till 14? See, thrombolysis later on can be done, but the efficacy is best within 12 hours. Best is done within 12 hours of onset. Late stage, beyond 14 days, I don't think there is a role of. You can put IVC fillers. In some patients, you can consider plus minus IVC fillers also. Sorry, IVC filters. IVC filters can also be used for prophylaxis in case there is already a thromboembolism space which has been created. So, as I promised to all of you, we have done with almost 28 pages. More than one third of the things have been done. GI, hepat, they will take less time. These are the tricky part. Pulmonology has slightly more weightage than GI, hepat. So I have spent more time in this. Let's take a very small break, 10 minutes break. So we will mark as the answer. Before break, have a 081 which is thinking option D. Please have a look. Thank you. Okay, Sheikh Abdullah, I will have a look at it. So let's take a break. It's break time. I'm just turning off my screen. We will join shortly. Uh, yes, I will take him at tomorrow. Brief summary, I will take him at tomorrow. We will be doing tomorrow. Let us join in sometime. What is the time now? It is 7:54 in my watch. Can we start at 8:10? 8:10. Let me know in the comments. 8:10. Does it work? Yes, no. Everyone has run away. 8:10 will be 15-minute break only. Okay. Let's meet at 8:10. Okay. Okay. Thank you. I'm not turning it off. You can join from here only. I'm just turning off the screen. I'll also some get some water and some tea. Am I audible and visible, everyone? Should we start? Sensible Munda, I already replied to you. I have no idea about it. I know about myself. I don't know about sir. You can message to sir and ask about it. Hai. Okay, let us start. Okay, so let us start with the next case scenario. The case scenario is very important, and for some unknown reason, this topic has become relevant in all the exams, including the recent exam. There was a question, January 25 this year, there was a question asked on this topic, and similar questions have been asked, scenarios have been asked in the NEET PG exam as well. So the case scenario says, now look at the buzzwords, look at the keywords. There is progressive shortness of breath. It is not like sudden onset. It has started, it has a subacute kind of onset, but it is increasing. There is parasternal heave. Now, parasternal heave means there is likely right ventricle involvement that tends to produce a right-sided parasternal heave. It is more prominent on the right side. Loud S2, which is due to loud pulmonary component, plus minus right-sided S3, S4, plus minus features of congestive cardiac failure like hepatomegaly or raised JVP. What is the likely diagnosis? If there is a loud second heart sound, parasternal heave, shortness of breath, and right-sided sounds are abnormal, the likely diagnosis in the patient is PAH. What is PAH? Pulmonary arterial hypertension. It is not core pulmonale, pulmonary arterial hypertension. See, cor pulmonale is a consequence of it. Cor pulmonale, we will be talking about it tomorrow when we discuss cardiology. You need to understand cor pulmonale and PAH are related, but they are not the same. They are related, I repeat, but they are not the same. What is cor pulmonale? We will discuss tomorrow. So pulmonary arterial hypertension. Now, whenever you have a pulmonary arterial hypertension, we need to do a quick review, short review of this topic because some new drugs are also added in the Harrison 22nd edition. So what is PAH? First of all, the definition says that we calculate the mean pulmonary artery pressure. Mean pulmonary artery pressure, it is also written as small m PP. If it is more than 20 millimeters of mercury, that is said to be pulmonary arterial hypertension. Earlier, it used to be more than 25, but now the cutoff used in Harrison, it was changed in the last Harrison itself, it is more than 20. There are broadly speaking two types of PAH. You can have pre-capillary causes and you can have post-capillary causes. Pre-capillary causes, the identifying factor of them, examiner will use the word transpulmonary gradient. There is a gradient we calculate on catheterization. The transpulmonary gradient will be more than 12 millimeters of mercury. That is precapillary PAH. It is typically seen in patients who are having idiopathic pulmonary hypertension. And most common cause of idiopathic pulmonary hypertension is gene mutation known as BMPR2 gene mutation. This gene mutation has been asked in the INI set exam already. BMPR2 gene mutation. Second is post-capillary PAH, where the transpulmonary gradient is less than 12 millimeters of mercury. And the cause of this will be typically seen in patients with mitral stenosis as well as patients with left ventricle failure. Due to back pressure changes, post-capillary PAH will be produced. These causes, you need to remember, these causes are important and they are asked in the exam. Mitral stenosis is one of the favorite of FMG examiner, and we will be discussing this topic in detail tomorrow. It was asked in the July 25, it was asked in January 25, and it was asked in January 24 as well. So there is a good possibility you may get something on this tomorrow. We will be discussing it in details tomorrow. So remember, mitral stenosis is a common cause of pulmonary arterial hypertension, but it causes back pressure changes and so it causes post-capillary PAH. What happens to DLCO in these patients? DLCO in these patients will be reduced. What is the treatment that we are going to do in pulmonary arterial hypertension? Now, first of all, we have the first line therapy. Wherever you possible, you have to treat the underlying cause. Treat the underlying cause if there is a treatable cause. You will start with drug therapy. When you start with drug therapy, what are the agents which are approved for use? We have the first line agent. There are two first line agents which are available. First of all, we have the endothelin receptor antagonists. Endothelin receptor antagonists. Two varieties, two types of drugs are available. We have bosentan, which is a non-selective endothelin receptor antagonist. It blocks both the endothelin receptor A as well as endothelin receptor B. And the second one is ambrisentan. Ambrisentan is a selective ETA blocker. It has less side effects and it is more specific for PAH patients. So two of these drugs are approved for use. Second class of drugs, they are very popular, easily available. You must have heard the name phosphodiesterase 5 inhibitors. Now, this is also your pharmacology integration which is happening. So, PDE5 inhibitors, which are approved for use. One of them is a drug famous for its use in uh, male erectile dysfunction, sildenafil. Another long form of that, which is actually preferred these days, is taldalafil. Taldalafil. So sildenafil or taldalafil are the agents. Sorry, tadalafil are the agents which are used in as first line therapy. Can they be combined? They can be combined, but the problem is there is a possibility of fall in BP and there is a possibility of increased flushing happening. But many patients, you can combine them. In fact, some trials have shown that combining them reduces the overall mortality. If the first line agents fail, then you can go for second line agents. And the second line agent is prostanoid agent known as IV. IV agent we use, intravenous form of epoprostenol. Epoprostenol can be used. It is a prostacyclin, derivative. It is a pulmonary vasodilator and tends to reduce the pulmonary hypertension in the patient. Then we have the newer class of drugs which are available. What are the new drugs which have been approved for use? There is another, big set of list of drugs. In fact, there are total about 12 to 13 drugs which can be used in selected patients, but not all of them are available in our country as well. So there are two new drugs that we need to know. First of all, we have a prostaglandin I2 binder and activator of prostaglandin I2, that is selexipag. Selexipag. This is a new drug. And second is activin signal blocker. Activin signal is involved in producing thickness of the pulmonary vessel. If you can block that signal, the pulmonary pressure tends to fall. So activin signal blocker, sotatercept. Sotatercept can be used in these patients. So what are the five agents that you need to remember from exam perspective? Bosentan, ambrisentan, sildenafil or taldalafil, epoprostenol, selexipag, and sotatercept. It will be a bit tricky when you read it initially. That is why I said you have to read it multiple times. But if you read it 3, 4 times after and you do revision of that, eventually drug will be written there. All you need to do is identify and mark in the exam. So it is not going to be a theory paper. It is going to be an MCQ exam. So you just need to mark. Now have a look at the question and tell me the answer. FMG January 25 question. Female patient presented with progressive shortness of breath, raised JVP, palpable liver. There is a systolic murmur and loud P2. So progressive shortness of breath, loud P2 and raised JVP, palpable liver. Everything is fitting into which diagnosis? The patient is having a diagnosis of pulmonary arterial hypertension. Pulmonary arterial hypertension. Let us move further. No, calcium channel blockers are no longer favored agents in PAH. They are no longer used. Side effects outweigh the benefit. Moving further, we have some scenarios from the recent exam. Look at the word. Examiner will say Homan sign. ECG changes, sudden onset of shortness of breath. What is the diagnosis? Deliberately, I have not put this scenario in the topic. So read and tell me the answer. Read and tell me the answer. Homan sign. What is Homan sign? When you press the calf muscle and you try to push the dorsally, when you press the calf muscle, push the foot of the patient dorsally, there is pain. That is called as Homan sign. Homan sign indicates deep vein thrombus. So Homan sign is an indicator of DVT. Plus ECG changes are there and sudden onset shortness of breath. What is the likely diagnosis? You know the answer. It is not a shortness of breath will not occur in DVT. The likely diagnosis is pulmonary embolism. And that is the answer. Homan sign indicates DVT is there, and now DVT is causing shortness of breath. That is pulmonary embolism. DVT itself will never cause shortness of breath, right? So pulmonary embolism is your answer. Good. Many of you answering it correctly. Then, if the examiner says this was the question asked this year, July 25, petechiae sudden onset shortness of breath after fracture shaft of femur or road traffic accident. It is an orthopedic problem, what you call as fat embolism. Fat embolism. So don't confuse fat embolism with pulmonary embolism. Both of them are scenarios and both of them are frequently asked in the exam. Now, few words about primary ciliary dyskinesia. Primary ciliary dyskinesia is also known as Carter-Jenner syndrome. There is a triad of Carter-Jenner syndrome. What are the three things? Number one, these patients have situs inversus. Complete ulta ho jata hai. Normally, liver is on the right side, spleen is on the left side. This reverses, that is situs inversus. Plus, these patients have sinusitis. It is not one attack, it is recurrent attacks or chronic sinusitis. And thirdly, patient will have bronchiectasis. So three things occurring together: sinus inversus, chronic sinusitis, bronchiectasis. That is the triad of primary ciliary dyskinesia, also called as Carter-Jenner syndrome. And what is the defect? The defect is seen, I'm putting an MCQ point, dynein arms. There is a dynein protein which is present in the arm of cilia. That is where the defect is. So dynein arm of cilia is the site of defect. And because cilia are defective, they cannot move properly. This condition is also known as immotile cilia syndrome. It is also known as immotile cilia syndrome. Immotile cilia syndrome. And also remember that Carter-Jenner syndrome is more severe in males. More severity is seen in males. And because cilia is absent, these patients will have infertility as well. Infertility tends to occur in the males. Immotile cilia lead to reduced motility of the sperms in these patients, right? So this is few words regarding the topic of Carter-Jenner syndrome. Then, what are the three common types of ILD? Actually, ILD has it's a multiverse of its own. It has multiple types of diseases. We will not go into the details. Silicosis, asbestosis, then the rare other forms. They are all types of ILDs only. But here we are talking about three ILDs on which one-liner questions are asked in the exam. So three common types of ILD you should distinguish. One is idiopathic pulmonary fibrosis. Second is ILD seen in Sjogren syndrome or scleroderma. It is seen not only with Sjogren syndrome, you would write and scleroderma. Sjogren syndrome and scleroderma. And third will be ILD, which is also called as Hammond-Rich syndrome. So idiopathic pulmonary fibrosis, when you do biopsy of the lungs, you find a pattern known as UIP. What is the full form of UIP? UIP stands for usual interstitial pneumonitis. The treatment response in these patients is variable. They may improve with steroid, they may not improve with steroids. Second is ILD associated with Sjogren syndrome and scleroderma. That is ILD which is associated with connective tissue disorder. That when you do biopsy in these patients, it shows NSIP. What's NSIP? The full form of NSIP is non-specific interstitial pneumonia, also called as non-specific interstitial pneumonitis. Non-specific interstitial pneumonitis. And these patients, the drug of choice is steroids. Plus, there is a new anti-fibrotic agent. It is commercially useful. And one of my relatives, there is a relative of mine, She got COVID, and then post COVID, she got fibrosis. And we started a drug in that lady, that relative of mine, and she actually improved after 6 months. And it is a uh, antifibrotic agent, slightly costly, but oral form it is available. It is nintedanib. Nintedanib is useful in patients. It's an antifibrotic agent useful in post-infection or post-connective tissue disorder, ILD, particularly if it is showing NSIP. So nintedanib is a pharmacology integration with medicine. And third is your Hamann-Rich syndrome. LIP can also occur. See, LIP can occur in Sjogren syndrome, but the more common ILD in connective tissue disorder in is NSIP. More on this we will talk when we talk about connective tissue disorder. Now, biopsy shows Hamann-Rich syndrome shows acute interstitial pneumonitis. Acute interstitial pneumonitis. And acute interstitial pneumonitis is one condition which has a rapid, acute, fulminant course. And this is the variety which has a high mortality. So highest mortality in acute presentation is seen in AIP patients. So these are the three types of ILDs on which MCQs are asked. So we are discussing them here. Let us move further and move into a topic which is one of the favorites again for FMG examiners. Examiner will make a case scenario. They will say either a smoker or a non-smoker. So smoking history is plus, but it is not mandatory. So fever and hemopsis. Hemopsis means there is blood in the sputum. Weight loss is there, loss of appetite. Whenever weight loss and appetite loss happens, you should think of something chronic, and malignancy should be a DD. Chest X-ray shows either mediastinal widening or collapse of the lungs. Collapse of the lungs. What is the likely diagnosis? Patient is suffering from carcinoma of the lung. Carcinoma of the lung is also known as bronchogenic carcinoma. It is also known as oncogenic carcinoma. Now, it's an important topic. So just like we spent some time talking about pulmonary hypertension, similarly, we will be spending some time talking about this disease. And we will do it in a high yielding manner, so you can revise it also. So if you have done, I'm changing it. What are the types of lung cancers? Now, broadly speaking, there are four varieties, but there is a classification of that as well. First variety is small cell cancer of the lung, SCLC. Small cell cancer of the lung is also known as oat cell carcinoma. So when they say oat cell carcinoma, some people are still fond of using the word oat cell, but the new nomenclature says the term oat cell should not be used. It is just a variant of small cell cancer only. So they are identical. So small cell cancer, also called as oat cell cancer of the lung. This is not very common. This comprises just about 15 to 25% of all lung cancers, but it is an aggressive tumor. And these patients have early brain metastasis. See, most of the lung cancers will metastasize to liver, which is the variety which metastasizes to brain commonly. It is a Robbins related MCQ point, and it's a pathology MCQ, small cell cancer of the lung. Second category are the non-small cell cancer of the lungs. It includes three varieties. You have squamous cell carcinoma, you have adenocarcinoma, and you have large cell carcinoma. Large cell carcinoma. Squamous cell carcinoma as well as no, small cell carcinoma both tend to occur in smokers, whereas adenocarcinoma is the one which is associated with a non-smoker. So if they say what is the most common tumor or brain or most common lung tumor, lung cancer in non-smokers, it is adenocarcinoma. This is the variety which is associated with asbestosis as well. Asbestosis is associated with increased risk of developing adenocarcinoma. It does not occur in the hilum, it tends to occur more in the peripheral region. Now, let us discuss the three common varieties. Large cell carcinoma will never be asked. It is more of a diagnosis of exclusion. So they will be asking you to distinguish between these three. They will be making a case scenario out of it and asking you what is the likely diagnosis. So let us go one by one. Small cancer of the lung. This is central in origin, central in location. Central means it occurs in hilum. Squamous cell carcinoma is also central, tends to occur in hilum, whereas
Adenocarcinoma tends to occur in the peripheries. What is the frequency? As I said, it's seen in about 15 to 20% of the patients. Squamous cell carcinoma is second most common worldwide. This is the most common type in India, unfortunately. Adenocarcinoma is the most common worldwide. Most common type worldwide as well as overall, if they mention and the word India is not there, the answer will be adenocarcinoma. Okay. Then what is the gender predilection? Small cell carcinoma, males are more commonly affected than female. Squamous cell carcinoma, males more commonly affected than female. Adenocarcinoma, females more commonly affected than males. Okay, so it's a stupid way to remember, but remember that both the cancers which are strongly associated with smoking are more common in male. You can remember like this: males smoke more. So males have small cell carcinoma more, squamous cell carcinoma more. Females, they smoke less, and females are, they are found on the periphery of the patriarchal society. So females are more commonly affected than males in adenocarcinoma. It's a stupid way, but at the end of the day, you need these generalizations to make you remember in the exam. Now, smoking association, strong association here, strong association here, but it is absent in case of adenocarcinoma. What about the markers? When you do histological staining, small cell cancer of lung will have markers like chromogranin, which is positive, synaptophysin, which is positive, and plus minus NSE may be there. NSE is plus minus. What is NSE? Non-specific enolase. These are, now this is pathology integration, very, very important. Pathology integration happening. Squamous cell carcinoma will be having cytokeratin. Keratin is always present in the squamous cells, right? Yes, Horner syndrome tends to occur in adenocarcinoma. Yes. So chromogranin is also known as chromogranin A. Chromogranin has multiple subtypes. A and B are the two common subtypes. So chromogranin A positivity is small cell cancer. You can write chromogranin A. Cytokeratin will be positive here. These patients will be having positivity for P40, P63, as well as P65 positivity. These are the tumor markers of squamous cell carcinoma of the lung. Adenocarcinoma, unfortunately, does not have many tumor markers. So most of them are having TTF1 positivity. TTF1 positivity. TTF1 stands for thyroid transcription factor number 1. Details I will not ask you. Now, moving over, what will you find on microscopy? Small cell carcinoma, you will find small malignant cells. First of all, this size of the cells will be small. They will have increased basophilic staining. Increased basophilic staining, especially in the endothelium of the vessels, in endothelial region. Endothelial region. And this effect is called as Azopardi effect. Azopardi effect. Azopardi effect. Squamous cell cancers will be having keratin pearl formation. So keratin pearl formation, and they will have whorl formation. Whorl means ऐसा ring वो बन जाता है fibrosis और keratin material का ऐसा whorl बन जाता है. Whorl is something like this. This is called as a whorl. So whorl formation will be common in squamous cell cancers. Whereas in adenocarcinoma, there will be butterfly pattern. So सबसे beautiful looking, not for the patient, but for the pathologist is adenocarcinoma, butterfly pattern. It is also known as lepidic pattern. Butterflies जो होती हैं उनकी family का नाम ही Lepidoptera है. Ptera is not the right way to pronounce it, but I'm writing like this, saying like this so that you can remember it better. It is actually called as Lepidoptera. बट पी वर्ड साइलेंट होता है तो हम लोग ऐसे प्रोनाउंसिएशन में लेपिडोप्टेरा कहते हैं उसको. सो लेपिडोप्टेरा इज द technically speaking, Lepidoptera is the genus of butterfly. So this is also called as lepidic pattern, beautiful butterfly pattern, right? Then which is the variety which is strongly associated with Horner syndrome? It is minus, it is minus, it is strongly present. And Horner syndrome patient will have all the features like ptosis, meiosis, anhidrosis, etc., along with loss of ciliospinal reflex. It is something you have read in anatomy and surgery also. Which is the variety which is associated with squamous cell carcinoma? It is adenocarcinoma, which is associated. Now, paraneoplastic syndromes, you need to remember they are rare in adenocarcinoma. They are common in squamous cell carcinoma. They are common in squamous cell carcinoma. They are rare in adenocarcinoma. In small cell cancer, the most common paraneoplastic syndrome is SIADH. SIADH. What is SIADH? Syndrome of inappropriate antidiuretic hormone synthesis. Second most common, they can also have Cushing syndrome. In case of squamous cell carcinoma, the most common paraneoplastic syndrome is hypercalcemia. Why hypercalcemia? Because these patients have increased PTHRP peptide formation. Parathyroid hormone related peptide. It works like parathyroid hormone, it is not the same. So it causes hypercalcemia. And adenocarcinoma generally does not have paraneoplastic syndrome. About 10 to 20% patients, however, 10 to 20% patients may have migratory thrombophlebitis. They may have migratory thrombophlebitis. Migratory thrombophlebitis is also known as Trousseau phenomena or Trousseau's disease. So migratory thrombophlebitis, it is not considered to be a true paraneoplastic syndrome, but it can occur in patients with adenocarcinoma. So these are the important summary, and this summary covers, let me tell you, this summary which I have just written, it covers every single MCQ asked on these distinguishing tumors in all the exams of FMG and NEET PG and most of the recent INSET also. It's a very important table. Mark it. You are supposed to go through it in the last week when you are doing revision, right? Go through it. It's a very important table. So I've written slowly while explaining. Now have a look at the FMG July 25 question and tell me the answer. A patient presented with cough and progressive weight loss since past 3 months. Biopsy of lung mass revealed chromogranin and synaptophysin positivity. What is the likely paraneoplastic syndrome? First, you need to make the diagnosis. Cough, progressive weight loss, and lung mass. So it is likely cancer. Which cancer? Small cell cancer. And small cell, what is the most common paraneoplastic syndrome? You tell me the answer. Yes, SIADH. Absolutely right. SIADH is your likely answer. So SIADH is the possibility. Okay. Look at the next question. FMG January 25. Chronic smoker presented with progressive shortness of breath. Spirometry revealed FeV1 of 60% and FeV1 by FVC of 0.6. It is less than normal. So what is the possibility that we are thinking of? ILD, silicosis, and DIP, they all belong to the same category. They are all restrictive lung diseases. This is a patient with low FEV1 by FVC. So likely answer in the question is C, that is COPD. Question looks easy if you have done the topic. If you have done it superficially or don't have the precision, the same topic becomes tough. Although the topic, the disease is done, but there are a few points. Let us write a few points because it is a topic which is pediatric but also asked in medicine occasionally. Let us write down a few points related to cystic fibrosis. Cystic fibrosis. What is the dyad of cystic fibrosis? Dyad means two things which occur together. दो चीजें जो एक साथ होती. First of all, these patients have recurrent pneumonia. And second, these patients have malabsorption. Particularly, malabsorption is seen. What is the gene of cystic fibrosis? CFTR gene, which is present on long arm of chromosome 7. So it is present on chromosome 7q. CFTR gene codes for a epithelial chloride channel. Chloride. What is the most common mutation which is seen in cystic fibrosis? It is delta F508 mutation. It is also written as phenylalanine 508 deletion, means there is deletion of phenylalanine residue on the 508 position. There is another name of this. This is called as class 2 mutation. So for future exam, you can remember the alternative names. If they ask second most common mutation, the answer is G551D. What is the screening test of choice? Screening test of choice. The screening test in these patients, sweat chloride test. Yes, absolutely right. I can make out that most of you have done this topic well. If the value is, if chloride level is equal to or more than 60 milliequivalent per liter, that is considered to be a positive test. But if they say screening test in neonate, you cannot do sweat chloride test in a newborn. You will do a blood test for IRT, which will be elevated. IRT is a abnormal form of trypsinogen which circulates in the blood of these patients. So immunoreactive trypsinogen will be your answer. In patients of cystic fibrosis, what is the cause of infertility? Infertility is more common in males compared to females. It is CAVD. What is CAVD? CAVD stands for congenital absence of vas deferens. Congenital absence of vas deferens. It is just summary we are doing. I'm quite sure you have read about it in pediatrics already. If not, you are supposed to read. So congenital absence of vas deferens. Then in these patients, what happens to chloride secretion? Remember, it's a ionized set MCQ. In respiratory tract, GIT, and pancreas, the chloride secretion is decreased, whereas in sweat gland, the chloride secretion is increased. This is the MCQ recently asked in one of the ionized set exam. And what is the new class of agents which are available? The new agents which are available are CFTR modulators. CFTR modulators are the new class of agents which are approved for use in these patients. You have CFTR potentiators. The typical example is ivacaftor. And we have CFTR correctors. The example for this is lumacaftor, tazacaftor, elexacaftor. This may seem like this is important from MCQ point of view. It's the integration between pediatrics, medicine, and pharmacology. So if I zoom out, it's just a few points of cystic fibrosis, but it is important that you revise these points. Almost 70% of the points I have wrote are NEET PG or INISET or FMG actual previous year questions. I've just, put them up in the form of a condition. See, pancreatitis is not common. It is more like a subacute or low-grade pancreatitis which occurs in these patients. This is the one which is responsible for eventually malabsorption, and in long-standing cases, diabetes can also occur in the patient. But predominantly, the cause of death is always pneumonia in cystic fibrosis. Right? So, dear friends, we are done with respiratory system. Now, the GIT and hepatology part is relatively easy. It will be more scenario-based approach we will be taking, and there will be a lot of integration happening with the surgery part. So, I will not talk about the surgical details, but I will try to talk what bare minimum I feel you should know about the topic. Let us start with GIT. We'll be starting with esophagus first of all. So esophageal disorders, what is dysphagia? First thing, approach to dysphagia. There is a flow chart we have to make, and this flow chart is very, very important. A lot of questions are asked from this flow chart. Dysphagia, one liner, it is considered the hallmark of esophageal disorders. So if somebody says, what is the hallmark of esophageal disease? It is dysphagia. What is dysphagia? Difficulty in swallowing is called as dysphagia. Suppose you are sitting in a OPD. Patient comes to you and he says, I am having difficulty in swallowing. You ask him, is it difficulty in swallowing or is it pain in swallowing? Patient says, no pain, only difficulty in swallowing. So he has dysphagia. If pain is there, that is called as odynophagia. So dysphagia, if it is there, you will ask the patient again, is it to solids or is it to both solid and liquid? Patient says only to solid. So if there is dysphagia only to solids, the patient is having a structural cause of dysphagia. The patient is having a structural cause. A structure is there which is obstructing and causing dysphagia.
If the patient says both solids and liquids, I am having dysphagia, that will be motility cause of dysphagia. Motility cause of dysphagia. How structural cause causes dysphagia, motility cause causes dysphagia. This is something we have discussed in our face-to-face classes. In many of the Arise centers, I have discussed that. But unfortunately, neither do we have the time or the luxury of discussing the details. So simply remember dysphagia to solids alone, structural cause, dysphagia to solids as well as liquids, motility cause. Then if it is structural cause, you ask the patient, when does it happen? Patient says occasionally, कभी कभी होता है. उतना ही है कई सालों से. It is not increasing. So then you are dealing with benign disorders, structural disorders. Two possibility. First possibility, patient is having Zenker diverticulum. And second possibility, patient is having a ring known as Schatzki's ring. Schatzki's ring. If the patient says बढ़ता जा रहा है, patient is more than 60 years and there is significant weight loss present, the patient is likely to have carcinoma malignancy, carcinoma of esophagus, also called as esophageal cancer. If there is dysphagia to solid and liquid, regurgitation, GERD is present prominently all the time. Patient कहता है हर वक्त मुझे खाना ऊपर की तरफ आता फील होता है. Retrosternal chest pain is there mimicking angina. Patient has achalasia cardia. The likely diagnosis is achalasia cardia. And if the patient says regurgitation plus minus इतना खट्टा डकार आता है नहीं आता कम आता है बट जब मैं तेजी से खाना खाता हूं तो बहुत छाती में दर्द होता है when I try to eat fast I have pain in my chest. The likely possibility is DES. What is DES? DES was previously called as diffuse esophageal spasm. Now it is called as distal esophageal spasm because it is the distal esophagus which is more affected according to Harrison. पहले इसका नाम था diffuse esophageal spasm. Now it is distal esophageal spasm. Harrison 22nd में this is the change. So by looking at the buzzwords, keywords, and the clinical finding, you can easily reach the correct answer. But we need to know the fine details. Some MCQ practice also we have to do. Let us move towards scenarios for diagnosis. So, first possibility, examiner will say intermittent dysphagia to solid, halitosis. What is halitosis? Bad breath. Bad breath. A clue for all of you. Whenever you have to take a history of bad breath, never ask the patient himself. क्योंकि देखो अगर मुझे हेलिटोसिस है तो मुझे नहीं पता चलेगा. यू अंडरस्टैंड. जिसको बैड ब्रेथ होती है उसको नहीं पता होता है दूसरे को पता होता है. तो ऑलवेज आस्क द स्पाउस और ऑलवेज आस्क द पार्टनर ऑफ द पर्सन हु इज अकम्पनिंग क्या इनको बैड ब्रेथ है. वो बोलेंगे हाँ बहुत. तो पेशेंट विल से नहीं 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 है. Who will you trust? The other person, because our nasal receptors they tend to get accustomed to it. All those close-up and Colgate ads where they do like this, that is nonsense. You cannot come to know halitosis unless your mouth is stinking. Your mouth is really stinking, then to obviously you also will come to know. But generally, low-grade halitosis, it is the patient's attendant who will be telling you. So halitosis. Second thing, globus pharyngeus. It is also known as globus hystericus. There is a sensation of foreign body. Actually नहीं है, लेकिन sensation of foreign body sticking in the throat. That is called as globus pharyngeus. So intermittent dysphagia to solid, bad breath, sensation of things sticking in the throat. Likely diagnosis in the patient. Yes, many of you are answering it correctly. It is Zenker's diverticulum. The likely possibility is zinc diverticulum, also written as ZD. Now, let us do a quick rapid fire review. Zenker's diverticulum is a type of pulsion diverticulum. It's a type of pulsion diverticulum. Pulsion means something which forms due to pressure. Increased pressure inside the esophagus pushes a part of it through a weak area of the muscle. That is called as pulsion diverticulum. It is also known as pseudo-diverticulum. Pseudo-diverticulum means there is no true muscle, only mucosa and submucosa are present. Only mucosa and submucosa. Remember, pseudo-diverticulum is Zenker's diverticulum. But Mickel's diverticulum is true diverticulum because it has mucosa, submucosa, muscularis layer. They all are present. Okay. Now, what is the most common site? Zenker's diverticulum occurs through a triangle known as Killian's triangle. Killian's triangle is a triangular area
present posteriorly in the inferior constrictor muscle. Inferior constrictor muscle. There are two types of muscles which are there. You have the, if this is the neck, if you are seeing posteriorly, you will find that there are oblique fibers, and then you have the horizontal fibers. These fibers are cricopharyngeus fibers, these are the thyropharyngeus fibers, and this triangular space which is present between them, this is called as the Killian's triangle. This is called as the Killian's triangle. And both thyropharyngeus and cricopharyngeus are the uh, two parts of inferior constrictor muscle. This is also an MCQ. Okay, so it occurs most commonly through the Killian's triangle. What is the investigation of choice? You will do barium swallow. And when you do barium swallow, what you will find? You will find outpouching. This is also a spotter image. Can you see posteriorly there is a outpouching pouch formation where barium is going and it is getting located there. This is the typical photograph of Zenker's diverticulum. Remember this. Treatment of choice. There is no medical therapy, surgery. What is the best surgery that we do? According to Harrison, the best surgery is diverticulectomy. You cut the diverticulum and reinforce the cricopharyngeus muscle so that the gap becomes closed. We call it as cricopharyngeal myotomy. Alternative to this, we go through the oral route and pull out the not outside the body but pull out inside the throat only the diverticulum. So we call it as transoral endoscopic marsupialization. Marsupialization. These are the two types of surgeries which can be done in the patient. Yes, various named surgeries have been given to them. Dolman's procedure, cricothyroid, cricopharyngeal myotomy, and so on. So these are the two basic procedures that are mentioned in Harrison from medicine point of view. Surgical details, you can always do from surgery. So when you are reading these topics in surgery, revise the medicine part. When you are revising medicine, revise the surgery part. It will make sure that the topic gets covered because you don't know from where the question is going to be framed. Next question, examiner will say intermittent dysphagia to solid. Barium swallow shows a circular ring or constriction in the distal esophagus at the squamo-columnar junction. Look at this photograph. There is a constriction like this. This also is an MCQ. If you have a presentation like this in the lower esophagus, there is a circular narrowing at squamo-columnar junction. The patient is having the diagnosis of Schatzki's ring. Schatzki's ring. देखो मार्सुपिलाइजेशन का मतलब क्या होता है? You take out a hollow viscous and just evert it and make a knot upon itself. उसको कहते हैं marsupialization. How do I show? Like suppose there is a hollow thing, I take it out, I pull it out, then I evert it, right? I evert it and then occlude the lumen using the structure itself. उसको कहते हैं marsupialization. A term which is better learned when you see it being performed, but you will be doing it, seeing it when you do your internship in surgery. When will you be doing your internship? You will be doing your internship in May 2026. Why? Because exam will happen in January, result will come in last week of January or February, and wait for 2-3 months. Examiners will take their own time, NB takes its own time, but eventually you will all be interns. So fingers crossed, summers 2026, you will be interns. And I will be guiding your juniors and saying the same thing, telling them that I said the same thing to your seniors who are now interns. I've said this. It's all manifestation. It's all doable. 150 questions. मुश्किल नहीं है. Problem क्या होता है? 300 questions. When they come, 50 questions are tough. 1 to 2 questions, every subject, they are unsolvable. We start chasing those topics when actually previous year topics, previous year questions, and integration across these subjects with good MCQ practice is what we are lacking. If you just do that and you're able to catch hold of those words and those tougher topics, you have to identify the pattern. Some topics are always asked. There will always be questions on oral hypoglycemic agents, diuretics in pharmacology, new monoclonal antibody, and probably one question on, pro drug and all. There will generally be one question on the uh, what are these classification of SSRI, SNRI. The only question is, do you remember them precisely or not? Somebody wakes you from sleep, you should know that venlafaxine, whether it is SSRI or it is an SNRI. So that precision is what you should be aiming for. It's not rocket science. Whenever you feel कि कैसे होगा, people worse than you have passed. And when you feel कि नहीं overconfidence आ रहा है, think that pass percentage is less than 20%. Five friends preparing, only one will pass. Remaining four will fail. Right? So it's not tough, but again, it's doable if you just study with a plan and with a focus. More on this, other faculty members, and we'll be talking about it, but this is not the place. This is just a small break I took talking about it so that, you come back into the topic itself. Sometimes you need to, just take some breathing space in between the topics. So Schatzki's ring. What is Schatzki's ring? Intermittent dysphagia to solid, and there is a barium swallow showing a knowing in the lower part. Schatzki's ring is also known as steakhouse syndrome. Steaks are a type of non-vegetarian food. India is a kebab country. Kebabs are more commonly taken, but steaks are more commonly, preferred outside the India. So Shatsky's ring is not very common in India. It is more common in the Western world. And Shatsky's ring is more common in males compared to females, particularly in the age of 50 to 70 years. So it is more commonly in the older population. What is the treatment of Shatsky's ring? Treatment is very simple. Again, no role of medical therapy. You will do endoscopic dilatation, and if it fails, you will go in for surgery. The only good thing about this condition is it is not very common in India. So all examiner will ask you is diagnosis, what will you find, photograph, age, what first line therapy, if it fails, what is to be done, surgery is to be done. Only 4 5 points you need to know. Next which now we have a problematic topic, carcinoma esophagus. How would you the patient present? Old age, progressive dysphagia to solid, significant weight loss by the time patient presents. So patient is having carcinoma esophagus. When you do barium swallow, what will you find? Barium swallow shows, the word is important, irregular filling defect, producing a shouldering sign. Remember this word. People run after rat tail and bird beak. They forget the word irregular. Remember that in esophagus, when you do contrast study, regular defect is benign, irregular defect is malignant. So if they say irregular defect, irregular bird beak, irregular red tail, what should be your diagnosis? Carcinoma esophagus. If they say regular filling defect, if they say regular bird beak, the answer will be benign condition like achalasia cardia. So this word is important and we tend to ignore it. Right? Irregular filling defect. Now, what are the signs which are described? Two types of signs are described. The first sign, if carcinoma esophagus occurs in the middle part of esophagus, it produces an appearance known as apple core appearance, as you can see in this photograph. This is the apple core appearance. Apple core appearance can be seen in carcinoma colorectal also. But in middle esophagus also it can be seen because there will be dilatation above, dilatation below, contrast material and irregularity in between. It is as if somebody has eaten apple only from the circumferential central part. That is apple core appearance. It will be seen in middle one third of the esophagus. And the second variety, distal esophageal cancer, you will have dilatation and then irregular tail-like narrowing. This is called as the rat tail appearance. Rat tail appearance. Rat tail appearance tends to occur in the lower one third of the esophagus. So bird's beak is the word which was originally described for achalasia. But if they use the word irregular bird beak-like appearance, it can be indicative of carcinoma. We often keep running after bird beak rat tail. Let me put it very clear. Listen to me very carefully. If they say bird beak alone, achalasia. Rat tail alone, cancer. But if they use the word regular with any of them, the answer is achalasia. If they use the irregular with any of them, the answer will be cancer. If you just remember this funda, your answers will not go wrong. Unnecessary controversy gets created because we read a lot of random information. This is reliable information given in standard books. Just stick to it, right? So I repeat,
If they simply write bird beak, achalasia. Simply write rat tail, cancer esophagus. Irregular word, cancer. Regular word, benign, like achalasia. Right? There should be no controversy after this. Let's move further. So, what are the types of esophageal cancers? Upper two-third of esophagus, you have the squamous cell carcinoma. Squamous cell carcinoma. Whereas lower one-third, you have adenocarcinoma. What are the risk factors for squamous cell carcinoma? The risk factors include smoking. Another risk factor is alcohol. Another risk factor is betel nut, also known as areca nut, also known as supari chewing, zuba kesari, pan parag, all these things, raj tree. Person eats more, what cancer do they end up with? Squamous cell carcinoma. And excess ingestion of hot liquids. A person says to the vendor, भैया गरम गरम चाय देना उबलती हुई धुआं निकलती हुई. That person is also smoking. He just had alcohol last night and then he takes some Rajri pan masala and tries to eat it. Now, what is the cancer which is surely going to occur in the next 15, 20 years if this continues like this? It is squamous cell carcinoma. Squamous cell carcinoma, because Indians are more prone to have betel nut chewing and excess ingestion of hot liquid. This is the most common type in India. So in India, it is more commonly squamous cell carcinoma. And what are the other risk factors? It can occur in patients with Plummer-Vinson syndrome. You must have read about Plummer-Vinson. You will be reading in ENT also. These patients will have glossitis, esophageal web, anemia, etc. And lastly, it can be associated with chronic achalasia. Chronic achalasia cardia. These are the important risk factors. There are other also, but these are the important ones. Lower one-third, you will have adenocarcinoma, which will be. Now, what are the risk factors for adenocarcinoma of esophagus? It will be associated with obesity, high fat diet. It will be associated with processed food, all this ultra processed food that we eat. And it will be associated with GERD, so gastroesophageal reflux disease, which causes Barrett's esophagus. Which cancer will occur? Adenocarcinoma will occur in the patient. And because obesity, high fat, processed food is more common in the Western world, so United States, UK, what is the most common cancer of esophagus? It's adenocarcinoma. So answer will depend upon what options have been given to you, how the question has been framed for you. And if they ask in general, what is the most common site of cancer? Overall most common site. Overall most common site in the Western world, it is lower esophagus. In India, it is middle one-third of the esophagus. So these are all the points which are overlapping, confusing. We are discussing at one single place. Right, let's move further. See, these are all kind of bland topics, but topics have to be done. The more topics we are covering, the more your revision is happening and more you are moving closer and closer to your goal. Moving to screening investigation. What is the screening investigation in carcinoma esophagus? It is always barium swallow. But if they ask investigation of choice, it will be endoscopy and biopsy. And if they ask you what is the staging investigation, the answer will be EUS. What is EUS? Endoscopic ultrasound. In fact, these are not separate. We put an ultrasound, we put an endoscope, and through that we take biopsy also, and we do ultrasonographic uh, invasion, depth of invasion testing. So it helps in staging of the patient. What is the most common site of distant metastasis? Wrongly given in many of the older editions. It is not lung, it is liver, which is the most common site of distant metastasis. Liver, liver, liver. I repeat, liver. कहाँ भी lung लिखा है, उसको change कर दो, liver है, right? If you read your notes and you find it is written lung, you are supposed to change it. अगला चीज ट्रीटमेंट. फिर मुझे पूछोगे सर उन्होंने ये बताया, मुझे पता है किसने क्या पढ़ा है, तब भी मैं कह रहा हूं लिवर, तो मतलब राइट, आई टेक फुल रिस्पॉन्सिबिलिटी फॉर लिवर. It is the current, because some older books and older videos, there is lung also mentioned at a few places. So liver is answer. There is no doubt about it.
Coming to treatment part. Now, if the patient presents early, if there is early presentation, which is relatively rare, you will have to do surgery. What surgery you will do? You will do esophagectomy. And whenever you do esophagectomy, surgery integration, you will keep a cancer-free margin. You will free a cancer-free margin of equal to or more than 10 centimeter. Remember that when you are doing surgeries of cancer in gut or cancers in the colorectal region, or you do in the stomach, you keep a cancer-free margin of about 5 centimeter there. But in esophagus, you always keep a cancer-free margin of 10 centimeter. It is a NEET PG one-liner question. And if the patient presents late, you need to create a new esophagus afterwards. Late patient, you will have to use chemotherapy along with radiotherapy. The radiotherapy is called as EBRT. What is EBRT? External beam radiotherapy. You will be using external beam radiotherapy. External beam radiotherapy. After the food, after dinner, many of you have become sluggish. And it happens all the time. I've been taking sessions for a long time now. Whenever session is started, people are very active and answering questions, and then slowly the comment section becomes more quiescent. It's okay, I'm not asking you to post more. You are listening to it, you are understanding, and you are adding the points. Some of you only looking at the screen right now, I can see. Make sure that you add these points today or tomorrow only, because if you keep thinking कि मेरे पास है, YouTube पे पड़ा है, बाद में देख लूंगा, बाद में देख लूंगी, बाद कभी नहीं आता. Someday I will do that. Someday means never. Remember this, I repeat, someday means never. I will do it on this day. And if that day comes, you have to do it. किसी दिन करूंगा या करूंगी, वो कभी नहीं आता है. Remember that. So, external beam radiotherapy. Okay, and let's move further. There is a good regime for chemotherapy which is used. What is the currently followed best regime for these patients? Now we are integrating with surgery and pharmacology. फ्लॉट regime. What is फ्लॉट regime? पांच चार चीजें हैं. F से हुआ 5 फ्लोरोयूरासिल. साथ में हुआ L से हुआ ल्यूकोवोरिन. इट इज अ टाइप ऑफ फोलिक एसिड डेरिवेटिव. साथ में हुआ O से oxaliplatin. It is a platinum compound. Earlier we used to use cisplatin, but now Harrison's 22nd edition says oxaliplatin is more efficacious. It is a part of FLOT regime. Plus taxanes. Taxane is a class of drugs. Example of that is docetaxel. Paclitaxel and docetaxel, two drugs are there. So this is the FLOT regime. This is the best regime in these patients. Yes, I know typing distracts. Good. Good. Please continue listening. See, it's not the process. पता क्या है? अभी सुन रहे हो, उसके बाद जब नोट्स बनाते हुए लिखोगे या सुनोगे, पॉज करोगे, वो सेकंड रिवीजन हो जाएगा. सो फॉर नाउ लिसनिंग टू इट इज इंपॉर्टेंट. एंड लेट मी टेल यू अ थिंग. क्रिकेट मैच देखने में मजा आता है. रिजल्ट पता लग गया, हाईलाइट देख रहे हैं, मजा नहीं है. देखते तो हैं हम, लेकिन मजा नहीं है. राइट, लाइव देखने में मजा है. So when you are learning something, it is always better to do it live. If you are busy in something, class is there. Like some of you message that, sir, our class gets over at 8:30, 9. Some of your classes are still ongoing. You are offline students. It's okay. I told them, जब भी खत्म हो जाए, जब फ्री हो जाओ, ज्वाइन कर लेना. पढ़ने का मन नहीं, सुन लेना. So that whatever you are listening, at least passively some information will go inside, right? So, what is the new monoclonal antibody in carcinoma esophagus? It's a Harrison 22nd edition update. Harrison 22nd edition update. So, please zoom in your screen. Okay, as you said, zoomed. So, new monoclonal antibody, there is a monoclonal antibody known as nivolumab. Nivolumab. Nivolumab is a PD-1 analog. PD-1 stands for a programmed death analog. What it does is it activates apoptosis in many it activates apoptosis in many cancer cells, in PD-1 positive cancer cells. तो हम क्या करते हैं? See, in carcinoma esophagus, we first try to see what are the tumors, what are the patients who are PD-1 tumor marker positive? If they're positive and money is available, it's a costly drug, we start nivolumab. It selectively kills only those cells which are cancer containing because they express PD-1 on there. But not every cancer will improve, but those cancers where PD-1 is positive on the cancer cell, it is a very useful monoclonal antibody. You can get a question on this. And lastly, what is the most important prognostic factor in carcinoma esophagus? It is depth of invasion. More is the depth of invasion, more versus the prognosis in carcinoma esophagus. There are other risks like lymph node involvement, distant metastasis, etc., etc. But it is the depth of invasion which is the most important prognostic factor. Nitish Kumar, some of the topics are similar because I am the same person and my videos are same. Some of the things are different. Like for example, all these treatments I have discussed in esophagus. This entire page which I have discussed, it is not there in the my older video which you have seen. So every single information counts, right? Hi doc, I think some of you have joined now. So I hope all of you are doing good. तो जहां से जुड़े हो वहीं से join कर लो. So join from where you have joined. So let us continue next scenario. Next scenario, dysphagia to both solids and liquids. Very, very important. Liquids more than solids in long-standing cases. Regurgitation and heartburn are present. External chest pain mimicking angina is present. What is the likely diagnosis? What is the likely diagnosis? Patient is having achalasia cardia. Achalasia cardia. देखो हम ना मोटिवेशन और भी कर सकते हैं, बातें और भी कर सकते हैं, बहुत सारे स्टूपिड लॉजिक बना सकते हैं, बहुत सारे आई हैव थिंग्स टू डिस्कस विद यू. दोस हु यू हैव अटेंडेड माय फेस टू फेस क्लासेस और लाइव क्लासेस ऑनलाइन, you know I'm very fond of chatting in between, but the problem is exam is too close and medicine is something we cannot take too lightly. It's like an ocean. So I am talking in between, but mostly it is, so that you can grasp the concepts better. More on chit chats, more on strategies and motivation, I will do later on once we connect through some specific session for that, or I come on Instagram. But for now, only hard work and focus that we need. But I'm trying my best to tell you the clinical implications and real life examples where possible. Uh, thank you, Sinistarani, sir. But it's not for us. It's like life saving. See, whether your life gets saved in the actual exam or not, that is not in my hand. I am trying my best. But eventually, देखो आपको टीचर या आपका सीनियर बता सकता है, लड़ाई तो आपको लड़नी है ना. So for now, we have time. So let's prepare well. So dysphagia to solid and liquid, liquid more than solid, and regurgitation, heartburn, chest pain present, achalasia cardia. Now, what is the mechanism of achalasia cardia? It is always a acquired disease. The mechanism is herpes simplex virus 1 infection triggers autoimmune reaction. This autoimmune reaction destroys ganglion cells in esophagus. उससे क्या होता है? When the peristaltic wave comes, the lower esophageal sphincter does not open. I'm putting like this: lower esophageal sphincter fails to relax. Weak waves, weak peristaltic waves, and that is achalasia cardia. Normally क्या होता है? Normally when you eat something, the ganglion cells, the Ayurvedic plexus, mental plexus, they trigger peristalsis, and in response to that peristalsis, the lower esophageal sphincter relaxes. But in these patients, the ganglion cells are destroyed, so the waves which are produced, they are not sufficient to cause a relaxation of LES, and so there is a constricted LES that causes dysphagia, and the proximal esophagus becomes low, it becomes enlarged, it becomes dilated. That is achalasia cardia. When you do barium swallow, you will find a smooth filling defect. You will find smooth filling defect. Smooth filling defect. What about etoposide in esophageal cancer? Uh, Jisna, you need to know that there are many regimes. I hope you know that for any cancer, there is never a single regime. There are multiple regimes which are useful. So there are some regimes which use carboplatin. There are some which use cisplatin. Some which use etoposide with carboplatin. But the best regime, according to Harrison, is what we are writing here. right? So etoposide can be used. It is there in one of the regimes, but it is not a part of the favored regime these days. So barium swallow will produce a smooth filling defect. It is a benign condition. I told you benign conditions will have smooth filling defect, giving rise to bird's beak appearance. Bird's beak's appearance or bird's beak sign in the distal esophagus. What is the investigation of choice or sensitive? See, the barium swallow is only for screening purpose. Investigation of choice will be high resolution manometry. It is high resolution manometry. What is the treatment of achalasia cardia? Treatment has three parts. First of all, you will be using drugs in the patient. Three class of drugs. Any one of the following can be used. Either you can use calcium channel blockers, for example, nifedipine, or you can use phosphodiesterase 5 inhibitors. I'm writing like this PDE5 Is, that is PDE5 inhibitor, for example, sildenafil. Or you can use nitrates, glyceryl trinitrate, isosorbide mononitrate. But drugs का problem क्या है? They have to be taken 1 hour before each meal. Now try to think. Before every meal, you are taking a sildenafil, you are taking nifedipine. They have their own side effects also. They cause fall in BP, flushing, hypotension, or and try to think like this that see so difficult now. It occurs in females, but can occur in males also. Male having sildenafil with every food. It's not logical. Male having or male or female, both of them having nitrates with every meal, BP will fall suddenly. So these drugs are useful, but have a limited role in real world management. So more importantly, these days we go for local therapy. And what is local therapy? We give injection of botulinum toxin. Botulinum toxin, that is Botox injection. Sir, in one of the exam, they gave this image and answer was carcinoma esophagus. That is what I said. I think you missed that point. What did I say? Bird beak and rat tail can occur in either carcinoma esophagus or achalasia cardia. If they mention the word while explaining irregular, the answer will go in favor of cancer. If they are saying regular or they simply say bird beak, nothing mentioned around it, then the answer will be achalasia cardia. Okay, regular versus irregular will make the difference. Otherwise, though, these signs I have they have been described in both of them. So injection of botox, लेकिन botox का effect कितने time तक रहता है? 6 month तक. Money cannot buy happiness, but money can buy botox injection. Botox is not only useful for removing wrinkles, it is also useful for therapy of achalasia cardia. Right, and if all else fails, we go for surgery. The best surgery in these patients is Heller's myotomy. It is also known as LES, lower esophageal sphincter myotomy. And there is a new surgery being done these days. Alternative to this is a surgery known as POEM procedure. POEM procedure. What is POEM procedure? Per oral endoscopic myotomy. We reduce the thickness of the lower esophageal sphincter so the food which is coming by mechanical effect, they can still pass even if it does not relax totally. Right. So this is the treatment. Treatment is important. I have not discussed details of treatment in other things, but here the treatment is important. FMG previous year question: which infection produces achalasia-like illness by causing destruction of the ganglion cells of the myenteric plexus? There is a disease known as Chagas disease, not Chagas, Chagas disease. It is caused by Trypanosoma cruzi. You're welcome, Nitish. I hope these videos help you in crossing the line and then we meet for PG exam preparation. That is what my aim is. We should meet again. In real world, obviously, we can meet. Most welcome. But apart from that, we should meet for NEET PG as teacher student, but not for FMG. Let's finish the game. 17 January. I will wait for your message. Sir, ho gaya. Thank you so much. That message is sufficient. I may not meet you, but that message will, mean a lot to me. Obviously, it will mean a lot to you, but it will mean a lot to me as well. It will, push me for doing more videos for your juniors.
the cycle should continue. A lot of people say, sir, when does the cycle stop? It never stops. You have to decide when, but you can't stop now. You started this when you took up biology in after 10th standard. You have to finish at least by getting that license to practice against your name. After that, it's a choice. So we will decide after that, but before FMG, nothing else. That should be your singular focus with exams approaching. Let's move further. Topic is done. Topic is done. Is this enough for NEET PG? See, NEET PG, I would not be sitting in the exam listening to this. Although it will be good for revision, but end of the day, NEET PG is not qualifying exam. You have to do better than others. So you need to up the game a bit for NEET PG. But here our focus is on FMG exam with a few MCQs and tidbits of NEET NI also, which I am already putting in if you have noticed. Um, if you are preparing for any licensing exam, whether it is in India or the other countries as well, the topics remain the same. Harrison remains the same. So your surgery book, Robbins remain the same, and surgeries Bailey and Love remains the same. So that is where my lecture is based upon. So it will obviously benefit, but you need to see according to your exam that you are giving. So infection which produces echolactic illness, Chagas disease. Let's move further. Easy things are coming your way now. Dysphagia to both solid and liquid. Retrosternal chest pain on eating quickly. Yeah. Have you ever been in that pani puri eating competition? Those stupidities have you done in your life? If you have not, you will still end up doing that. Don't think that that phase is over. So people go into गोलगप्पा eating competition. चार पांच छह खा लेते हैं यहाँ पर फंस जाता है गले में तो ऐसे पेन होता है फिर सडनली ऐसा लगता है मरने लगा हूं दैट इज that is a variant of that. The pathological version of that is DES. What is DES? Distal esophageal spasm. It was previously known as diffuse esophageal spasm. Uh, Kaushik, I will be doing a neuro class tomorrow. I will be doing it tomorrow. And see, okay, never did doesn't mean that you will not do it. Don't think. When I finished my MBBS, I thought that I will never do stupidities and that I have become very mature. I did more stupidities after that. Then when I finished my MD, I thought that my time of doing stupidities is over. I did more stupidities after that, right? The level of stupidity keeps on changing. And now, maybe 2 years, 1 year back, I used to think that now my phase of stupidity is over. I don't know, maybe I am doing more stupidities. So that phase will always come in your life again and again till you actually, go into that saint mode, which none of us are. So distal esophageal spasm, you will do these stupid activities. Just that right now is not the time. So don't do that. What you will end up with? You will end up with barium swallow showing corkscrew esophagus, also called as rosary bead esophagus. This particular photograph is a very, very important point, and it's a spotter image also, which has been asked in the exam. Distal esophageal spasm, also called as diffuse esophageal spasm. Your skincare routine. Two type answers are there. One answer is I eat good food, I stay away from, all caffeine and other things, and I use sunscreen, etc. This is the ideal answer, but the practical answer is it is only good genes. The one good thing I do is I don't smoke. Smoking is the biggest killer of your skin, the collagen, right? Apart from that, genes from my mom and dad. Right. So let's continue with the class. It's not about me, it's about you people. So barium shows what? Corkscrew esophagus or rosary bead esophagus. क्या होता है in patients के अंदर? Due to an unknown reason, it's the cause is unknown. When the patient tries to eat quickly, all different segments of esophagus they contract together, and that produces spasm, pain, and a rosary bead appearance. This is distal esophageal spasm. Unfortunately, the treatment, there is no surgical therapy available for that. Drugs can be tried, but drugs can be tried similar to echalacia. But no specific therapy is available yet in these patients. And what is the differential diagnosis? The differential diagnosis is some which appear similar to this, but it is not same. Jackhammer esophagus. Jackhammer esophagus. It is also known as the nutcracker esophagus. Don't try to read too many details. It is a topic which you will be needing for your INI set exam when you will be preparing. Right? It's not needed for neurology.
पता नहीं ये यूट्यूब वाले नायका के ऐड मुझे क्यों दिखा रहे हैं। भाई नायका का ऐड सब जगह आता है, नायका के सब तरह के प्रोडक्ट्स होते हैं। सो दे आर शोइंग इट टू यू दैट यू वंस यू क्रैक द एग्जाम यू आर सपोज टू बाय इट। Either you will buy it for yourself or you will be buying it for somebody close to you, right? So similar thing. This material is enough for NEET PG. See, this material will make you qualify the exam, but it will not be sufficient because remember, NEET PG you need to do better than others. But here our focus is not NEET PG; it is FMG exam, right? Next question. Examiner will say dysphagia with food impaction. गले में अटकता है खाना. History of atopy, allergies is there. Type 1 hypersensitivity, asthma, food allergy. GERD is there, regurgitation is happening, and biopsy shows this is very, very characteristic. Biopsy shows equal to or more than 15 eosinophils per high power field. What are we looking at? The patient is likely suffering from EOE. What is EOE? Eosinophilic, eosinophilic esophagitis. Eosinophilic esophagitis. One of you just messaged me here on my phone कि सर अब क्लास कब तक खत्म होगा, आज वर्क पूरा हो जाएगा। भाई हो जाएगा, अगर नहीं होगा तो कोई बात नहीं, जहां होंगे वहीं रुक जाएंगे। कल सुबह शाम को क्लास 5 बजे की जगह 4:30 शुरू कर लेंगे। Don't worry. Whatever you are doing, keep on going with the flow. I'm not here to do formality for any of you. I'm here to teach as if I'm teaching the alternate younger version of me. Ki these are the bare minimum things you need to know to have a fighting chance. So eosinophilic esophagitis, dysphagia with food impaction, atopy, GERD will be there, and biopsy will show eosinophils to be high. Kitna eosinophil? 15 or more eosinophil per high power field. When you do barium swallow and when you do endoscopy, this is what you will see. This is the barium swallow finding, and this is your endoscopic finding. Endoscopic finding. Yes, video will be posted in the channel after removing the pause which was there. So it will be posted after just a lag of few hours. It will be posted. Um, we have to finish before 11. Before 11, and there is a reason for that. There are other commitments I have to cater to. So yes, I cannot cover all medicine topics, but I will touch upon all the systems. Okay. So barium swallow and endoscopy, this appearance. Now, normally when you look at the esophagus, it is a smooth tube. It is a smooth tube. There are no hostrations, no rings. When this like appearance appears, this is called as feline esophagus. Feline means cat. कैट के इसोफेगस, बिल्ली के इसोफेगस में रिंग्स होते हैं, सो फेलिन इसोफेगस. इट इज ऑल्सो नोन एज esophageal shiver. It is also known as trachealization of esophagus. Trachealization of esophagus. Trachealization of esophagus. So feline esophagus is typically seen in eosinophilic esophagitis. What is the treatment that you do? GERD is very prominent in these patients, so you need to give PPI. And because it is an allergic reaction, so steroids need to be given. But which steroid is used? Locally acting steroid known as budesonide. This is the first line therapy. This is the first line therapy. But if this first line therapy fails, you go for second line therapy. And the second line agent, according to Harrison, is dupilumab. Dupilumab is not only anti-interleukin 4 or monoclonal antibody, it is also anti-interleukin 13 monoclonal antibody. And because interleukin 4, 5, and 13 are the three interleukins involved in eosinophilic esophagitis, this is efficacious. It's a costly agent, but it produces dramatic recovery. So, 6 monthly infusions may be needed in the patient. Don't write the therapies and drugs and all. Just remember the name of the drug. That is all examiner will be asking. Can you make a dedicated video for ECG? Do you have the time for that? That is the problem. And do I have the time for that? That is the problem. So there are some videos I've already posted on my YouTube channel. You can try out. Stick to the things which have been taught to you by your medicine regular educators, whatever they have taught. In the coming days, the plan is there that I will be posting some ECG videos also. But right now, I don't think it is the time to learn the basics of ECG. It should be revision oriented. Okay. Okay, so the topic is done. Let's come to some one-liners. Easy things and one Harrison update as well. So what is the investigation of choice for GERD? What is the investigation of choice for GERD? Investigation of choice is endoscopy and biopsy. Endoscopy and biopsy. What is the gold standard investigation in GERD? 24-hour esophageal, 24-hour esophageal monitoring, esophageal pH monitoring, 24-hour esophageal pH monitoring. सर जुकाम हो गया तो दवाई लो. कौन सा दवाई? वो दवाई जिससे नींद ना आए. टेक सम. फॉर कंजेशन यू कैन टेक फेक्सोफेनाडिन. दैट्स अ नॉन सेडेटिंग वन. सो डोज वगैरह देख लेना एक बार. एलेग्रा नाम से आता है वो. एंड टेक सम स्टीम. फॉर फीवर यू कैन टेक पैरासिटामोल एसओएस. And honey based syrups like Honitus you can use. But try, and if you feel that fever is persisting, some lymphadenopathy, sore throat, then you can consider antibiotics. But don't try to take cough syrups. They're not good and they will cause a lot of sleep issues as well. So just wait and watch. Trust your immunity. Take some fluids. Symptomatic relief, it should go away. Now coming to treatment of GERD. First of all, first line therapy. First line therapy is always the most difficult thing to do. Lifestyle changes. लाइफस्टाइल चेंज का सबसे मुश्किल काम है. गर्ड हो गया है तो पेशेंट को बोलोगे वेट कंट्रोल करो, डाइटरी चेंजेस करो. क्या डाइटरी चेंजेस? अवॉइड स्पाइसी फूड. उबला खाना खाना है, मसाले नहीं खाने. अवॉइड कैफिनेटेड बेवरेजेस, चाय कॉफी नहीं पीना. अवॉइड कार्बोनेटेड बेवरेजेस, रेड बुल, लिम्का, पेप्सी, कोक नहीं पीना. कहना आसान है, लोग मानते नहीं है. सो फर्स्ट लाइन इज लाइफस्टाइल चेंजेस, बट इट इज वेरी डिफिकल्ट टू फॉर द पेशेंट टू अडियर ऑल्सो. राइट. सेकेंड लाइन थेरेपी. सेकेंड लाइन थेरेपी. सेकेंड लाइन थेरेपी ड्रग्स. नाउ यहां पर आया हैरिसन का अपडेट. न्यू क्लास ऑफ ड्रग. अभी तक आपने क्या पढ़ा? पुराना हैरिसन क्या कहता था? इफ यू लुक एट योर ओन एग्जिस्टिंग नोट्स ऑल्सो, PIs, proton pump inhibitor, are the drug of choice? No. Harrison 22nd edition says there is a new class of drugs known as PCABs. What are PCABs? Potassium competitive acid blockers. According to Harrison, they are the drug of choice and most efficacious drug in GERD these days. Not for peptic ulcer, but for GERD. PCABs, what is the example of this drug? Vonoprazan. वोनोप्राजान. इसके और भी डेरिवेटिव हैं. सबके एंड में प्रजान आता है. तो प्रजान जहां पर भी आ जाए वो क्या है? पोटेशियम कॉम्पिटिटिव एसिड ब्लॉकर. फॉर्चुनेटली और अनफॉर्चुनेटली इंडिया में वोनाप्रजान मिलता है. So it is now available in our country also. So potassium competitive acid blocker are the first line agent. They are irreversible blockers of hydrogen potassium ATPase pump, which is involved in acid production. And they are irreversible, immediately acting. PIs are relatively slow acting. So they are the favored agent. Second line drug after this, if not given in the option, then PPI. And PPI के अंदर भी Harris says new generation PPIs should be preferred. Example of a new generation PPI is tenetoprazole. Tenetoprazole is again irreversible PPI, faster acting PPI. If that is not in the option, then your answer will be H2 blockers like cimetidine, ranitidine, etc. Don't you think it is a topic waiting to be asked as a fresh question in pharmacology or medicine? Yes, it is. Please add it. What is GERD? GERD stands for gastroesophageal reflux disease. Somebody missed, so I've been writing there. GERD का full form होता है gastroesophageal reflux disease. खट्टा डकार ऊपर की तरफ आना खाने का. That is called GERD. Right? We all have experienced it sometime or the other. That is reflux. If reflux is significant, it is causing Barrett's metaplasia. It is causing serious symptoms affecting quality of life. Then we call it as GERD. Simple is reflux. बार बार हो disease करे तो that is GERD. That is the full form of GERD. Right. This second line therapy fails, we go for third line therapy. Third line therapy is surgery. And what is the surgery that we perform in these patients? The surgery done in these patients is Nissan's fundoplication. Nissan's fundoplication. So Nissan's fundoplication is the surgery of choice. Yes, dear friends, we have done with the esophageal disorder. Let time to solve some MCQs. Let's solve some MCQs. I'm changing. You're welcome, Doc. Let's go. Let's move further. Look at FMG January 20. Read the question and give me your answer. Read the question and give me your answer. A, B, C, or D? A middle-aged female presented with difficulty in ingesting liquids more than solids. What is the most likely characteristic finding on barium swallow imaging? Liquids more than solids. Likely, and female patient, it is likely achalasia cardia. एकलेशिया में irregular नहीं होता, कौन सा होता है? Regular filling defect. This was a controversial question when it was asked in January 25. There are many versions of this question across the platforms, but I have my own collection of questions, and this was the question I know that which many of the students who actually sat and cleared also they mentioned it. तो सर डाउट यही हो रहा था कि रैट टेल तो कैंसर में होता है. Regular filling defect is the clinching point. So always watch out for regular filling defect. um, let us focus on the class and let us not compare. At the end of the day, we all are trying to teach the best we can. End of the day, what matters is we are able to understand, number one, and we are able to apply in MCQs or not, right? That is the most important thing. Let us next have a look at the next question. FMG July 23. 55-year-old male with difficulty in swallowing after a few bites of. तो डिफिकल्टी इन स्वेलोविंग का मतलब उसको डिस्फेजिया है, हैलिटोसिस, बैड ब्रेथ हो रहा है, एंड उसको निमोनिया विद कंसोलिडेशन भी हुआ है. निमोनिया क्यों होगा? समथिंग गोइंग इनटू द पाउच which is getting aspirated when he's lying down. So everything fitting into Zenker's diverticulum. What is the type of Zenker's diverticulum? It is a type of pulsion diverticulum. Great, good. Most of you have answered it correctly. The answer is A, pulsion diverticulum. तो पहले वाले का आंसर C, second one the answer is A. You are doing fine. You are understanding well. Let us continue the momentum. Next topic: Mallory-Weistier versus Boerhaave syndrome. How do you distinguish between them? इसके summary करेंगे, सिनेरियो समझेंगे. Listen to the scenario. Scenario is something like this. 17th January, you appear in the paper. Your exam has went fine, but you are not sure. 27th January, your result comes. You were thinking you have done good, but your result is unexpected. You're expecting to pass. You have not just passed. Your score is 236. You will rub your eyes. Am I dreaming or not? It is 236. Call up your family. Immediately, they're so happy. First of all, your mom or dad will tell you, बेटा check कर लो, सही है कि नहीं. आप बोलोगे नहीं सही है, इतना ही है. They will be very happy. You will be happy. Now your friends will ask for party. Now you had promised yourself that if you get 220 plus, you will leave alcohol, right? So because you thought that you can never get it, but now you have got. It is nature's way of telling you, God's way of telling you, leave alcohol. But before you leave, what you will do? Party. Now you go for party. You go to a good nightclub, you get money from home because you're going to leave it afterwards. So what do? You start binge drinking in a very short span of time. Tequila shots, one, two, three, four, five, six. After that, you are doing Nagin dance. Then you are talking nonsense things, calling your ex, random things you are doing. Then you start vomiting. First two vomitings are clear. The third vomiting is having blood in it. It's a painless hematemesis. Now your friends who are parting with you, they are concerned. They are like, oh, ये तो मर जाएगा. Let him take him to emergency. You walk into emergency. You're not brought to emergency. You walk into emergency. You're still vomiting and crying, thinking about your ex. Things people do when they are high, but you are still your hemodynamics are stable. Every time you're vomiting, there is blood in it, but it's painless vomiting. So, what are the buzzwords? What are the keywords? Alcoholic binge drinking with a person of no previous history, followed by vomiting. Few vomitings are normal, then there is painless hematemesis, no shock in the patient, and no significant pain. What is the likely diagnosis? Mallory-Weistier. Many times it stops spontaneously. Sometimes you are given cold fluids followed by PPI injection, wait and watch, settles down. This is Mallory-Weistier, right? I hope you will never forget it now. Or have a syndrome kya hai? You are alcoholic, right? You are not binge drinking, but you are alcoholic.
Chronic alcoholism causes weakness of the muscular layer of esophagus, or you have undergone endoscopy in the past for some reason. So your upper GI is already compromised. Now, due to some reason, you have multiple violent episodes of vomiting, and suddenly there is severe killing chest pain, severe pain. Hematemesis is there, but it is a painful hematemesis, and swelling appears in the neck and chest region. You call it emphysema, subcutaneous emphysema appears, and you lose your consciousness. You don't walk into the emergency, you are brought to an emergency. That is Bohr-Haave syndrome. Transmural rupture of esophagus, pain, and hemodynamic compromise. When you take an X-ray or CT or MRI, you will find air in the mediastinum. We call it as pneumomediastinum. These are the buzzwords which go in favor of Bohr-Haave syndrome. Treatment will not be conservative. Treatment will be urgent laparotomy. Okay. I hope you will never forget it now. Let us write down these words which help you in reaching the answer if you get an MCQ. Right. Mallory-Wistia is more common. Bohr-Haave syndrome is rare. Mallory-Wistia is superficial mucosal tears. Superficial mucosal tears in lower esophagus, particularly near the gastroesophageal junction. Gastroesophageal junction. So what is the learning point from here? Not just Mallory-Wistia and Bohr-Haave, never do binge drinking. Ideally, no drinking, but at least never do binge drinking as well, even if it is for party. So gastroesophageal junction. Another takeaway point, don't do noggin dance. Third takeaway point, never call your ex, even howsoever high you may be. So near gastroesophageal junction. What about Bohr-Haave syndrome? It is transmural. Transmural means throughout the thickness. So transmural rupture of lower esophagus. Transmural rupture of lower esophagus. And it typically occurs in the posterolateral aspect. Posterolateral aspect of esophagus. What are the risk factors? Risk factors for Mallory-Wistia is alcoholic binge drinking. Have you heard the term? Nadeem sir must have taken your class already. Bulimia nervosa. Really seen in adolescent girls, they eat a lot and then they vomit out. So bulimia nervosa is another risk factor. Risk factor here in Bohr-Haave syndrome is alcoholism and recent endoscopy done or instrument inserted into the esophagus. Mallory-Wistia presents with painless hematemesis. Painless hematemesis. These patients have painful hematemesis. These patients also have a triad known as Mackler's triad. What is Mackler's triad? It is a previous year FMG MCQ also. Three things which occur together. There is persistent vomiting, there is severe chest pain, and there is subcutaneous emphysema. Subcutaneous emphysema. What is the investigation of choice here? You will do endoscopy. Investigation of choice here, contrast esophagogram. If that is not possible, you can go for CT also. Yes, CCT of the chest. CCT of the chest as well. What is the treatment here? Conservative. Fails, you go for PPI. Fails, you go for endoscopy. And what is the treatment here? Laparotomy has to be done along with shock management. Shock management. I hope the topic is clear and you have understood it nicely. There are many other signs. See, what we are doing is getting the answer correct or remembering the key points. Each topic
you can expand as much as you want. But do we have the time and do we have the need for this? That is the only thing. You know? So Mallory Wiestier versus Boerhaave syndrome. Let's move further. Now we have summary of malabsorption disorders. Looking at the buzzwords, we have to look at the likely diagnosis, 2 points about it, and the treatment of that. Now, first scenario, how to differentiate esophageal varices with Mallory-Weiss syndrome? Good question. We will be doing it, but Mallory-Weiss is painless, mild to moderate hematemesis. There is no splenomegaly. In portal hypertension associated varices, there will be splenomegaly, there will be chronic alcoholic patient, and there will be massive hematemesis. So mild hematemesis and no splenomegaly, no other thing, and risk factor like alcoholic drinking goes in favor of Mallory-Weiss. On the other hand, chronic alcoholic patient, known liver disease patient, cirrhotic patient, chronic liver disease patient, splenomegaly, massive bleeding, that goes in favor of varices. So, summary of malabsorption disorder. So, onset between 6 months to 2 year. So, starting malabsorption starts in the first 2 years of life, can continue into adulthood. Poor weight gain, anemia, steatorrhea, fatty, bulky, sticky stool. HLA-DQ2 is positive. Sometimes HLA-DQ8 is also positive, but most commonly HLA-DQ2 is positive. What is the likely diagnosis? Patient is suffering from celiac disease, also called as wheat allergy. The technical name for this is gluten sensitive enteropathy. Good. Gluten sensitive enteropathy. It was previously known as celiac sprue. Sprue word is no longer used. What are the associations? It is strongly associated with a skin condition known as dermatitis herpetiformis. It's a skin manifestation of celiac disease, produces vesicles and bullae. It is associated with syndromes. Three syndromes are associated: Down syndrome, Turner syndrome, and Williams syndrome. It is associated with type 1 diabetes mellitus and other autoimmune diseases. It is also associated with selective IgA deficiency. It's a primary immunodeficiency which can occur in association. Associations are important. They have been asked in INI set as well as NEET PG exam. Both of them they have been asked. So you can get a repeat question in FMG as well. What is the screening test? You do the blood test. What is the blood we do? Total IgA level in the blood along with IgA TTG. TTG stands for tissue transglutaminase. If that is not there, you can go for total IgA along with IgA EMA. What is EMA? Endomysial antibody. I'm writing on the side. TTG stands for tissue transglutaminase. Tissue transglutaminase. And it is Hamesha IgA antibody that we check. EMA stands for endomysial antibody. Endomysial antibody. अमन इज आस्किंग फॉर न्यूमोमीडियास्टाइनम, कैन यू एक्सप्लेन? देखो अमन, क्या हो रहा है कि बोर हवा में पूरा का पूरा थिकनेस रप्चर हो रहा है, तो एयर लीक कर जाएगी मीडियास्टाइनम में, उसको कहते हैं न्यूमोमीडियास्टाइनम. यू कैन नॉट क्लिनिकली सी इट, इट इज अ रेडियोलॉजिकल फाइंडिंग इफ द डायग्नोसिस इज इन डाउट. सो एयर कब लीक करेगी? जब पूरा इसोफेगस रप्चर हो. सो न्यूमोमीडियास्टाइनम इज अ फीचर ऑफ बोर हावे सिंड्रोम, इट इज नॉट अ फीचर ऑफ मैलरी वीस्टियर. Right. So ये है आपके antibodies, but what is the investigation choice? Investigation of choice is upper GI endoscopy and biopsy. Upper GI endoscopy and biopsy. Biopsy will show flattening of the villus and inflammation, lymphocytic infiltration in the gut epithelium. What is the treatment that you do in these patients? Lifelong gluten-free diet. If you are allergic to something, you have to avoid that diet. So no wheat-based products, no gluten-containing products. What is the food to use? Rice is safe. Maize is safe. Buckwheat is safe. Buckwheat is not wheat. Quinoa is safe. Sorghum is a millet. It is safe. And chia seeds are safe. Tapioca, also known as sabudana, that is safe. And flax seeds, alsi कहते हैं in North India, that is safe. What is the food to avoid? Bro. Bro should be avoided. What is bro? Barley should be avoided. Rye should be avoided. Oats should be avoided. And wheat should be avoided. All types of wheat, including semolina, suji, whole wheat, they all should be avoided. Dalia. So, bro is to be avoided in these patients. There's something you already know. So, this finishes our first malabsorption disorder summary. We have discussed in more details, more frequently asked, can occur in children, can occur in adults. That is celiac disease. Next question, next scenario. Let us have a look at the next scenario. Let us have a look at the next scenario. इनिशियल आर्थराइटिस फॉर 6 to 12 months. पहले पेशेंट को जब स्टार्ट होगा तो पहले 6 से 12 महीने तक इनिशियल आर्थराइटिस होगा. 12 महीने तक नहीं, 12 साल तक. इसको कट करो, ये मिस्टेक है. इनिशियली आर्थराइटिस विल बी फॉर 6 to 12 years, नॉट मंथ्स. 6 to 12 years. मंथ्स तो मिनिमम होता है, ईयर्स तक एक्सटेंड हो जाता है. फिर malabsorption start hota hai. This is the stage where the patient actually is treatable and comes to medical attention. And intestinal biopsy shows positive inclusions in the gut epithelium. What is the likely diagnosis? Yes, the likely diagnosis is Whipple's disease. So joint involvement, malabsorption, pass positive finding in the gut epithelium, Whipple's disease. It's an infectious disease caused by a bacteria known as Trophima whipplei. Trophima whipplei is the bacteria. It is a gram positive, pass positive, intracellular bacteria. Cell के अंदर रहता है. What are the later complications? Patient can develop CNS complication and CVS complication. CNS complication can be in the form of memory loss and aphasias. And CVS complication can be in the form of inflammation, carditis, carditis, endocarditis, myocarditis, pericarditis, they all can occur, and some patient can develop arrhythmias as well. What is the treatment? Treatment is actually very difficult. So we will go by the 2025 update on the treatment. Now there has been a treatment update from the International Society for Gastroenterology, Hematology and Nutrition. So what they have suggested is there are two types of regimes you can follow for these patients. Whipple disease is a difficult disease. The only good thing about Whipple disease is that it is more common in the Western population. Why it is more common in the Western population and not in the Indian subcontinent, we don't know. One theory is that we people get so much of commando training during our childhood. What is commando training? All kind of nonsense food we are eating, all kind of street food with so much of bacteria, viruses, parasites we are eating. Our gut epithelium is always in a upregulated state. And Whipple disease, even if the bacterial exposure occurs, it is not able to maintain or get entry into the body system. This is one theory. We don't even know why, whether it is true or not. So there is a good thing about something and there is a bad thing about something. The good thing about our system is these Western people come to our country, they get diarrhea next day. We go to all the countries, we don't get any diarrhea. Our immunity is very good. Right? So update says that it is difficult to eradicate them, but two types of regimes can be used. First regime is you use IV ceftriaxone. It is important. It is very, very important, and it is not there in most of the standard books. So you need to write it, whatever source you are preparing it from. First regime is you give IV ceftriaxone, and this is given for 2 weeks, followed by cotrimoxazole, which is given for 1 year. Second is you start with oral. Either of the two regimes can be used. You start with oral doxycycline and combine it with another oral drug known as hydroxychloroquine. And this combination is given for 1 year. So long-term therapy needs to be given in the patient. Okay, so two regimes are there. Let us go to the next disease. Onset of malabsorption, diarrhea within 2 weeks of visit to tropical country. So it's an American word, but we have to live with it. So tropical sprue. Tropical sprue is the diagnosis. What is the hallmark? 100% patients are having folate deficiency. Can B12 deficiency occur? Yes, it can. But what is always present? Folate deficiency. And what is the treatment in these patients? Doxycycline और टेट्रासाइक्लिन, दोनों सेम क्लास के हैं, दोनों में से कुछ भी यूज कर सकते हैं ओरली, प्लस फोलेट सप्लीमेंट 5 mg per day. Oral therapy is good enough for tropical sprue. Cause is not known. Generally, it is supposed to be some non-specific bacteria and it is according to the country. तो सिनेरियोस की बात हो रही है। देखो अभी सिनेरियो क्या पढ़े हमने? तीन सिनेरियो पढ़े हैं। लेट अस समराइज, ऐसा भागता नहीं चलेंगे, समझ के चलेंगे। सिनेरियो वाज childhood onset, steatoria, DQ2 positivity, and certain foods causing problem in the patient, that is celiac disease. If they are saying ki arthritis followed by malabsorption followed by PAS positive bacteria on endoscopy and biopsy, Whipple disease. Malabsorption and diarrhea within 2 weeks of staying or visiting a tropical country, tropical sprue. Fourth scenario, malabsorption disorder due to reduced length of small intestine. Obviously, it will always be after disease or after a operation. So small intestine length becomes reduced. So malabsorption will occur because patient will not be able to absorb. So malabsorption disorder due to reduced length of small intestine. It is called as short bowel syndrome. Short bowel syndrome. Short bowel syndrome. If the small intestinal length becomes less than 200 centimeter, it causes malabsorption syndromes. Malabsorption symptoms appear. And if the small intestinal length becomes less than 100 centimeter, it causes complete intestinal failure. And so the patient will be TPN dependent lifelong. Patient will be TPN dependent lifelong. Now, what are the causes? We have one-liners here. Most common cause in newborns, there is a condition known as NEC. If you have done neonatology in pediatrics, you would know. I am being tempted to talk about it, but I can't because we are discussing medicine. So NEC, necrotizing enterocolitis. Second common cause are intestinal atrechias. Atresia means absence of lumen formation. Have you heard of duodenal atresia, jejunal atresia, ileal atresia? They all can cause. Most common cause in children is volvulus. It's a surgical emergency. Most common cause in adults, it is Crohn's disease. It's a type of inflammatory bowel disorder. Now, what are the drugs which are useful in these patients? There are two kinds of drugs. One is the drug which causes hyperplasia of the villi, and it helps in the increasing the absorptive surface area. There is a drug known as GLP-2 analog. The typical example of this drug is teduglutide. Teduglutide. And second are anti-motility agents. By slowing down the gut motility, they allow more time so that absorption can occur better. So anti-motility agents, two of them are approved for use. Either you can use loperamide or you can use combination of diphenoxylate with atropine. Highlight this particular thing. Treatment is important. This is important. Treatment of short bowel syndrome is important. Next thing, patient will be having recurrent diarrhea and absorption, recurrent diarrhea and malabsorption, not absorption, recurrent diarrhea and malabsorption due to reflux of colonic content into ileum via the ileocecal valve. Via ileocecal valve. So ileocecal valve is leaky and it is not being able to keep the intestinal content separate from the colonic content. Back flow is happening, and from colon, bacteria is moving into the sterile region of small intestine. This is what you call as SIBO. What is SIBO? Small intestinal, good, good. Small intestinal bacterial overgrowth. Small intestinal bacterial overgrowth. देखो कभी सोचा है ऐसा कि हमारा जो स्टूल है जो कोलोन से आता है, कोलोन में इतना बैक्टीरिया है, small intestine में बैक्टीरिया नहीं है, because ileocecal valve is very efficient. It does not allow the content of colon to go back. But if ileocecal valve is leaky due to some reason, whatever reason, sometimes no reason is found, then bacteria can periodically go inside and it will cause recurrent diarrhea and malabsorption, and that will cause small intestinal bacterial overgrowth. Now, in small intestinal bacterial overgrowth, you cannot repair ileocecal valve. So periodically, you will have to use drugs like metronidazole with or without doxycycline. Multiple courses will be needed. And it is a disease which is actually very difficult to treat. And these days, a lot of endoscopic procedures are being done, but it is something beyond our exam level that we are preparing. So metronidazole with or without doxycycline. Yes, you rightly said rifaximin is being used in refractory cases. So refractory cases, we are giving a trial of rifaximin as well. Rifaximin acts locally and sterilizes the gut, so that can be used. But the first line therapy, according to Harrison, it is metronidazole with or without doxycycline. So next scenario, examiner will say there is a patient with hypoproteinemia with edema, low serum albumin and globulin. सो देखो ब्लड में एल्बुमिन नहीं है, ग्लोबुलिन नहीं, लेकिन किडनी और लिवर से लॉस नहीं हो रहा, लिवर डिजीज नहीं है, रीनल डिजीज नहीं है, तो प्रोटीन का लॉस हो कहां से रहा है? स्टूल में हो रहा है. दैट कंडीशन इज नोन एज प्रोटीन लूजिंग एंटेरोपैथी. प्रोटीन लूजिंग एंटेरोपैथी. प्रोटीन लूजिंग एंटेरोपैथी. देखो इसके ऊपर इसका एक डिफरेंशियल डायग्नोसिस है, आई एम पुटिंग अ स्टार. एक होती है प्रोटीन लूजिंग गैस्ट्रोपैथी, व्हेन द लॉस हैपनिंग फ्रॉम द स्टमक. Protein losing gastropathy is seen in patients who are having Menetrier's disease. Menetrier's disease produces protein losing gastropathy. These patients will have hyperplastic mucosal folds, और इन पेशेंट्स में लॉस होगा स्टमक से, लेकिन यहां पर इंटेस्टाइन से लॉस हो रहा है. सो दिस इज प्रोटीन लूजिंग एंटेरोपैथी. नाउ इट इज नॉट अ सिंगल कंडीशन, इट इज अ एंड रिजल्ट ऑफ मल्टीपल डिजीजेस. क्रॉस डिजीज में हो सकता है, ट्रॉपिकल स्क्रू में हो सकता है, समटाइम्स लिम्फेटिक abnormalities can cause it. Investigation of choice, we check this tool for alpha 1 antitrypsin clearance. Stool for alpha 1 antitrypsin clearance, that is increased. More alpha 1 antitrypsin getting lost in stool is a marker that albumin and globulin are also getting lost in stool. So it's a test that we perform. How to perform the test will not be asked. Alpha 1 antitrypsin acts as a surrogate marker indicating कि protein का loss हो रहा है into the stool. And what is the treatment? You treat the cause, plus you give increase high protein diet, and you add MCT, medium chain triglyceride oil, MCT oil in the food. It has been shown to improve the steatorrhea in the patient. Now, there is a very interesting thing here. I'm putting a star. Important point. There is a new test which is available for protein losing enteropathy. Many times, alpha 1 antitrypsin clearance will not be possible or it will not be available. तो हम क्या करते हैं, ब्लड में चेक करते हैं लिम्फोसाइट काउंट. हमें ब्लड में मिलता है लिम्फोपिनिया with depletion of CD3 positive T cells. If this is found in the blood and patient is having malabsorption with hypoproteinemia, you should suspect which disease? Protein losing enteropathy. It is a new test which is available in these patients. MCT oil means medium chain triglyceride. Medium chain triglyceride. Medium chain triglyceride जो होते हैं, इनका absorption ज्यादा diffuse होता है, and even if intestine से नहीं absorb हो रहे, they can get absorbed from the colon, proximal colon as well. So medium chain triglycerides are always added in a patient with uh, steatorrhea if you are suspecting it. Here, steatorrhea is not obvious, it is just a component. So you usually add MCT oil in the food. MCT is medium chain triglyceride oil. It's a health supplement. And then we have some one-liners, easy one-liners. Specific or confirmatory investigation or investigation of choice for any malabsorption disorder. What is your answer? It is endoscopy and biopsy. Endoscopy and biopsy. Gold standard test for steatorrhea, one-liners. 72-hour fecal fat excretion. बट सोच के देखो क्या यह प्रैक्टिकली पॉसिबल है? 72 आवर तक यू हैव टू कलेक्ट फिकस. कैसे करोगे? उसके बाद वो इतना बड़ा लिफाफा लेकर, डब्बे में तो आएगा नहीं. किसके पास जाना है? लैब वाले के पास. और उसको क्या बोलना है? भैया फीकल फैट चेक करो. लैब वाला मना कर देगा. I'm telling you the real world. I'm telling you practical. So many gold standard tests are only theoretical. They are not practically applicable, applied, right? But from exam perspective, we have to know. So 72 are fecal fat excretion, right? That is the gold standard test for steatorrhea. Gold standard test for uh, proximal small intestinal malabsorption. There is a test known as D-xylose test that we perform. And gold standard test for vitamin B12 malabsorption, again, a test which is no longer done these days, it is Schilling test. Schilling's test. Schilling test may you give oral radiolabeled B12 and you find that there is less than 10% of radiolabeled B12 excreted after oral administration. After oral administration, it indicates likely malabsorption. Likely B12 malabsorption. It is not due to dietary deficiency, it is due to malabsorption of B12. So this is the interpretation. It is a topic. Uh, Ramesh is saying, thanks for your wonderful time, sir. It's 2 time. I'll join tomorrow live session. Okay, Ramesh, I understand you have to leave. I think many of you have to leave. Some of you are messaging me separately on Instagram also. See, if you're finding it useful and you're not doing anything very significant, you can continue with the class. This video will be available for all of you till you sit in the exam. So it will be there. So I will keep on discussing rather than do it in a, recorded way. We thought that let's do it in a interactive way so that I can also interact with you. Otherwise, recording becomes very boring. So we have no uh, serious exigencies. See, when I planned on taking a medicine rapid revision, I knew it already that it will be impossible for me to cover every system. Second way was I do only one-liners, but that will not satisfy me, the educator inside me. So I thought, we'll start with 2 days, but if there is a need, we will, sneak in some extra hours in one of the days also. So we will do it, right? We will touch all systems, but will not just do it for the sake of formality. So let us continue with this. If you can stay, 10 minute break मिलेगा. Hmm. You're asking a tough question. Even I need to get that water bottle filled of mine. Thank you so much, docs. Let's take a quick. Let's take a very quick 10-minute break. Right? Sharp 10:26. I will start. Sharp 10:26. We will start. Sharp 10:26. We will start. But we'll definitely finish GI hepatology today and enter rheumatology. Let's see how much we are able to do. We'll start tomorrow from where we have left only. Okay. So 10 minutes break. Break is on.
Okay, we're good to go. Everyone, please let me know if I'm audible or visible or not. Okay, audible and visible. So let's start with FMG 2019 question. Just a small announcement. Exact timing will be made available to all of you. So because other sessions are also planned. So we will be starting the session tomorrow, irrespective what time we end today. We will be starting early. We'll be starting around 3 or 3:30. Either 3 or 3:30, exact time will be made available to all of you by morning, early morning. So link will remain the same. Where we leave today, we will be starting from there. But the topic, first we will finish this workbook, then we will move to the second part of the workbook, right? So we will not compromise anything, will not leave any system. FMG 2019. See, it is important because if we transfer it to the end of the discussion on 20th or 21st December, what will happen is you will have less time to revise also. So I want to finish off medicine early before that. I hope it is okay with all of you. Right. Okay. FMG 2019 question is 3-year-old child presented with steatorrhea, weight loss, and malabsorption features. What test shall be confirmatory to make the diagnosis? What is your answer? What is your answer? A, B, C, or D? Look at it and tell me the answer. Which is the confirmatory test as well as investigation of choice? I've already told you. The answer is no, 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 no. Confirmatory test. Look at the options. Look at the one-liners. The confirmatory is always small intestinal biopsy. Whether they ask 3-year-old child, whether they say 30-year-old man or woman, the answer will be same. Small intestinal biopsy will be confirmatory. It will be confirmatory in the patient. Okay. Let's move further. Talk about H. pylori. H. pylori is important bacteria. Questions are asked. And there was a question on H. pylori treatment in the July exam also, and likely to be asked in the upcoming exam as well. So what are the diseases which are associated with H. pylori? There is a list, and twice it has been asked in your FMG exam. First of all, H. pylori is associated with peptic ulcers. What kind of peptic ulcers? It is associated with, it is seen associated with 70% of duodenal ulcers and 50% of gastric ulcers. 50% of gastric ulcers. So it is associated with both duodenal and gastric, but the association with duodenal ulcer is more common. Secondly, it is associated with distal gastric adenocarcinoma. It increases the risk of stomach cancer of adenocarcinoma. Third, it increases the risk of developing GIT lymphomas. Fourth, it increases the risk of functional dyspepsia. What is functional dyspepsia? See, middle-aged adults often have, they will eat something and then they will have, abdominal distension. They will have belching, dakar aega. Then they will be, just putting some, massage on their tummy. Then they will be drinking and they will be belching like, that kind of a thing. You must have seen middle-aged people do that. That is functional dyspepsia. There is no organic cause, but functional gas, belching, dyspepsia, indigestion, that is functional dyspepsia. And fifth, these patients will have functional abdominal pain. These are the important diseases which are associated with H. pylori. Now the question arises, what is not associated with H. pylori? Not associated with H. pylori is carcinoids. Carcinoids are not associated. It's a previous year question. Another MCQ, is there a protective or negative association? Protective or negative association of H. pylori? The answer is yes. What is protective or negative association? What it means is H. pylori prevents certain disease from happening, right? So what is protective or negative association? Two things. H. pylori protects against GERD, gastroesophageal reflux disease. And secondly, it protects against distal esophageal adenocarcinoma. It's a very, very interesting phenomena. that H. pylori causes stomach adenocancer, but it prevents esophageal adenocancer. I repeat, see here, H. pylori causes distal gastric adenocarcinoma, but H. pylori protects against esophageal adenocarcinoma. It's a very interesting thing, and obviously MCQ. It's not an MCQ in FMG exam. It's an MCQ. The old NEET PG question can be asked in the FMG exam as well. Okay. Now, is the treatment of H. pylori infection? We will go by what the Harrison 22nd edition update is saying. What we know so far. Traditionally, I'll write traditionally. Traditionally means what we normally do in H. pylori treatment. Traditionally, the first line therapy is called as triple therapy. Triple therapy. What is triple therapy? Either you use OCA or you use OCM drugs for 14 days. What is OCA or OCM? O stands for omeprazole. It is a proton pump inhibitor. C stands for clarithromycin. A stands for amoxicillin. Sometimes you don't use amoxicillin, you use M. M stands for metronidazole. So either OCA or OCM, either of the two, we use for 14 days. And second line, if first line therapy fails, then we go for second line therapy. Second line is called as quadruple therapy. Quadruple therapy. What does quadruple therapy entail? Quadruple therapy will have OBMT, and it will also be given for 14 days. O is the same. B stands for bismuth compounds. And T stands for tetracycline. O and M we have already written. Now, quadruple therapy and triple therapy, these were the original therapies which were employed. However, now Harrison says, the new edition of Harrison says, in areas with more than 15% clarithromycin resistance, there are many countries in this world, including India, including many countries in Africa, where clarithromycin resistance is very high. In areas with more than 15% clarithromycin resistance, for example, India, OCA and OCM cannot be used. So what happens to the therapies? So in these areas, first line therapy becomes OBMT therapy. And what if the patient is resistant to OBMT or does not respond? Second line, there are two options which are available. Either you can go for levofloxacin based regimes, or you can go for rifabutin based regimes. And both of them will be combined with proton pump inhibitors. It is an exciting new thing. It is an exciting new thing. Already in the July 25 exam, before Harrison was released, this question had been asked. And now it has changed significantly the entire therapy for H. pylori. The biggest change in Harrison is H. pylori treatment. So there is a very good possibility something out of this will be asked in either FMG or NEET PG or INI set or maybe all of these exams. So this is something you need to know. Triple therapy is failing in our country and we are not supposed to use it, right? So this changes a lot. This changes things a lot. Details of levofloxacin and rifabutin they will not ask because it becomes too complicated. So there are big tables and flowcharts. You don't need to go into it. It's very important. Sir, I promised I'll go with multiple reasons. Watch this video before exam. Please try to do that. But at the same time, also mug up the PYQs of FMG and NEET PG as well for medicine also and for other subjects, right? Topic is done. Let us move to a star topic, inflammatory bowel disease. Inflammatory bowel disease is of two types. It's a integration. You read about it in pathology, you read about it in surgery, and you read in medicine. In fact, treatment is done by medicine people only. So inflammatory bowel disease is of two types. We have Crohn's disease and we have ulcerative colitis. Crohn's disease can involve any part of gut starting from mouth till anus, but terminal ileum is commonly involved. Ulcerative colitis only involves the colon.
So, first of all, what is the family history and twin concordance? Crohn's disease is strongly associated with positive family history and twin concordance. Ulcerative colitis association is not significant. Crohn's disease, the gene associated with familial Crohn's disease is NOD2 gene mutation. This is important, mentioned in both Robbins and Harrison. Smoking. Crohn's disease, the smoking increases the risk of Crohn's disease. But ulcerative colitis and smoking have a protective association, means smoking reduces the risk of getting ulcerative colitis. So should you smoke? No, because you will not get ulcerative colitis, but you will get Crohn's disease and you will get all the other types of lung cancers that we discussed. Appendicectomy has no effect on Crohn's disease, but appendicectomy has been shown to have a protective association. People in whom appendix has been removed, ulcerative colitis prevalence is less, but it is not reasons significant enough that we do removal of appendix in every patient. It's just a finding. OCP use slightly increases the risk, slightly increases the risk of Crohn's disease. But ulcerative colitis, there is no effect on ulcerative colitis related to OCP use. What is the most common antibody? It is ASCA. Details of these antibodies and full forms you will be reading separately also and in pathology also. The ulcerative colitis is associated with antibody known as P-ANCA, perinuclear anti-neutrophil cytoplasmic antibody. What is the site of involvement? It involves any part of the body from mouth to anus, but most commonly involves which part? Terminal ileum. On the other hand, ulcerative colitis typically involves the colon. In colon, the most common site of involvement is rectum. The most common site of involvement is rectum. What are the lesions? Here you find discontinuous lesions because there are skip areas, also called as skip lesion. क्योंकि क्या होगा, थोड़ा सा पार्ट में अल्सर आएगा, फिर नॉर्मल, फिर अल्सर, फिर नॉर्मल, फिर अल्सर, फिर नॉर्मल. यहां पर कॉन्टिन्यूअस होता है. Continuous means starts from the rectum and without any skip area goes all the way till whatever is the edge of the colon. Now the types of ulcers, here they are deep and focal ulcers. Here they are superficial ulcers. Is there gut wall thickening which is seen? Yes, it is present here. It is absent in ulcerative colitis. What about stricture, fistula, and fissure? It is significantly present in Crohn's disease, but it is absent in ulcerative colitis. Malignancy risk, it is low in Crohn's disease, it is high in ulcerative colitis. How high? It is related to the age. So colonoscopy, regular colonoscopy is recommended every year after a certain period of ulcerative colitis has happened. The risk of malignancy is 2% in 10 years after diagnosis, and it rises to 8% in 20 years after diagnosis of ulcerative colitis. It is mentioned in Harrison. So as the age increases, the risk of malignancy in ulcerative colitis increases. What about extraintestinal manifestation? Extraintestinal manifestations can occur in Crohn's disease, but they are rare, but they are common in ulcerative colitis. What are the three common extraintestinal manifestations which can occur in ulcerative colitis? तीन ऐसी चीजें जो इंटेस्टाइन के बाहर हो रही हैं and which occur in ulcerative colitis. First of all, these patients have high risk of developing uveitis, particularly anterior uveitis, so they can develop blindness. Secondly, these patients have high risk of developing primary sclerosing cholangitis. प्राइमरी स्क्लेरोजिंग कोलेंजाइटिस, इसमें जो आपकी लार्ज बाइल डक्ट है, in that large bile duct sclerosis happens, thickening happens. उससे क्या होता है, पेशेंट में सिरोसिस हो जाता है, कॉन्जुगेटेड बिलिरुबिनेमिया हो जाता है और उसकी अनियन वॉल थिकनिंग हो जाती है. यू मस्ट हैव रेड इन सर्जरी एज वेल एज इन पैथोलॉजी. सो प्राइमरी स्क्लेरोजिंग कोलेंजाइटिस. Thirdly, these patients can develop pyoderma gangrenosum. Can erythema nodosum occur? Yes, it can. But more commonly what you find and on which question has also been asked is pyoderma gangrenosum. इसमें एक नॉन हीलिंग अल्सर बन जाता है आपके लेग के ऊपर. So remember these three important words: uveitis, primary sclerosing cholangitis, and pyoderma gangrenosum. However, the only extra intestinal manifestation which is more common in Crohn's disease than ulcerative colitis is ankylosing spondylitis. It is more common in Crohn's disease compared to ulcerative colitis. What will you find on? Yes, yes. See, there many things can occur. Episcleritis can occur. There is a whole lot of list which has been brought to you. We can't remember the entire list. Remember, it is rapid revision. So we are doing only what is asked and what has been asked in the recent exam. Obviously, this is the bare minimum. You are supposed to go into more details than this. Microscopic examination. देखो अल्सरेट क्रॉस डिजीज में क्या हो रहा है? आपके पूरी थिकनेस इन्वॉल्व हो रही है, तभी तो गट वॉल थिक होगा, तभी तो फटेगा और फिस्टुला करेगा. सो देर इज ट्रांसम्यूरल इन्फ्लेमेशन. ट्रांसम्यूरल मीन्स थ्रू आउट द थिकनेस देर इज इन्फ्लेमेशन, एंड दीज पेशेंट्स विल हैव सीरोसाइटिस, सीरोसा का इन्फ्लेमेशन, एंड क्रॉनिक इन्फ्लेमेशन से फाइब्रोसिस ऑफ द गट हो जाएगा. और फाइब्रोसिस से ही एक रेडियोलॉजिकल साइन प्रोड्यूस होता है, उसका नाम है स्ट्रिंग साइन ऑफ कैंटर. So there will be narrowing due to fibrosis. It produces a sign known as string sign of Cantor. In case of ulcerative colitis, ये सुपरफिशियल रहेगा, म्यूकोजा में रहेगा, लेकिन सूडो पॉलिप बनाएगा. सो देर विल बी म्यूकोजल एंड सब म्यूकोजल इन्फ्लेमेशन. म्यूकोजल एंड सब म्यूकोजल इन्फ्लेमेशन. एंड क्या करेगा ये? इट विल फॉर्म सूडो पॉलिप्स, क्रिप्टाइटिस, क्रिप्ट का इन्फ्लेमेशन, क्रिप्स ऑफ लाइबर्कन, एंड क्रिप्ट एब्सेस, न्यूट्रोफिल कलेक्शन इन दी क्रिप्ट्स. इसे कहते हैं क्रिप्ट एब्सेस. ये वर्ड्स हैं जिसको वॉच आउट करना है. इनफैक्ट हैरिसन कहता है कि जिन पेशेंट्स के अंदर बड़े बड़े सूडो पॉलिप बन जाएं, सूडो पॉलिप जो होते हैं ये इंक्रीज करते हैं कैंसर का रिस्क. सो दे कैन बी प्री कैंसरस ऑल्सो. सो दे कैन बी प्री कैंसरस एज वेल. एंड रेडियोलॉजिकली इसमें क्या दिखेगा? द अपीयरेंस इज कॉल्ड एज लेड पाइप कोलोन. लेड पाइप और होज पाइप कोलोन. lead pipe or hose pipe colon. Why? Because there will be loss of hostrations. हमेशा hostrations होते हैं, वो लॉस हो जाते हैं कोलोन में अल्सरेटिव कोलाइटिस होने से. एंड कोलोन जो है वो बहुत स्मूथ दिखती है. सो फोटोग्राफ्स यू मस्ट हैव सीन इन योर रेडियोलॉजी क्लास एज वेल एज इन सर्जरी क्लास. Yes, yes, but nobody's see, granularity in bowel is more theoretical thing. Let me tell you, nobody sees granularity in bowel and nobody asks in the exam as well. ये ना कुछ चीजें होती है वो रेडियोलॉजिस्ट तक ही होती है, वो क्लिनिशियन तक नहीं पहुंचती हैं. वो क्योंकि पेशेंट डायग्नोज ही नहीं होता है तब तक. सो अर्लीस्ट फाइंडिंग, जैसे कि अब रिकेट्स पढ़ते हो तो रिकेट्स में क्या आता है? अर्लीस्ट फाइंडिंग लॉस ऑफ प्रोविजनल जोन ऑफ कैल्सिफिकेशन. अरे भाई वो आइडियल है. पेशेंट जब तक रिकेट्स होता है और हमारे तक पहुंचता है तब तक उसका वो बाकी के सब कपिंग फ्रिंग मेटाफाइसिस सब कुछ हो चुका होता है. राइट. सो बहुत सारी चीजें हैं जो थ्योरेटिकल हैं, उनको याद कर सकते हैं, बट दे आर एग्जामिनर इज नॉट गोइंग टू आस्क देम फॉर द सिंपल रीजन दे आर नॉट क्लिनिकली रेलेवेंट. Exams are becoming more and more clinical. INI set exam tomorrow when you will prepare, that still has good weightage of pre and para, but the current exams they are more and more clinical. There is integration, yes. So you have to correlate with what you see clinically. So granularity of bowel, it has been described in IBD, but granularity of bowel is virtually never seen clinically, because by the time patient comes to attention and he gets his radiology done, all these signs are already, all these Cantor sign, lead pipe colon and other things, they are already present in the patient. Now, what about the treatment of IBD? Now, treatment के लिए there is a tabulated form that we'll be writing it, so it is easy for us to remember. नेक्स्ट, ट्रीटमेंट ऑफ आईबीडी. सबसे पहले फर्स्ट लाइन थेरेपी क्या है? क्रॉन्स डिजीज अगर माइल्ड टू मॉडरेट है तो हम यूज करेंगे ओरल या रेक्टल बुडेसोनाइड. व्हाट इज बुडेसोनाइड? इट इज अ कॉर्टिकोस्टेरॉइड. इट एक्ट्स लोकली, अब्सॉर्ब नहीं होता. ओरल और रेक्टल बुडेसोनाइड है ना. आइदर ओरल दे देते हैं, लेकिन अगर आपको लोअर एनस वाले रीजन में हो रहा है तो रेक्टल बुडेसोनाइड एनिमा भी दे सकते हैं. इफ दैट फेल्स in mild to moderate patient, then you go for oral prednisolone. Oral steroid will be indicated. If it is severe, then you have no choice but you use systemic steroid like prednisolone, and it is combined with either MMF or azathioprine. What is MMF? I'm writing the full form above. MMF का full form है mycophenolate mofetil. It's a very interesting and good immunosuppressive agent which is available in India. Pehle it used to be costly, but now it is cheaper. The patent on this is gone, and now locally it is getting produced in India. So it has a, it's a good agent to use. So it is combined with prednisolone in these patients. What about ulcerative colitis? Ulcerative colitis के अंदर हम सबसे पहले 5 ASA agents का ट्रायल देते हैं. 5 ASA. ASA stands for amino salicylic acid. Amino salicylic acid agents. 5 ASA agents are employed. You can use them either orally or you can use them enema. What are the agents which are used? First agent is sulfasalazine. Second is mesalamine. Mesalamine. And third is balsalamide. Either of these agents can be used. Either of these agents. ये तीनों एक क्लास के हैं, तीनों भाई हैं. So you can use one of them. And if ulcerative colitis is severe, then you have no choice, but you have to use steroids. So oral prednisolone will be used, plus minus MMF or azathioprine. So this is the treatment of mild to moderate. But if the Crohn's disease or ulcerative colitis are fulminant, severe, not getting controlled, very rapidly progressive, recurrent, बार बार हो रहे हैं, the moment you cannot give steroids indefinitely ना, non-responsive, respond ही नहीं कर रहे हैं, तो क्या use करेंगे? Biological agents. And which biological agents are useful in these patients? We go for anti-TNF alpha therapy. Traditionally speaking, हमारे चार anti-TNF alpha agents हैं जो इनमें यूज करते हैं. So these agents, now if you look at the table of Harrison, it talks about 11 to 12 monoclonal antibodies and new drugs. सब के सब नहीं करने हैं, करेंगे नीट पीजी के लिए करेंगे. फॉर एफएमजी एग्जाम वी विल डू ओनली व्हाट the bare minimum you need to know, what are available in our country and what are actually clinically used. So there are four biological agents that you need to remember from exam perspective. For the first one, which is useful in both Crohn's disease and ulcerative colitis, is infliximab. So infliximab. माइल्ड मॉडरेट का कैसे पता चलेगा? क्लिनिकली देंगे वो. अदरवाइज देर इज अ वे टू चेक फॉर माइल्ड मॉडरेट. देर आर क्लासिफिकेशंस known as Montreal classification. You can go for Montreal classification. It talks about extent, it talks about severity and so on. उससे करते हैं. बट एग्जाम में जब एमसीक्यू आएगा तो दे विल मेंशन माइल्ड है, मॉडरेट है, सिवियर है. सो इन्फ्लिक्सिमैब, देखो आपको ये समझना है कि आपके पास पेशेंट नहीं है, आपको तो एग्जामिनर केस बनाकर दे रहा है. तो वो केस बनाकर जब देगा तो बताएगा ना आपको, राइट? सो इन्फ्लिक्सिमैब विल बी यूजफुल इन बोथ अल्सरेटिव कोलाइटिस एंड क्रॉन्स डिजीज, दोनों में यूज करते हैं. सेकेंड इज अडालीमूमैब. 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 String sign of Cantor, Shivani, string sign of Cantor is a radiological sign. Aphthous ulcer is a endoscopic finding. Both are different. String sign of Cantor, I repeat, is a sign done on barium examination. Aphthous ulcer is seen on endoscopy when you do. Okay? So दोनों अपनी अपनी जगह पर कॉमन साइंस है. Aphthous ulcer will always appear before string sign of Cantor. String sign of Cantor जो है उसमें फाइब्रोसिस होगा तो आएगा, पहले तो अल्सर बनेगा. सो एप्थस अल्सर विल ऑलवेज अपीयर अर्ली. So adalimumab, it will be again useful in both ulcerative colitis and Crohn's disease. Third, we have certolizumab. You can remember C के साथ C. So it is useful only in Crohn's disease. So you can remember like this, C stays with C. And fourth is golimumab. Golimumab. Golimumab is useful only in ulcerative colitis. Ulcerative colitis. Apart from that, you will put a star and write what are the recent drugs which are being used. Recently, we are using two more drugs. There is a drug known as vedolizumab. Vedolizumab is useful in both ulcerative colitis and Crohn's disease. And second is a new class of drug known as ozanimod. Ozanimod. Ozanimod is a S1P1 receptor modulator. ये एक ओरल ड्रग है. This is an oral drug which is which is effective in severe ulcerative colitis patient. So this is the Harrison update of new drug related to the what is important. If you This is based upon my reading and my perception of the drugs which are given. Let me tell you again, there are 11 drugs, biologicals. But if we write everything, we remember nothing. So we have to remember the more important ones and the ones which Harrison is also paying a lot of attention and which are actually available to us also. Otherwise, experimental things, there is no end, no point just remember, doing them for the sake of it. So this is Crohn's disease and ulcerative colitis. Right. उसमें छोटी छोटी और बहुत सारी चीजें हैं वो these have been covered in other systems. So this finishes our quick review of Crohn's disease, ulcerative colitis. Let us move into the world of liver, hepatology. Hepatology is relatively easy in the beginning. So hepatology में सबसे पहला चीज जो इस पे questions are asked is scoring systems in hepatology. So if you have written, I'm changing. So in scoring systems, we have the first scoring system, that is the MELD score. What is MELD score? MELD score stands for Model for End Stage Liver Disease. This was one of the earliest score which was devised to help guide कि किस patient में prognosis अच्छा है, किस में खराब है, and which patient will require liver transplantation. It is used in the age group of 16 years and above. What are the components? Components are asked in exam. The mnemonic of component is CBI. So C stands for creatinine, B stands for bilirubin, and I stands for INR. What is INR? International Normalized Ratio. It's a marker of prothrombin time. Second is PELD score. It's a pediatric modification of MELD score. ये कई सालों के बाद आया. Modification of MELD score, it is used in the age group of 15 years and less. इसके कंपोनेंट क्या है? देखो इसके कंपोनेंट सेम नहीं है. द कंपोनेंट्स आर डिफरेंट एंड दिस कंपोनेंट्स आर आल्सो आस्क्ड इन द एग्जाम. द निमोनिक फॉर दिस इज अ बिग एप्पल. A big apple. A stands for age because ये बच्चों में हो रहा है. B stands for bilirubin. I stands for INR. G stands for growth failure. And last A, it stands for albumin. Now, interesting MCQ for you. Which of the following is a component of MELD score but not a component of PELD score? And one of the option was creatinine. That was the answer. So creatinine is a component of adult MELD score, but it is not a component of the pediatric end stage liver disease score, that is PELD score. Right? Interesting thing. You can just remember. Many of you know the answer already in the comment section. You're all smart people. I have high hopes from all of you. Third, child pug score. Child pug score, also called as child pug Turcot score. चाइल्ड पग टर्कॉट स्कोर. देखो इसको ना अलग अलग नाम है. चाइल्ड स्कोर भी कहते हैं, चाइल्ड पग भी कहते हैं, चाइल्ड पग टर्कॉट भी कहते हैं. तीन लोगों ने मिलकर दिया था, तीनों का नाम आना चाहिए ना, लेकिन कई जगह पर सिंपल चाइल्ड पग स्कोर लिख देते हैं. इट इज यूज टू प्रिडिक्ट मोर्टेलिटी एंड नीड फॉर ट्रांसप्लांटेशन इन सीएलडी पेशेंट्स. व्हाट आर द कंपोनेंट्स? नाउ कंपोनेंट्स कैन बी रिमेंबर्ड लाइक दिस. चाइल्ड पग स्कोर, एक चाइल्ड को क्या चाहिए? व्हाट डज अ चाइल्ड नीड? बच्चे को चाहिए एन एजुकेटेड बाप. चाइल्ड पग स्कोर में क्या चाहिए? एन एजुकेटेड बाप. बाप is a Hindi word. Its a literal meaning is father. So A stands for albumin, E stands for encephalopathy. तो कोई लॉजिक नहीं है, याद करना है. ये कंपोनेंट है तो है, कैलकुलेट करना नहीं बोलेगा, कंपोनेंट पूछेगा एग्जामिनर. We will show discuss MCQs also. B stands for bilirubin, A stands for ascites, and P stands for prothrombin time. Prothrombin time. So these are the components of child pug score. Fourth, we have the Nazar score, also called as Nazar's prognostic index, and this is used in patients with Wilson's disease. What is Wilson disease? It is a disease of copper metabolism defect. Wilson disease, ATP7B gene mutation. Yaad aaya? These patients, they have increased copper levels. Increased copper levels occur in the liver. They occur in the eyes. In eyes, it produces KF ring, as well as sunflower cataract. And in the brain, they can affect the basal ganglia. They can produce Parkinson-like disease. So this is Wilson disease, right? So this is a I've written so that you remember this is Wilson disease which is being talked about. What are the components of Nazar's prognostic index? Components can be remembered by the mnemonic ABP. News channel भी है ना ABP. Uh, it literally stands for Anand Bazar Patrika, but the name of the channel, the news channel is ABP. A stands for AST levels, that is SGOT levels. B stands for bilirubin levels, and P stands for prothrombin time. There is a new modification of this recently done, very important. It is missing in many of the textbooks. So modification kya hai? There is a Nazar's index has been expanded to call it as the New Wilson index. New Wilson index. New Wilson index was given by a person whose surname is Dhawan. So it is also known as Dhawan's index. No, it is not the Dhawan you are thinking of. It is not the same Dhawan, it's a different Dhawan. So न्यू विल्सन इंडेक्स और धवन्स इंडेक्स क्या होता है इसके अंदर? एबीपी. It's not Rajiv Dhawan actually, it's a different Dhawan. So ABP along with serum albumin and WBC count. WBC count. WBC count. So इसको कहते हैं धवन्स इंडेक्स और न्यू विल्सन इंडेक्स. It is just a modification of Nazar's prognostic index. Yes, yes, I know. Rajiv sir is very popular in FMG. He's a like legend for ENT in not just FMG but also for NEET, PG, and INSET. And it's a pleasure to have known him for so long. He's my friend also, but friend is not the right word to use because he's very senior to me. So he's also my, you know, you can say colleague, come friend. So a lot of things to learn from him. And I'm quite sure you have seen sir's videos and you are following sir through social media as well. So, but it's not his index. It's a different Dhawan who was given this index. It's a modification of the Nazir's prognostic index. Yes. All the Dhawans, Shikhar Dhawan, he was also a good player. Punjabi, Rajiv Dhawan, also a good player. ENT. Dhawan index, good index, Wilson disease. Let's move further. FMG January 23. Tell me the answer. Oh, it's humility only that he talks about me. He has been doing this work much longer than I have been. So FMG January 23. Look at the question and tell me the answer. See and tell me the answer. Select the correct combination regarding components of child buck score. A, B, C और D. देखो बड़े सिंपल है. APTT तो किसी भी स्कोर का पार्ट नहीं है, तो A and B are ruled out. ग्लोबुलिन किसी का पार्ट नहीं है, ये सी भी रूल्ड आउट, तो बचा क्या? D is your answer. This is how you're supposed to mark in the exam. You should, that speed of marking is also important and it develops the more MCQs you solve. तो थ्योरी अपनी जगह है, but please solve MCQs. It's a skill also which you develop. FMG June 22. Chronic alcoholic patient with splenomegaly presented with sudden onset hematemesis. Somebody was asking me, sir, Mallory Weiss को कैसे differentiate करेंगे? Chronic alcoholic, splenomegaly, sudden onset hematemesis. What are we thinking of? Esophageal bleeding varices. देखो स्प्लीनोमेगली नहीं होता है बोर हवे में, राइट? और उसमें पेनफुल हेमेटोमेसिस मेंशन करेगा. पेन विल ऑलवेज बी देयर. अगर पेन नहीं तो बोर हवे नहीं. सो पेन इज ऑलवेज प्रेजेंट इन बोर हवे सिंड्रोम, राइट? सो बी इज योर आंसर. याद कर लो, याद कर लो. आई एम राइटिंग. पेन इज ऑलवेज देयर. पेन इज ऑलवेज देयर इन स्कर्वी. बिना पेन का स्कर्वी नहीं होता. पेन इज ऑलवेज देयर in Boerhaave syndrome. Pain is always there, deep in heart of all MBBS doctors. कुछ ना कुछ ग्राउज हम लेकर चलते हैं. So if you feel that pain is there, it's okay. It's okay. You learn to live with it. Ignore it. Focus on the job which is important. Mostly the pain is of regret.
काश ये कर लेता, काश मैंने ये कर दिया होता, वट एवर, लीव इट. The day you crack your exam, it will be a new you. It will be a new professional journey. It will be a new personal journey for you. अभी आपको विश्वास नहीं होगा. The day you crack the exam and you take that passing certificate in your hand, that confidence comes back. That confidence you had when you were a topper in your school, that confidence will be back when now you are an adult, and that degree will be in your hand. Your way of dealing with people, you've got commando training outside India, you have done well, you have survived with a lot of homesickness and everything, but now all you need is just to crack that exam, right, and carry this pain. This pain is of many types: staying away from the family, a bit of heartbroken, everyone is, right? Both genders you find these. Then a bit of the regret of not performing to the ability, not doing well in the previous exam. Carry this pain with you. So this pain is good. Let it motivate you. Remember, scurvy is always painful. Bore syndrome always painful. They will mention the question with bone pain in scurvy. They will mention the question and painful hematemesis in bore syndrome. Let's move further. What is the first line therapy for upper GI bleeding due to varices? Now varices के साथ पेशेंट आया है upper GI bleeding के साथ, क्या करोगे? पहला चीज, आफ्टर मैनेजिंग एबीसी, राइट, मैनेज एबीसी. व्हाट इज एबीसी? एयरवे ब्रीदिंग सर्कुलेशन. इफ शॉक में आया है तो यू विल मैनेज शॉक, यू विल गिव फ्लूइड्स followed by blood transfusion, followed by blood transfusion. And wherever you are giving blood transfusion, the target hemoglobin should always be between 7 to 9 gram per deciliter. कभी भी हाई नहीं करना, एमसीक्यू है. बिकॉज इफ यू इंक्रीज द हीमोग्लोबिन बियॉन्ड 9, इट हैज, किसी का 9 है तो कम नहीं करना है, बट बढ़ाना नहीं है by artificial transfusion, because it has been shown that it worsens bleeding due to paradoxical rise in portal pressure. तो portal hypertension वर्सन हो जाता है if you give high more blood transfusion. So only देना है जितना जरूरी है. And then you will start the patient. If you are suspecting portal hypertension, you will give IV terlipressin or IV octreotide. दोनों में से एक मेंशन होगा, that will be given to the patient. And then do endoscopy. Now, when you do endoscopy, what is the first line therapy that you will perform? In endoscopy, the first line therapy is endoscope EVL. What is EVL? Endoscopic variceal ligation. वेरिसिस को बंद करने की कोशिश करोगे. दिस पॉइंट विच आई एम राइटिंग, इट्स वेरी इंपॉर्टेंट. इट्स इंटीग्रेटेड बिटवीन सर्जरी एंड मेडिसिन. सो मेडिसिन सर्जरी इंटीग्रेशन इज देयर. सो एंडोस्कोपियल वेरिसियल लाइगेशन बंद करने की कोशिश करेंगे. एंड ऑल्टरनेटिव टू दिस इज आइदर बैंड लाइगेशन, या तो बैंड लगाओगे, या आप स्क्लेरोथेरेपी करोगे. Sclerotherapy means injection into the base of the bleeding vessel. If this fails, the second line therapy will be tamponade of the bleeding vessel. और उसके लिए एक ट्यूब यूज करते हैं, उसे कहते हैं सैंक्सटैकन ब्लैकमोर ट्यूब. सैंक्सटैकन ब्लैकमोर ट्यूब. स्टेप वाइज पूछता है एग्जामिनर. ये हो गया, व्हाट इज द नेक्स्ट स्टेप इन मैनेजमेंट. इन सर्जरी, almost one third questions these days in FMG are what is the next step in management. So in surgery, particularly when you are preparing, keep that in your mind. And if that also fails, then third line therapy is always surgery. What is the surgery that we do in portal hypertension? TIPS procedure will be performed. So this is how you do management of upper GI bleed due to varices, right? So yes, there was a question on this. That is why we are covering it here. It's a very, very important question. It has been asked multiple times in all the exam. So मैंने उस तरीके से लिखा है कि what if it is a medicine question, you can manage. If it is a surgical question, you can manage, right? So upper GI bleeding management is done. Now, what they have done is there is a printing error during formatting. Drug of choice for prevention of variceal bleed. ये अलग topic है. Go to the अलग page. Drug of choice for prevention of variceal bleeding is beta blockers. So beta blockers like carvedilol, carvedilol or propranolol
or nadolol. In तीनों में से कोई भी एक can be given for prevention. Beta blockers do not have a role in treatment, but it's a one-liner question. For prevention of variceal bleed, what they do is they decrease the portal pressure and the rupture of the varices cannot happen. Then we have ascites. What is ascites? Free fluid in the peritoneal cavity. In ascites, we always calculate a gradient known as serum ascitic albumin gradient called as SAG. When you calculate SAG, this table comes in. This table is extremely important and often asked in the exam. If you calculate SAG, there will be two possibility. Either there is high SAG where the value of sag is more than 1.1, or there will be low sag that is less than 1.1. Let me explain in simple words so that you have an idea what I'm talking about. There is a patient of ascites, right? Ascites kya hai? Fluid in the peritoneal cavity. Generally, these patients will be having cirrhosis. Some of them will be having nephrotic syndrome, CCF, or some other reason. Now you need to find the cause. What do? You take out some fluid from the abdomen. You check the protein in it. Then you take the blood and check the protein in the blood. What protein? Albumin. So serum albumin minus ascitic fluid albumin, what value you get is SAG. What is SAG? Serum ascitic albumin gradient. Serum albumin minus ascitic fluid albumin, that is SAG. If the value is less than 1.1, it is low SAG. If it is more than 1.1, it is high SAG. Low SAG, there are five causes. Among them, these three causes are already asked in exam. Nephrotic syndrome, pancreatitis, TB. Ideally, all remember करना है, ये तीन नहीं भूलने. If it is high sag, you further see ascitic protein. If ascitic protein is less than 2.5, it is cirrhosis. If it is more than 2.5, it is cardiac cause like congestive heart failure or constrictive pericarditis. Sometimes it can occur due to IVC obstruction also. So if you are running short on time, तो ये जो पॉइंट मेंशन किए हैं ये गलत नहीं होने चाहिए. Ideally, the entire table is important. This table was important when I was a student. This table is important now, and this table will be important tomorrow when you will be teaching your juniors. And maybe when tomorrow your kids are doctors, then also this table will be important. The only question is, would your kids be doctors? I don't know what answer you're going to give, but I know many of you what you might be thinking. You're thinking of it now because you're on the wrong side of this preparation. That depends. That's a good question. Yes, Anand, that is a good question. Many times you initially feel when you are in the heat, you feel no, this branch is not good. You go to social media, people will be talking about saturation, people will be talking about lack of opportunities and how 15 rupees per consultation is being given. है ना? You'll find all these things. They are there. But let me tell you, if you're good in your field and you have just a bit of patience, eventually things fall into place. Trust me. I have gone through these are all milestones we all go through. So there are always two aspects. There is always someone who's working hard and still not making good money and not satisfied. And there is always someone who's silently doing his work and making and doing good in his life or her life. Generally, people who are doing well are silent, and people who are not doing well or struggling. And let me tell you, struggle will be there, but during your internship, during your residency, and first 2 to 3 years after you move into field or job will be tough. But they will be tough for everyone. You have to survive that phase, and you have to, have that patience. Once that time passes away, that time goes away, you find that it is not that bad a branch as well. Yes, there are problems, there are society problems, money related problems, opportunities. But if you are good and honest in your intent, eventually things fall into place. For now, it is not the time for you to think. Crack the exam, enter the system, understand it. And you will find it, there are always two aspects. It is never black or white, it is always gray. And it is not 50 shades of gray. There are 500 shades of gray. So this is HISAC and questions. Multiple questions have been asked. In fact, January 25 there was a question in FMG, and last year January 24 also there was a question on FMG. King of Alpha is asking, is your kid a dog? भाई मेरा बच्चा नहीं है कोई अभी. कहाँ बच्चा पैदा करवा रहे हैं यार. Shall we continue tomorrow? Because you seem to be very tired. When I get tired is the time I actually come into my own. Yesterday session also went till early morning. Okay. Okay. Um, Let us do one thing. Let us finish the hepatology part, है ना? And then we will move further. So HBV serology. So HBV serology. This is a table. Now, ideally, you should be make remembering and mugging up this table. कि क्या पॉजिटिव और क्या नेगेटिव तो क्या इंटरप्रिटेशन. But let me tell you, I have been a student and it is very difficult, almost impossible to remember and mug up this table. It is almost impossible. So what is the alternative way? Let's make a flowchart. This flowchart always works and we will try to practice it in the question also. Let's make a flowchart here. Is there any sufficient space? Yeah. Let's make a flowchart talking about how we actually approach the patient. So I'm giving the heading hepatitis B virus approach. Approach for MCQ. And an MCQ will be something like this. There is a patient with hepatitis B virus. He's having his blood test or her blood test was done, HbSCA, IgGA, IgMA, and they will tell what is the likely diagnosis. This is how they will ask you. So how we are going to go? First thing, first thing is check for HbsAg level. What is HbsAg? HbsAg is the surface antigen of hepatitis B. There will be two possibility. Either HbsAg is positive or HbsAg is negative. If it is positive, it indicates active infection. यानी कि hepatitis B active है body में. Okay. Now you see the antibody. There are two types of antibodies. If you find IgM anti-HBC, the patient is suffering from acute hepatitis B virus. The patient is having acute hepatitis B virus infection. And if the patient is having IgG anti-HBC, the patient is having chronic hepatitis B virus infection. Okay. But if the HbsAg is negative, there is no active infection. There is no active infection. Not active infection. अब क्या करेंगे? अब हम करेंगे तीन चीजें चेक. Three possibilities. First possibility, first possibility, patient is having only anti-HBs positive. बाकी सब कुछ negative है. So the likely diagnosis in such a patient will be vaccinated patient, immunized patient, injection लगा है. He never got hepatitis B actually. Second, if the question says anti-HBs is positive, मेरे साथ साथ बनाओ. It is very useful and it comes like this. Sahil Meena, that will give you a fighting chance. You need to add the updates I'm discussing here also along with PYQ. If anti-HBs is positive, plus IgG anti-HBC is also positive. अगर आपके पास जगह कम है तो अगले पेज पे भी लिख सकते हो, अलग पेज पे भी. सो आंसर विल बी हेपेटाइटिस बी हुआ बट रिकवरी हो गया लेस देन 1 year. एंड थर्ड पॉसिबिलिटी, ओनली IgG anti-HBC is positive. These patients will have remote recovery. Remote recovery का मतलब बहुत पहले इन्फेक्शन हुआ और रिकवर हो चुका है. कितना टाइम हो चुका है? Equal to more than 1 year. Equal to or more than 1 year. I'm zooming it. Equal to or more than 1 year. And also remember last point, if HBeAg is positive, that indicates high infectivity. And if HBe antigen is negative, that indicates low infectivity. You apply this rule and you will always reach the answer. If the table actually is tougher to remember because even if you read it multiple times, you will still forget it. But this flowchart, if you make it just 2 times also and just practice in the MCQs, most of your MCQs which are asked, you should be able to answer by this flowchart approach. And I've tried it, people have tried it, students have tried it, it works like a charm. Let us see if you can apply this approach in your MCQ or not. So, what is the approach in MCQ? Look at this question. FMG MCQ 2020. Look at this question. What is the likely diagnosis if a child has both, if a child has HBsAg negative, HBeAg negative, anti-HBs positive, and IgG anti-HBc positive? See, you need to, thank you doc, thank you. देखो HBsAg नेगेटिव है, इसका मतलब नो एक्टिव इन्फेक्शन। पहला ही स्टेप देखो, नो एक्टिव इन्फेक्शन, यानी कि एक्यूट भी नहीं हो सकता, क्रॉनिक भी नहीं हो सकता, तो बचा क्या? प्रीवियस HBV infection. D is your answer. If you see carefully, you will find that it fits into the previous HBV infection, but patient has recovered. You don't need to talk about, recovery versus non-recovery in the patient. So recovery has happened less than 1 year. It was previous infection which has recovered. So if you just simply apply this logic and follow the chart, you will always reach a correct answer. Try it out. When you try it in MCQs, PYQs, question bank practice, mock exams, this will work. So this flowchart approach should be in a place where you can see it again and revise it in the last week also before the exam, right? Or you're traveling in the morning in the bus, cold time, you're going to give a test in between during travel, have a look at this chart because you may not get a question, right? But if you get a question, you should have that accuracy to get it right. So, topic is done. Then another topic on which questions are repeatedly asked. Inherited hyperbilirubinemias. What are inherited hyperbilirubinemias? They are inherited causes of jaundice. Now, questions are asked on that, Dubin, Johnson, Rotor, etc. Let's form an approach. Examiner will say inherited hyperbilirubinemia. There are two possibilities. Either it is conjugated jaundice which is inherited or conjugated jaundice which is inherited. If it is unconjugated, those patients who have a neonatal presentation, only neonate they present, those are called as Crigler-Najjar syndrome. Crigler-Najjar syndrome. Crigler-Najjar syndrome is of two types, type 1 and type 2. One has is incompatible with life, type 2 is compatible with life. One has high mortality, they all develop kernicterus, that is bilirubin induced damage. They may or may not develop kernicterus. Another unconjugated jaundice which can present at any age including newborn period is Gilbert syndrome. Gilbert syndrome is entirely compatible with life. I went to take a class in Jaipur. In one of the institutes where I took an offline class, a student came to meet me. He's from Kyrgyzstan. He said, Sir, I am Gilbert syndrome. He was a diagnosed patient. Like I've seen in kids, but adult patients I had not seen. And he came to me after this session and after the class, and he said, "Ki sir, mujhe Gilbert hai." His eyes were yellow, and he said, "Sir, whenever I take stress or whenever I have some gut infection or anything, the jaundice becomes more severe, eyes become more yellow. Then I take a rest and I have good diet, it comes back, it becomes normal again." Gilbert syndrome, compatible with life. It will cause jaundice in the newborn period and later on also worsening occurring during any stress or any strenuous exercise, but absolutely normal and it can occur in general population, right? So Crigler-Najjar syndrome. Annotated PDF, I will share with the team. I will forward it to them till the time we have discussed, till that part. Okay, I will share with the team today only. Then conjugated jaundice. Conjugated jaundice is of two types. Okay, you are in Kyrgyzstan right now. Great to know that. In fact, I'll be traveling to Kyrgyzstan shortly in the, I think, January or, yeah, most likely January. So, what about inherited causes of conjugated jaundice? Now, if it is conjugated jaundice, there are two possibilities. First possibility, I'm highlighting the word dark pigmented liver. And second possibility, there is a normal looking liver. If it is a dark pigmented liver and abnormal secretion into urine of coproporphyrinogens, there is a disease you will think of. We call it as Dubin-Johnson syndrome. Dubin-Johnson syndrome. Thank you, Shubham. Thank you so much. Normal liver and no pigmentation in the liver, but similar presentation like Dubin-Johnson, that is Rotor syndrome. Dubin-Johnson syndrome is having gene mutation, ABCC gene mutation. which causes decreased MRP2 protein. This is your NEET PG MCQ. And these patients, there is a test that we do known as BSP dye test, bromosulfatholin dye test, which is abnormal. Rotor syndrome, there is another gene mutation, SLC01B1 and SLC01B3. These are the two genes which are mutated. Both produce the same rotor syndrome. And these patients, the bromosulfatholin dye test is normal. And remember that Dubin Johnson and rotor never occur. They are never seen in neonates. They have excellent outcome. They can be doctors. One of my MBBS batchmate, I'll not take the name. He is Dubin Johnson. He's doing fine in his life, and he has done his MD in diploma in dermatology. So he's doing good. Like obviously, we are once you with time you tend to lose touch with each other, but these are compatible. The only thing which is not compatible is Kriegel-Najar 1, and which is again not being incompatible, but still not very good outcome because plus minus connectors, that is Kriegel-Najar 2. All the other conditions are entirely compatible with life. Almaty, I came last year. This year, the schedule is yet to be made. So likely I'll be coming. I'll be coming to Kyrgyzstan. Dates are final. Almaty, I'll be coming. Most likely I'll come, but dates are not final, right? So let's focus on this. We are done. We are done. We are done with the topic. We are done with GI. We are done with pulmo. We are done with hepat. What about rheumat? What to do with rheumat? It's already 11:27. Come. No, no, no. Not anytime soon. No, moving to rheumatology. Let us do a small thing. Remaining things we will discuss tomorrow. But just like you have a post-credit scene, at least one topic, let's do the beginning. And we come back to this topic and continue from here. Let us start with the star topic of this session, that is systemic lupus erythematosus, SLE. SLE is an autoimmune disease, multi-organ damage, due to autoantibodies and immune complexes. SLE is also simply called as lupus. If you have watched Dr. House MD, it's a popular web series. There is a favorite dialogue over there. His dialogue is, "It's never lupus. When it MCQ's time, when it is a rheumatology clinic time, it is generally lupus." Lupus means wolf. Just like wolf attacks the person and kills him, SLE also kills the patient. When wolf attacks someone, the wolf attacks the central part of the face. See, cat family, leopards, tigers, and lions, they have a tendency to attack the neck of their prey. Wolves tend to attack, when they attack humans, they tend to attack the mid face. These patients have malar rash occurring and then they eat up the person. So similarly, these are the reasons why the disease is called as lupus. This is what people say, how the name lupus came in. So what is it's an autoimmune disease. What is the age and gender? So age and gender in these patients, it is 30 to 50 years, middle-aged females. Females more common than males. And the ratio is 9:1. So 9 times more common in female, predominantly a female disease. What is the clinical picture? Number one, they will have constitutional symptoms like fever, weight loss, etc. Second, they will have cutaneous manifestation. What are the cutaneous manifestation? There are two types of cutaneous manifestation. First is chronic cutaneous manifestation and second is acute cutaneous manifestation. Acute cutaneous manifestation is known as malar rash. Look at this lady. She is having a rash in a butterfly distribution, starts on the bridge of nose and like a butterfly spreads to the whole cheeks bilaterally. So it is erythematous, raised, scaly rash occurring in butterfly distribution. Butterfly distribution, it occurs on the nose as well as cheeks, and it always spares the nasolabial folds. These lines are never involved. It spares nasolabial folds. Malar rash is worsened by sun exposure, and this rash is the typical presentation in the patient. Remember, cutaneous involvement is the second most common organ which is involved. Chronic rash can occur in the form of DLE. What is DLE? Disc-like rash. We call it as discoid lupus erythematosus. And these are the patients who also have ulcers, nasal as well as oral ulcers, and they have alopecia. So loss of hair is common in the chronic variety of SLE. So two types of presentations are malar rash, which is acute, and chronic, which is discoidally, where ulcers and alopecia are common along with disc-like lesion. Third is musculoskeletal involvement, and I'm highlighting the word overall most common system involved, NEET PG one-liner MCQ. Overall most common system is musculoskeletal involvement. So it mostly occurs in the form of intermittent polyarthritis. This polyarthritis involves hands, wrist, and knee joint. There is deformity, but no erosions are seen. There is deformity. I think there is some issue. Just let me know if I'm audible and visible to all of you or not. Am I audible and visible? Because my own screen is stuck up in the phone, which I've kept on the side. Am I audible and visible? Okay, okay. So these patients will have intermittent polyarthritis, joints का inflammation होगा, डिफॉर्मिटी तो आएगी लेकिन इरोजन नहीं होंगे. डिफॉर्मिंग नॉन इरोजिव आर्थराइटिस इसे कहते हैं जैकूड्स आर्थ्रोपैथी. जैकूड्स आर्थ्रोपैथी. And what is the most serious involvement of kidneys? A serious involvement of SLE, it is a renal manifestation called as lupus nephritis. Lupus nephritis will require, it can be symptomatic or it can be asymptomatic. There are 6 classes which are described on renal biopsy. It is a pathology thing, so I will not go into the details. Remember, the most severe forms are class 4, followed by class 3 and class 6. Class 4 lupus nephritis is the one which is having wire loop lesions. And these patients have subendothelial deposits of immune complexes. So this is something which is asked in the pathology class as well. So what we have done so far, the patient is having constitutional symptom, the patient is having skin involvement, patient is having musculoskeletal, patient is having renal involvement as well. Among them, the serious manifestation is lupus nephritis. And before cyclophosphamide, etc., came in, this used to be the cause of death. Right now, it is not the cause of death. Can other systems be involved? Yes, other systems can be involved. What are the other systems which can be involved? These patients can have hematological involvement. So these patients can have anemia as well as thrombocytopenia. And they can have lung involvement in the form of pleuritis. There is no pleural effusion, no pneumonia. Pleuritis is the most common SLE involvement in lungs. And this is a January, it is a mid-year 2019 MCQ of FMG exam. What is the most common lung involvement of SLE? It is pleuritis. How do you make the diagnosis of SLE? There is a criteria known as Euler ACR criteria. Look at this criteria. Don't be scared looking at this criteria. All this criteria tells you is that for any patient of SLE, what you need to know is that anti-nuclear antibody should be positive 1:80. This is considered to be the most important criteria. This is considered to be the entry criteria. Just like for entry into medical education, medical system in country, you need to crack FMG. Similarly, to be diagnosed as SLE, पहला चीज क्या करते हैं? ANA करते हैं. अगर ANA कम मिला या नेगेटिव मिला तो SLE नहीं है. अगर ANA 1:80 से ऊपर पॉजिटिव मिला तो that is entry criteria. Then you look at the other criteria. These are the criteria given and corresponding score is given. My suggestion to you, don't read this criteria in detail. आया भी तो याद नहीं रहेगा. तो हमें याद क्या करना है? Essential criteria for entry into diagnostic criteria is ANA. कितना? More than 1:80. Apart from that, if you look at clinical criteria, you look at immune criteria, take out the total score. You see कि क्या क्या चीज प्रेजेंट है. सपोज फीवर है तो यू गिव ए स्कोर ऑफ 2. साथ में ओरल अल्सर है, गिव ए स्कोर ऑफ 2. साथ में एंटी स्मिथ एंटीबॉडी है, गिव ए स्कोर ऑफ 6. कीप ऑन एडिंग. इफ द टोटल स्कोर is equal to or more than 10, it is sufficient to make a diagnosis of SLE. These criteria need not occur simultaneously, they can come one after the other. तो कम से कम एक clinical criteria, 10 points, and total score, the patient is having SLE. I repeat, listen to me carefully. SLE के लिए criteria क्या करते हैं? ANA करते हैं. कितना? 1:80 and more. अगर है तो आगे चलो. आगे चलेंगे, क्लिनिकल एंड एंटीबॉडीज दोनों चेक करेंगे. जो जो प्रेजेंट है उसको टिक करेंगे, फिर टोटल स्कोर निकालेंगे. इफ द टोटल स्कोर इज इक्वल टू और मोर देन 10, और कम से कम एक क्लिनिकल होना चाहिए, ऐसा नहीं कि सिर्फ एएनए से डायग्नोसिस बना दिया, इट शुड बी क्लिनिकल, यू मेक द डायग्नोसिस ऑफ एसएलई. need not occur simultaneously. Suppose there is a patient who says एलोपेशिया पिछले साल हुआ था, अभी उसको अनीमिया हो रहा है, तो दोनों को क्राइटेरिया को कंसिडर करेंगे. एंड इफ द टोटल स्कोर बिकम्स इक्वल टू मोर देन 10, it is SLE. The only thing important is ANA should be positive. कितना? 1:80 and more in the patient. Right? This is ULAR ACR diagnostic criteria. So there are autoantibodies, there are one-liners, there is management and scenarios. I think it's already 11:40. Uh, it will stop here. We will continue from here only. We'll be starting the class somewhere around 3 or 3:30. Exact timing will be announced and changed appropriately in the YouTube video as well. Right? So it's been a pleasure discussing with all of you. We started the class late, and then there were two gaps of 5 minute interruption. So almost 45 minutes were lost. Otherwise, we would have finished rheumatology. So it's okay. We will continue from here only, and we will finish everything, and then we will move to the part two video. Okay, CVS CNS will come afterwards. Thank you so much. Uh, Thank you. Stay in touch, and no, I can do till 12, but the problem is there are technical team also. And if daily the classes are going till 12, that is not good. So my aim is we should finish the class tomorrow 10 if we start around 3. Okay. So there will be 2 breaks in between. So let's continue from tomorrow. Thank you so much. We are trying to cover as many MCQs as possible, as many NEET PG MCQs also, and concepts. We don't have the time, but we are forming some generalization. I hope you all like it. Thank you so much. And let's stay in touch. Let's meet tomorrow. Bye bye.